Yes.
Can you hear? So, Dr. Azmi, how do you think about this the webinar? Because endoscopy is one of the most important highlights in the neurosurgical procedure. So, how do you think?
Very relevant. Yeah, very relevant, and most of the speakers has demonstrate the benefit and all the tips and tricks. I think it will attract a lot of, especially the young generation. Now, endoscopy is like a must in addition to microscopy. You need to master. Very relevant.
Okay, thank you. Sachin, maybe if we have a time, maybe you can show us some promotion video of the May Congress if you already finish. Okay.
So is Sachin going to share the video, or I continue with the recorded webinar?
Okay.
Okay, then I'll start.
Mm-hmm.
Yeah, please start. Please start.
Good morning, and thank you for the kind invitation. It is a real pleasure for me to join you today. I have nothing to disclose. Let me give you a short self-introduction. I am Alberto Feletti. I am an Italian neurosurgeon. I was graduated at Padova University, one of the most ancient universities in the world. Great anatomists like Morgagni and Vesalio, and also Galileo Galilei used to teach in Padova. I then moved to Modena. Most of you probably don't know where Modena is. It's here. Probably many of you know about Ferrari cars, Lamborghini, Maserati, and Parmigiano cheese. Well, all these products are made in Modena. So it was a very nice stay. Time at University of California in San Francisco for a fellowship, and also at the Fujita Health University in Japan and Fudan University in Shanghai, China. I have been asked to give a message to young neurosurgeons who want to start endoscopic surgery. I think you must be first curious to explore new territories through keyhole approaches. However, you must also be wise enough to realize that minimally invasive neurosurgery does not always mean small cranial approach. You have to be perseverant. Labor omnia vincit. Work conquers everything. So use your time and your energies to study, to follow and learn from experienced surgeons. And always be empathetic, because we deal with people. Ventricular endoscopy can be performed using rigid or flexible scopes. Both have some pros and some cons, and I am convinced that we must be able to handle both instruments. In particular, it is good to know how to use a flexible scope, which is very useful to explore every corner of the CSF pathways, as you can see in this video, where we explore all ventricles, including the cerebral aqueduct here, and the fourth ventricle. Here. In my presentation, I tried to follow an anatomical order. Several procedures can be done in the lateral and anterior third ventricle. Here you can see some examples: septostomy, tumor biopsies, monoplasty, colloid cyst removal, fenestration of cystic craniopharyngiomas in selected cases, of course, ETV. All these can be performed with either a rigid or a flexible scope. However, there is a dark side in the third ventricle, which is not easy to explore, the posterior third ventricle. However, with a flexible scope, it is very easy to get there. For example, to do biopsies or even to remove tumors in selected cases, like in this patient with an ependymoma in the posterior third ventricle. We were able to completely aspirate and remove this tumor. This patient was admitted with symptoms due to the presence of a huge arachnoid cyst of the quadrigeminal system. I approached the cyst through a frontal bar hole and I fenestrated it through a suprapineal recess. We had the possibility after fenestration to explore the inside part of the cyst and to appreciate a very uncommon anatomy with the tentorium, the cerebellum up here, free margin of the tentorium, the straight sinus, the ampulla of Galen, the internal cerebral veins, the superior cerebellar veins. Let's move on with our journey throughout the CSF pathways. As you can see, many procedures can be done distal to the third ventricle. In antiquity, the Pillars of Hercules was the name given to the headlands that flank the entrance to the Strait of Gibraltar, the only connecting point between the Mediterranean Sea and the unexplored Atlantic Ocean. According to Greek mythology, the pillars were raised by Hercules, and the Renaissance tradition says the pillars bore the advice ne plus ultra, serving as a warning to sailors and navigators to go no further. Until recently, the cerebral aqueduct has been considered to be as the pillars of Hercules by neurosurgeons. Actually, crossing the aqueduct can be dangerous even using a thin, rigid endoscope because of its size and curved shape. However, with flexible scopes, it is possible to cross this limit. They nicely adapt to the complex and irregular geometry of the ventricular system, making it possible to completely explore all ventricles and to cross the pillars of Hercules of the cerebral aqueduct, which actually can be considered as the ventricle of the mesencephalon and therefore has enough compliance for such maneuver. Of course, a proper experience with simpler procedures with a flexible scope is required before attempting the navigation of the cerebral aqueduct. In this video, you can see the normal appearance of the aqueduct with the two constrictions and the ampulla in between. This young lady was admitted to our institution because of progressive consciousness impairment. The MRI showed a triventricular hydrocephalus, apparently caused by an aqueductal stenosis. However, during the endoscopic exploration, we found the aqueduct to be obstructed by a membrane, not by a real gliotic stenosis. And the membrane was perforated, restoring the physiological CSF pathway. Of course, if there is a gliotic stenosis, aqueductoplasty is not recommended and ETV must be preferred. If we move past the cerebral aqueduct, we can navigate the fourth ventricle, which has a very nice anatomy. As you can see from these pictures, you can see the roof of the fourth ventricle with choroidal plexus and cerebellum. Of course, the lateral recess with the Luschka foramen. This is the floor of the fourth ventricle. So you can see the brainstem with the facial colliculi. And if you move further, you can see also striae medullaris and the calamus scriptorius. But you can also perform surgeries. For example, in some cases, it is possible to fenestrate cysts in the posterior fossa, like in this patient who presented with symptoms due to a growing arachnoid cyst in the cisterna magna. We approached the cyst through a simple frontal bar hole and navigation of the cerebral aqueduct, carefully advancing the scope in the narrow space between the brainstem and the compressed roof of the fourth ventricle. And finally, we reached, see the pica here, we reached cyst. I always look through the wall of the cyst just to make sure that nothing is behind before attempting the fenestration. We did the fenestration. I also shrinked the wall of the cyst using monopolar coagulation. And at the end, the cisterna magna is completely patent and free. The two picas are clear. And withdrawing the scope, we could notice the clear decompression of the fourth ventricle without any damage to the cerebral aqueduct. Interestingly, in some patients with tetraventricular hydrocephalus, it is possible to have the definitive diagnosis, just exploring the fourth ventricle, where the outlets might be obstructed, like in this patient. You can see the exploration of the fourth ventricle. This is the roof of the fourth ventricle, and we are directing the scope to the lateral recess, and you can see the Luschka foramen is obstructed by a membrane. Of course, the treatment in these cases is ETV, but in selected cases, when third ventriculostomy is deemed too hazardous, it is possible to perforate membranes occluding the outlets of the fourth ventricle, like we did in this patient, because the basilar artery was very high in the interpeduncular cistern, and the brainstem was pushed against the clivus by the enlarged fourth ventricle. In such cases, we now use intravenous fluorescein sodium injection, which allows us to detect the ependymal, small, tiny vessels, and also those eventually crossing the membranes we want to fenestrate. Another interesting application of sodium fluorescein is when we want to perform a biopsy, especially in those tumors which don't have exophytic parts. It is possible also to highlight areas without brain-blood barrier, of course, choroid plexus, but also some circumventricular organs, like the median eminence on the floor of the third ventricle, not visible with normal light, but visible, clearly visible with fluorescein sodium, and also the organum vasculosum laminae terminalis. If we move the scope into the fourth ventricle, it is possible with fluorescein sodium to highlight the area postrema in the calamus scriptorius. This is the opening of the central canal. So the area where we perform third ventriculostomy actually has a function, oppositely to what we were always told. Nowadays, we try to spare as much as possible the median eminence when we perform an ETV. We showed different shapes, great variation of shape of the median eminence and also of the area postrema in different patients. Wilson, professor at the University of Sydney 1 century ago said, when one turns to the standard textbooks in search of the precise manner in which the central canal of the medulla oblongata actually expands into the cavity of the fourth ventricle, only vague and general statements are for the most part met with. Actually, this is true also nowadays. This tiny hole, the opening of the central canal in the fourth ventricle, is very difficult to see, even in cases of microsurgical exploration of the posterior fossa. But with the flexible endoscope, it is possible to have a clear vision of the calamus scriptorius and also of this tiny structure. Another interesting and useful application of transaqueductal endoscopic navigation is evident in cases of tetraventricular hemorrhage. You all know that this condition carries a very high mortality rate, up to 80% in some series. We know that IVH is an independent prognostic factor of poor outcome. And in case of intracerebral hemorrhage, IVH increases the risk of death in a significant way. We know that in case of subarachnoid hemorrhage, more than 20 milliliters IVH can be lethal. So there is a need to get rid of blood in the ventricles as faster as possible, because IVH not only gives increased intracranial hypertension and hydrocephalus, but also chemical damage, and it triggers an inflammatory response and also a direct mass effect with the reduced cerebral blood flow has been demonstrated. There are different ways to manage this kind of patients. There are some minimally invasive and some really invasive techniques. Probably the most common procedure is EVD. EVD is a simple procedure and it allows a fast resolution of acute hydrocephalus. However, it often has to be bilateral because it frequently obstructs, and we have to wait a long time before we can actually see blood to be washed out. So this has consequences: longer hospital stay and increased risk of complications. Fibrinolytic therapy can help to speed up the process, but still we have to wait days to see results. And moreover, there are some publications showing that fibrinolytic therapy does not substantially improve functional outcome in these patients. I will not talk about craniotomy for IVH because I really think this is too much invasive. But if we think about the fact that hemorrhagic fourth ventricular dilation is the most significant outcome predictor in this condition, as published by these and other groups, we understand the need to remove blood clots very fast from the ventricles, especially from the fourth ventricle. And the only way to do this fast is by endoscopy. As you can see, you can get rid of blood even from the third and the fourth ventricle. We have showed that in this way we can not only decrease the blood amount in the ventricles, but we can also decrease mortality and decrease VP shunt dependency. Also, it is possible to have an increase of good outcome in our patients. In this study, patients were divided into two groups. Group A treated with endoscopy, Group B treated with EVD alone. And the difference between the two groups in terms of shunt dependency was statistically significant. With endoscopy, we can have a lower risk of VP shunt dependency, as it was shown also by other groups and by this meta-analysis. How to do this kind of surgery? We use the operative channel of the flexible scope as a sucker. Instrumentation is very simple: a peel away to cannulate the ventricle and a syringe to do aspirations and irrigations. The access point is very crucial, it must be not too lateral. I would say about 1.5 centimeters from the midline. And you have to use irrigation maneuvers to unveil anatomical landmarks and aspiration maneuvers to remove blood clots. These are the different phases of the procedure, starting from the lateral to the third and fourth ventricles. Initially, this kind of surgery can be very frustrating because you can see only red due to blood clots, but just do aspiration and irrigation with the external syringe and you will find the first landmarks. For example, the border between the clots and ependyma. When you see the white ependyma, of course, you must stop doing aspiration. This is the interface between clots and ependyma. And finally, you can see the choroid plexus, which is a very important landmark. You can follow it backwards to clear the occipital horn, but most importantly, you can follow it forwards to the Monroe foramen, and you can do aspiration from the Monroe foramen and from the anterior part of the third ventricle and unveil the mammillary bodies, the tuber cinereum, and also the infundibulum, the optic chiasm, and the lamina terminalis. If you bend the tip of the scope in the third ventricle to the posterior part of the third ventricle and you do the same maneuvers, you can unveil the additum of the cerebral aqueduct, the posterior commissure, the abendular commissure, the pineal recess. You can have also a clear vision of the roof of the third ventricle, and then you can navigate the aqueduct, which is also obstructed by clots that can be aspirated. Here we are entering the fourth ventricle, and if you keep doing the same maneuvers, you can unveil the floor of the fourth ventricle and also the roof down to the lateral recess, foramen of Luschka, and the foramen of Magendie down here. This is the inferior triangle of the fourth ventricle. You can see we can obtain very nice results in these patients with the complete resolution of hydrocephalus and obstruction. You can use this technique also in cases of IVH due to ruptured aneurysms. In some cases, we do coiling, like in this small pericallosal artery aneurysm, and then immediately after coiling, we do endoscopy and we can get rid of blood from the ventricles. Also in this case of basilar artery aneurysm, which was coiled, and then you can see immediate decompression of the posterior fossa with endoscopy. Similarly, with aneurysms that are clipped, I clipped this left MCA and ruptured aneurysm, and immediately after I did endoscopy, you can see the blood is completely disappeared. With this technique, although the initial status, clinical status of the patients is really bad, we can obtain sometimes good outcomes. If we move to the spinal cord, we can also use the flexible scope. For example, in cases of empyema, epidural empyema. In this case, I removed the empyema through a small laminotomy with the same technique used with IVH. Or you can also explore huge syringes like this, just to make sure that all parts of the syringe are communicating one between the other. And in case you can do some fenestrations. Of course, there are some limits of flexible endoscopy. There is a suboptimal vision because It's based on fiber optics. However, nowadays there are new instruments with a chip on the tip providing perfect vision. Unfortunately, in the European Union, they are not validated yet. There is a limited number of instruments for flexible endoscopy, and the working channel size is limited too. Some people say that another limit is the absence of visual control of proximal portion of the scope, but this is not a limit because the scope is flexible and it perfectly adapts to the complex and irregular geometry of the ventricular system. I am convinced that there are very exciting future perspectives in this field. Thank you very much for your attention.
Dear Chairman, dear colleague, today it is truly my honor to be here and share with you our experiences for the pure ventriculoscopic resection of intraventricular solid lesions through a single burr hole. I'm Dr. Chen from Chinese PRA General Hospital. As we know, the intraventricular tumor or intraventricular lesions are deep-seated and usually intimate to the eloquent surrounding structures. So it makes the resection of the intraventricular lesions very challenging. Usually the neurosurgical resection for the intraventricular tumor or lesions is associated with a significantly higher early complication rate. So we used to modify our traditional craniotomy surgery method to the endoscopic port surgery for the intraventricular lesion resection. With this method, we can use this port with a diameter of 1.6 centimeter to access the ventricle and resect the lesion. However, although in this method with the endoscopic port surgery, you can use a small bone flap, which has a diameter of 2.3 centimeter to access the ventricle and do the resection of the intraventricular lesions or tumors. We still are thinking that is it possible for us to further modify or further improve this method with even a small single burr hole. So is it possible? We have this hypothesis that the pure ventriculoscopic resection of the intraventricular solid lesions through a single burr hole is possible with proper technique and technology and proper instruments. So we conducted this study. So our first try is at June 2012. That's a 13-year-old male suffered from headache. And we can see the ventricle, lateral ventricle, is significantly enlarged. And please notice that there's a small lesion located in the trigon area at the left side in the lateral ventricle. And the small lesion is very close to the choroidal plexus at that place. And for 3D space super high resolution MRI sequence, we can see that there's a small obstruction located in the aqueduct. So the patient now is confirmed to have obstructive hydrocephalus, as well as a small lesion located in the trigon area of the left lateral ventricle. So if we use this virtual endoscopy to simulate the situation in the lateral ventricle, we can see this is the trigon area on the left side, and you can see there's a small bulge, a small lesion located from the left choroidal plexus with a very narrow stalk. So we decided to do the pure ventriculoscopic surgery for this patient. Our purpose are as follows. First, we need to do the ETV to relieve the obstructive hydrocephalus. And then, if possible, we will do the aqueductoplasty with a flexible scope and to explore the fourth ventricle. And finally, we will get to this small lesion. So now you see, this is the floor of the third ventricle. And we use a special basket perforator to do the ETV, to do the endoscopic third ventricular ostomy. With this basket perforator, we can have a very satisfactory for the expansion of the fenestration on the third ventricle floor and to expand it. And another advantage with this basket perforator is the basket perforator can be used repeatedly. So in this way, we avoid this expensive single-use balloon catheter. And now we use a flexible scope to explore the aqueduct. You can see the aqueduct is obstructed with a membrane here. So you cannot see the fourth ventricle clearly. So now we forward this flexoscope to do the aqueductoplasty. And now we have completely perforated the obstruction, and we forwarded our flexoscope into the fourth ventricle. So this is inside the fourth ventricle. This is a foramen of Marchanti, and we can still see we can see that there's still membrane obstructed or partially obstructed the foramen of Marchanti. So we use a flexoscope to do the plasty of the foramen of Marchanti again. Okay, now it's better. It's much better. Okay, we have now completely perforated the foramen of Marchanti. Okay. So now we are satisfied that we have already got a ETV. We got a patent aqueduct, and we also got confirmed the patency of the foramen of Marchanti of the fourth ventricle. Okay, now next step, we need to withdraw the flexoscope, and we need to convert it into the rigid scope to do the lesion resection. So before withdrawal of the flexoscope, we confirmed that it's a dorsal, just now here, is a dorsal bundle of the C1 root. C1 root. This is a C1. This is C1 root on the left side. So with a flexoscope, we can forward the lens to the C1 or C2 level. Okay, we have already completely confirmed the patency from the lateral ventricle, third ventricle, aqueduct, and fourth ventricle, and to the spinal cord. This is a foramen of Luschka. This is a foramen of Luschka. You can see the membrane partially blocking the foramen of Luschka. However, here we tried to do the fenestration. Yes, now we successfully perforated the membrane blocking the foramen of Luschka. Okay, now we are withdrawing our flexoscope. You see the aqueduct is the shape and the size is much better than before the surgery, right? So now next step we need to convert it into a rigid scope to do the lesion resection. So the lesion is difficult to access and to resect because for the usual ventricular scope, we have only one usable instrument through the instrument channel, right? So when we try to do the tumor resection or partial biopsy with a biopsy forceps or a punch, the lesion is shifting, so it's very difficult to fix it. So we first use a microbipolar forceps to coagulate the stalk of the lesion to stop the blood supply to do the hemostasis. Okay, now the tumor stalk has already been completely coagulated. So next step, we will use the dual instrument manipulation to do the resection of the lesion, which is we will insert our basket perforator from the irrigation channel of the ventricular scope, and so that we can use the basket perforator to fix the tumor. And then we will insert a scissor from the instrument channel of the ventricular scope so that we can resect or try to cut the stalk of the lesion. So in this way, we can use two instruments through a single ventricular scope and to do the lesion resection. So now you can see the basket perforator has already fixed the tumor, and then a scissor was inserted through the instrument channel and to do the cut, to do the resection of the tumor. So in this way, because the stalk has already been coagulated, so it is very easy to do the resection and very safe. Okay, now we can use the basket perforator to retrieve the tumor gradually, but now it cannot pass through the irrigation channel. So we need to retrieve the lens as well as the tumor from the sheath. Now we are taking out the tumor. So in this way, the tumor was completely resected, and the schedule, the procedure was very easy. So this is a photo of the tumor. You can see the tumor is, the diameter of the tumor is 5 millimeters. The postoperative histological diagnosis confirmed that the tumor is meningioma. So these are the 5-year follow-up images of the patient. We can see the hydrocephalus has already been completely relieved with a patent ETV fenestration fistula, and the patient got no symptoms and no neurological deficit. And there's also no recurrence of the tumor. So after that first trial, we do believe that the pure ventriculoscopic resection of the intraventricular lesion through a single burr hole is technically feasible. So we furthered our study. So this is another case. This is a recent study. This is a 50-year-old male, right-handed male, and the patient suffered from a headache for 1 month. And the MRI image confirms there's a solid lesion, small lesion located in the left ventricle. You can see the lesion cannot be enhanced. There's no enhancement. So correlates with considering the location of the lesion and no enhancement, the possible diagnosis can be a ependymoma, subependymoma of the ventricle. So for this kind of tumor, because the blood supply is very poor, so we are confident that we can do the resection with pure ventriculoscopic resection. So this is a virtual endoscopy simulation of the tumor. You can see this is the ventricle. This is tumor. So all we need to do is to insert a ventriculoscope inside the lateral ventricle and resect the base of the tumor. And we usually use a contact laser to do the resection and the debulking of the tumor. So the patient positioning is like this. And because the patient is almost half bald, so we designed our incision like this at the edge of the hairline. So with a single bore hole and also contact laser, this is a picture of the contact laser fiber. Because the fiber can be flexible and can pass through the instrument channel of the ventriculoscope. So we think that we feel that the contact laser is a very good companion instrument for the pure ventriculoscopic resection of the intraventricular solid lesions. So here's a video of the surgery. You can see after insertion of the ventricle scope into the lateral ventricle on the left side, we can see the tumor here. There's quite a big lesion, right? With under the ventriculoscopic view. So now we use contact laser fiber to do the resection along the base of the tumor. So just step by step, because the blood supply of the lesion is very poor, so no problem, we can safely and easily resect the tumor from the base, so that we can remove the tumor in an in-block way. So you see, we just resect the tumor and cut at the base with a laser. So finally, the tumor, the lesion, was successfully resected in an en-bloc way. And you can see the diameter of the lesion is about 1.5 centimeter. And the incision was sutured with a metal clip. So the patient's post-operative course was uneventful and no neurological deficit was found. The histological diagnosis confirmed that the lesion is subependymoma. So these are the post-operative MRI images. You can see the post-operative image confirmed that the lesion has already been completely removed. The post-operative MRI and the virtual endoscopic simulation confirmed the total resection of the lesion. Here's the next case is more challenging. You can see this case, this patient suffered from a lesion located at the midbrain or the aqueduct. And the lesion has a low intensity ring around it, indicated that the lesion may be a cavernous malformation. So the patient was found to have this problem 15 years ago. But because the removal, the surgery for this CM, for this cavernous malformation at this place is very risky and challenging. So no one dared to do the craniotomy and surgery for him. So the doctors suggested him to do the radiation therapy instead 15 years ago. However, unfortunately, after the radiation therapy, the lesion is still there. There's virtually no effect on this lesion. So now the patient is suffering from aggravating movement mobility of the eye and from double vision. So he come to us. So we decided to do the ventricular scope plus video scope plus contact laser surgery for him. Try to achieve the following goals. The first is ETV. We need to do something to relieve the hydrocephalus. The second is try to resect the aqueduct CN cavernous malformation through the single burr hole from the frontal part of the skull. So the patient positioning and the incision are like this. So the patient is in a supine position with a flex of the neck, and the incision is a linear incision with a length of the 3 centimeter. So from a single burr hole, we first insert the rigid ventricular scope into the ventricle and do the ETV to do the endoscopic cervical ostomy to relieve the hydrocephalus. Then we use a flexible video scope to do the resection of the cavernous malformation located at the aqueduct. So these are the images we acquired from the video scope. You can see clearly this mulberry-like lesion located in the aqueduct is a cavernous malformation. Then we use the contact laser through the instrument channel of the video scope to do the resection of the cavernous malformation. You see, it's partially removed, and then we try to remove this, and finally we got a total removal of the cavernous malformation. And after the removal of the CN, the aqueduct was opened. So now aqueduct was opened, and we use a flexoscope to do the aqueductoplasty. And this is after we inserted our video scope into the fourth ventricle, we observed the patency of the foramen of Marchanti from the fourth ventricle. So in this way, we achieved our strategic goal, which is first to relieve the hydrocephalus, second to totally remove the CN located at aqueduct. So these are the videos of after the total resection of the cavernous malformation, and also as well as aqueduct plasty. This is the opening of the aqueduct. So after the surgery, the postoperative course of the patient was uneventful, and no neurological deficit was found. And from the postoperative control MRI, you can see the ETV is still patent, and also the lesion was totally removed, and the aqueduct was also patent. So this is a comparison between the preoperative MRI and the postoperative MRI. You can see preoperative lesion is here, and postoperatively the lesion is gone. It's completely removed. And the patient got no problem with eye movement, and the double vision disappeared and completely relieved. So in this way, we finished, or we conquered this challenging lesion, or resected this challenging lesion with a very, very minimally invasive way. So the results are as follows. From June 2012 to May 2021, totally there were 29 cases enrolled in our study, including CN for 11 cases, 8 cases of the subependymoma, and 5 cases of the small meningioma, 2 cases of the low-grade glioma, 1 case of the neurofibroma, and 1 case of the pseudoaneurysm, and 1 case of the granuloma. So for 93% of the cases, which is 27 cases, gross total resection was achieved. And for 2 cases, subtotal resection was achieved. So no hydrocephalus, no shunt is needed, and no long-term complications was found in this study. So for discussion, we think that because the intraventricular lesions are usually deep-seated and they are usually risky, and the surgery to resect the intraventricular lesions are usually challenging. So for craniotomy, traditional craniotomy, we need a bone flap with a diameter maybe 5 to 6 centimeter, which is quite big. And then later on, we evolved this method to our endoscopic port surgery. It's less invasive if we compare to the traditional craniotomy, but still the bone flap is about, the diameter of the bone flap is still about 2 centimeter to 2.5 centimeters. So for selected cases, we think that the latest single burr hole ventriculoscopic surgery is technically feasible. It's minimally invasive, and with a burr hole with a diameter of only 8 millimeter, which is 0.8 centimeter. So the major technical issues and the solutions of our single burr hole pure ventriculoscopic technique are as follows. The major issue, technical issue, comes from the small burr hole. We need to retrieve, or we need to resect a bigger lesion through a small burr hole. So we need some effective debulking method. In this way, the traditional bipolar coagulation as well as scissors are not efficient enough. So we think and we believe that the contact laser is a very effective way for debulking, because when you use the contact laser to do the debulking, usually the coagulation of the cutting edge of the lesion is completely finished while you are doing the cutting. So it is very highly effective. And the case selection is very important. We strongly suggest that for a lesion with a diameter smaller than 2 centimeter, you can consider this pure ventriculoscopic technique. For a bigger lesion with a diameter bigger than 2 centimeters, you can consider our endoscopic port surgery. And for ventriculoscopic surgery, one major technical issue is coming from the single instrument. So we need to either improve the instrument or either use dual instrument manipulation. So for single instrument, we strongly recommend to use a contact laser, because the contact laser can take the place of 2 instruments at least, which is bipolar coagulation as well as scissors. So that's 2 instruments converted into one single instrument. If a contact laser is not possible, or sometimes we do need to do the resection with 2 instruments, like the first case with a very small stalk meningioma, we need to fix the lesion and then to do the resection. In that way, we need something like basket perforator, this kind of instrument which can hold or fix the lesion so that we can insert the second lesion from the instrument channel and to do the resection. So our conclusion are as follows. First, the pure ventriculoscopic resection of the intraventricular lesions, solid lesions, through a single burr hole is technically feasible. Our experiences in the past years has already confirmed it, but we need to do that in selected cases. And so minimally, the feature of this method or technique is the minimally injury to the surrounding brain tissue along the trajectory. So the indications are small lesions with a small stalk or narrow stalk, and as well as enlargement of the lateral ventricles and the benign lesions. We do not recommend you to do this manipulation for a malignant lesion, because usually for the intraventricular malignant lesions, they have very wide base, so which will make the debulking and the resection very difficult. So the contact laser and the basket perforator are essential for this technique. And the final part, the final conclusion is still controversial, that we are thinking that is it possible for this technique to induce some further evolution of the surgical indications for such small case in the lateral ventricle. Because, for example, for the small case, traditionally maybe we will suggest to the patient to have the radiation therapy, or just the follow-up. But with this minimally invasive way, is that possible that the early stage intervention can be done with this minimally invasive technique to avoid the further enlargement or further growing of the tumor? So we also want to discuss this with our colleagues. So finally, thank you very much for giving me the opportunity to present our study here. And everyone, you are welcomed to visit us in Beijing in the Chinese PRA General Hospital. Thank you.
I'm Dr. Rohidas, neurosurgeon from Kolhapur, India. And this is a lecture on endoscopic cervical spine surgery approaches for conference Pure Endoscopic Neurosurgery WEB Summit 2022. This is the basic principle which I follow since my open surgery days. It really does not matter what technique you use to decompress the nerve root. If you fail to fully decompress the nerve root or introduce complications to the equation, you have failed to serve the patient. So the technique should have nice equilibrium between adequate neural decompression with preservation of the stability. Error on either side will add complications. Now, for the cervical spine, this is a C5-6 disc herniation on the right side. For this disc herniation, which is compressing the root, we compromise the whole disc by doing dystectomy, grafts, fixation, and everything. This is pre-op and this is post-op. This is pre-op axial, this is post-op axial. We have gone through the unconvertible joint and we have preserved the rest of the disc. These are, when we use endoscope, these are the disc preserving, motion segment preserving surgeries. This is a disc herniation causing cord compression at C5-6. This is post-op, and this is the amount of the disc which we have removed. This is the technique we used to do in 2005. It's a percutaneous endoscopic cervical dystectomy, PECD. Now the goal of the procedure is to decompress this nerve root by percutaneous removal of the herniated mass and shrinkage of the nucleus pulposus under local anesthesia. The indications were soft cervical disc contained by PLL. I used to use neuroendoscope for this procedure. This is the neuroendoscope. It's supine position under local anesthesia because communication between the surgeon and the patient is necessary during the procedure. It's a safety measure. If the procedure aggravates the spinal cord compression, patient can recognize and comment on the development of extremity weakness only under local anesthesia. So it's compulsory that this procedure should be done under local anesthesia. Initially, we pass the needle. Surgeon gently pushes the trachea and larynx towards the opposite side with index finger and middle finger, and then applies firm pressure in the disc space between the muscle and trachea. It's between the vascular bundle and visceral bundle. Then we pass dilators over that needle and we do a manual dystectomy. This is the procedure under fluoroscopic guidance and endoscopic guidance. There is continuous irrigation which is going on. This was the time I used to use single chip camera. When this herniated disc is removed, patient feels that there is no radicular pain, and that is the end point. This procedure is done for a left-sided herniation. We have to go from the right side, diagonally opposite. These are the results. I did only 11 cases, and these are the results. All patients had complete recovery in neck pain, radicular pain, and paresthesia. 2 patients with minor radiculopathy, they had gradual improvement in 2 months in cord signs over 2 months period. Amount of the disc removed was 0.5 to 1.2 grams. 1 patient has hoarseness of voice. That was the 3-level surgery, partially recovered in 2 months. Afterwards, I stopped this procedure because there was continuous radiation to the surgeon, because the surgeon used to stand in front of the X-ray tube. This is the incision of PECD as compared to the open surgery. Next, I started with anterior cervical approach. It's a transcervical approach. I use distendu technique, supine position, localization of the disc spaces with the C-arm and cervical localizing pin, and incision is something around 2 to 4 centimeter, 2/3 medial and 1/3 lateral to the sternocleidomastoid. This is the approach: medial to the vertebral artery, through the unconvertible joint, diagonally down towards the root. If you keep in mind this figure, next videos, you will be able to appreciate more that I am diagonally down towards the root or cord. This is the cadaver picture, vertebral artery. This is the nerve root which is compressed due to the herniated disc. We go diagonally down and decompress the root from vertebral artery to the dural sac. For a cord decompression, we go diagonally on the opposite side and decompress the cord. This is cadaver picture. This is the localizing pin which we use for exact localization and entry point for the cervical region. Localization pin is used like this way, and we get the direction of the disc space and the entry point here. After opening, going through the visceral and vascular bundle, we push a spinal needle and reconfirm the level before starting it. This is the spinal needle through outer tube of the endospine to reconfirm the level. This is the distandus endospine, outer tube, inner tube, and two clawed retractors to retract the vascular bundle and visceral bundle. And with the drill, we start with the bone work. Here you can appreciate this is the entry point and the direction to approach the disc. Uncovertable joint, we start with the foraminotomy like this. This was the first case which I did in 2006. Medial to the vertebral artery, this is the foraminotomy, and we remove the soft disc herniation medial to the vertebral artery. Rest of the disc is preserved. This is how we follow the disc. From both the sides. This is cranial caudal and this is the disc base. We diagonally go with an angle of 20 degrees medially. Once we are near the vertebral artery, I use this ultrasonic bone dissector for safe removal of the bone medial to the vertebral artery. This will preserve the soft tissue like vertebral artery and nerve tissue. It will not act on the soft tissues. This is medial to the vertebral artery. This is the suction, which is 4 mm diameter, and you will be able to realize the foraminatomy is something around 10 millimeters by 6 millimeters. This is a 2 mm Kerrison punch. Then with the curette, we remove the extruded part of the disc, compressing the nerve root. This is the dural sac. Nerve root is underneath my suction. This stand use technique is a mobile endoscopic technique. This is the final dissection. Dural sac, this is the nerve root, vertebral artery, medial border of the vertebral artery. This procedure can be used for a single level cord compression. This is a calcified OPLL. At C56, we approach from the right side and remove this calcified part of the OPLL.
Yes, please.
This is the cord which is completely decompressed, and this is the calcified OPLL. This is the incision as compared to the open surgery. This is one more case of a calcified OPLL. This orientation here is, this is cranial, this is caudal, and we are starting from one side. This is cranial caudal, this is the disc which we are following, and this is after the complete decompression of the cord from one lateral end to the other lateral end. I did around 78 cases with this technique, This is the clinical. Around 21 myeloradiculopathies, and rest of them were discs. This is the clinical. I had excellent result in 76 patients. Two patients had very poor results because that was a severely compressed cord with myelopathy, severe myelopathy. I had one dural puncture, one pseudoaneurysm, two Horner syndromes which recovered subsequently, and two laryngeal neuropraxia. Another approach which can be used in cervical is the posterior endoscopic cervical with the endospine. This can be used for dystectomy and canal decompression. Indications are unilateral disc herniation, single or two contiguous levels. Useful for removal of foraminal, posterior acute soft disc, foraminal stenosis, bony spurs, and facet hypertrophy. Contraindication is spinal instability. This is the schematic diagram. Do a laminoforaminotomy, decompress the root, and remove the disc. This is a disc at C71 on the left side. This is the approach, laminoforaminotomy. Disc in the axilla. This is left side, so this is cranial, caudal, medial, and lateral. Disc in the axilla. Extruded disc in the axilla. And we can do a canal decompression by diagonally going to the opposite side, undercutting the opposite lamina and decompressing the cord if it is necessary. This is the incision. We can use Kerrison punch. Always protect the dural tube with the cottonoid. We can use a true cut punch to remove the flavum in the cervical region because you cannot pull the flavum. Epidural oozing is one of the important things we have to prevent. Now this is C3 to C7 laminectomy on one side and canal decompression on the opposite side. Through one incision, I have decompressed C2, 3 and cranial part of C4. Complete cord you are able to see which is decompressed. And this is upper part of C4, 5 and C6, 7. Here we have preserved the lamina of the opposite side. We have only undercut it. Opposite muscle attachment to the lamina and facet is intact. We can use this ultrasonic bone dissector to undercut the lamina on the opposite side. You can see this is the bone dust. I am at C3 level. From one side to opposite side, I am still protecting the cord with the cottonoid. Whichever technique it is, it's always better to protect the neural structures. Total number of cases, I have done around 46. This is the age distribution. Levels, most common are C5, 6, 6, 7, 10. This is the clinical. 15 patients with radiculopathy and myeloradiculopathy. I had excellent result in 39 cases, good in 5, fair in 2. I had one dural puncture. Those cases where the cord was damaged and there were permanent changes in the cord, they had good results. Mobilized same day, active physiotherapy after a week. This cervical approach with the endospine can be used for a cervical tumor also. This is a cervical intradural extramedullary tumor. This is the incision. And this is post-op after 4 hours. No catheter, no drain. This was at C56 on the on the left side. This is the beauty of the endoscopic approaches. The trauma is minimal. Patients are mobilized quite immediately after the surgery. No catheter, no drain. So the art of medicine is amusing the patient until the nature cures the disease. So minimalism means we try to target what is the culprit, what is the point where the nerve is compressed, target that much only, rest nature will take care of. Thank you.
Hello everybody, I'm Kenichi Oyama from International University of Health and Welfare Mita Hospital in Tokyo, Japan. It's my great honor to make a presentation in this seminar. First of all, I'd like to introduce my university. International University of Health and Welfare has 6 campuses all over Japan, and the medical school is located in Chiba Prefecture near the Narita International Airport. In our medical school, many international students are studying to get the medical license in Japan. Actually, they are very smart and hardworking students, so we are sure they'll be great doctors in the near future. Our hospital is one of the branch hospitals of IUHW. It is located in the center of Tokyo, very close to the Tokyo Tower. So, when the COVID pandemic settles down, please visit our hospital and enjoy the surgical theater as well as the beautiful scenery and good Japanese cuisine. Today, I'm going to talk about the basics of our endoscopic endonasal approach, and then, due to the time limitation, I'm just focusing on the sagittal plane modules of the endoscopic endonasal approach. The concept of endoscopic endonasal approach was mainly established by Professor Kassan in the early 2000s. He is one of my great mentor and great friend. Actually, many years ago, it was a cutting-edge technique for the skull base. But nowadays, it's been a standard and widely used technique for the ventral skull base lesions. This is the endoscope we are using. This endoscope is integrated with the pneumatic arm, so we can freely mobilize and fix the endoscope during the operation. For most of the theral lesions, we usually perform a unilateral approach by a single nostril, and perform extended approach by both nares for the other complex paratheral lesions. This is a view of the nasal phase of paraseptal approach using the right nostril. Most of the nasal anatomy can be preserved using this approach. I'm going to show you this short video of the nasal phase. I'm now lateralizing the middle turbinate. You can see the natural ostium there. Then lateralizing the inferior turbinate. We usually cut the nasal mucosa vertically just in front of the tip of the middle turbinate to preserve the olfactory mucosa. Then dissect between the mucosa and the bone to get to the rostrum of the sphenoid sinus. This picture shows you the post-operative condition of the nasal mucosa after 16 months, you can realize the good healing of the nasoseptal mucosa, as well as the good preservation of normal nasal anatomy. After getting in the sphenoid sinus, you can see those bony surgical landmarks there. Using those landmarks, you have to imagine the important vital structures behind the bone. I'm going to show you one of the typical transfer approach. This is a case of pituitary apoplexy suddenly developed with visual disturbance, third nerve palsy, and pituitary dysfunction. The tumor had a hard consistency, so we cut the tumor capsule using the knife and then perform the internal debulking of the tumor. Such kind of tumor, we can find the border between the normal gland and the tumor and then dissect extracapsularly to remove the tumor completely. Finally, we could completely remove the tumor, and this is the final view. For the complex parallel lesions, we prefer to perform extended approach via both nails. For endoscopic endonasal approach, we can choose two approaches depending on the lesions. Paraseptal approach is more simple and less invasive approach than an extended approach, preserving normal anatomy in the nose. On the contrary, for the extended approach, we need to open up paranasal sinuses to create a wider corridor for treating complex skull-base regions. I'll show you some cases from now on. The yellow line connecting the anterior nasal spine and the cryptocally seems to be the anterior limit of this approach, but actually we can get to the frontal sinus via the draft 3 procedure using the angled scope. Using an angled scope and drill, we can drill the septum to get into the frontal sinus. This is a case of recurrent basal cell carcinoma. We can reach this kind of tumor from the nose. The lateral limit of this approach is an optic nerve. Using this approach, we could remove most part of the tumor, except the tumor located outside of the optic nerve. Thereafter, we perform the mini transcranial approach to completely remove the lateral tumor. Transcribriform approach is a key procedure to get to the anterior cranial base regions. To get to the anterior skull base endonasally, you have to think about the ethmoidal arteries, anterior and posterior ethmoidal artery. Those ethmoidal arteries are branches of the ophthalmic artery. In the right side, I've kept the bone intact, and in the left side, I've removed the bone over the ethmoid arteries. During this approach, you have to coagulate and cut the ethmoidal arteries to manage the bleeding from the tumor and to avoid intraorbital hematoma from the arteries. This is a case of the olfactory lobe meningioma. Firstly, we found the bony protrusion of the ethmoid artery and drill the bone over there. Then we coagulate and cut the artery to control the bleeding from the tumor. Actually, transplanum approach is one of the most popular and useful procedures of the endoscopic endonasal approach. For transplanum approach, you have to open up the posterior ethmoid to create a space for your surgical maneuver. The lateral limit of this approach is a ICA. This is a case of craniopharyngioma. Actually, this is a good candidate for the endoscopic endonasal approach because the tumor is located in the midline with a limited lateral extension. For this case, we perform the transplanum approach, and we also plan to perform a transcribal approach for the posterior part of the tumor as necessary. You can see that the tumor adhered tightly to the optic nerve, so we dissect the tumor from the optic nerve sharply. Finally, we could remove the tumor completely. Post-operative MRI showed a complete removal of the tumor, preserving the normal pituitary gland. Luckily, the visual function of the patient after the operation was also acceptable. This is a case of a huge tubercle vere meningioma. You can see that the ACA is involved in the tumor. In this case, we preserved the mucosa inside the sphenoid sinus for the reconstruction. Usually we perform with the drilling like this, and then we start to remove the tumor. After internal debulking, we dissect the tumor from the ACA and the optic nerve and the other vital structures sharply. And finally, we could perform complete removal of the tumor, in this case also. Function of the patient recovered well. Transcribal approach is really simple and straightforward to the lesion. During the transcribal approach, nasal turbinates can be preserved. The lateral limit of this approach is the ICA. The transcribal approach is really simple and reliable procedure, but there is one thing you have to manage during this procedure: the pituitary gland. You can see that the pituitary gland is located in the center of this region and just in front of the interpendicular fossa. So you have to manage the pituitary gland to get to that area. If you want to get to the interpendicular fossa via EEA, you have to mobilize the pituitary gland. Professor Kassan introduced this special technique called as the pituitary transposition. For the pituitary transposition, firstly, you have to drill the bone over the therum, planum, and clivus, and then open the dura toward the pituitary stalk. After that, you can detach the pituitary gland from the medial cavernous wall to mobilize the pituitary gland up, and then you can remove the posterior clinoid. After opening the clival dura, you can get to the interpedunclar fossa from the nose. By a transpetrosal approach, you can also get a good access to the interpedunclar fossa, but I was not sure which is better for getting to the interpedunclar fossa. So we compared those two approaches, EEA and the transpetrosal approaches, putting the water balloon tumor inside the cadaver head. The picture in the upper side shows you the surgical view of the EEA, and the picture in the lower side shows you the surgical view of the transpetrosal approach. You can realize the good visualization of the tumor using the EEA. So I think the EEA is one of the good choice for getting to the interpeduncular fossa. I'm going to show you a case of petroclival meningioma. The tumor was located in petroclival junction between the PCA and the jugular tubercle. I think there are several options for treating this tumor. Actually, the anterior transpetrosal approach is one of the good choice. Or we can choose combined ATP and retrosigmoid approach, combined petrosal approach, and combined EEA and retrosigmoid approach. In this case, we performed the EEA first because using the EEA we can reach and preserve the sixth nerve in the early phase of the operation. We perform the interdural pituitary transposition to get to that area in this case. Now I'm cutting the dura over the cavernous sinus, and then I've formed the inferior hypophyseal artery, coagulating and cut the artery using a flowable material to control the bleeding from the cavernous sinus. After that, we could remove the posterior clinoid to create a space for the surgical maneuver between the ICA and pituitary gland. Then cut the clival dura to get to the tumor. The tumor had a fibrous component, so we used the ultrasonic aspirator to perform the internal decompression. And now I'm removing the tumor in the interpeduncular fossa, dissecting the tumor from the PCA and the third nerve sharply. Finally, we could remove the tumor in this area. One of the key anatomy of the transcribal approach is a sixth nerve. It's coming from the pont-medullary junction and running superlaterally toward the Dolorous Canal. We found the sixth nerve in the pont-medullary junction firstly, and then follow the sixth nerve toward the Dolorous Canal and dissect between the nerve and the tumor. After that, we could remove the tumor safely, preserving the sixth nerve. Post-operative MRI showed a good removal of the tumor in this case. The blue line connecting the nether bone and the hard palate seemed to be the lower limit of the EEA, but actually the lower limit is a little bit higher than expected in the real clinical settings. You can get to the craniocervical junction via EEA and read the C1 and the DENS to get to the regions in this area. This is a case of craniocervical junction chordoma. We can treat such kind of tumors from the nose. This is the final slide. We describe the surgical boundaries of the EEA for ventral skull-based regions. Understanding of surgical anatomy is mandatory for treating complex skull-based regions via EEA. Less invasive and appropriate approach should be applied depending on the size, location, and type of the lesion. I'd like to say thank you to my great colleagues of IUHW and Nippon Medical School, as well as to the great collaborators in the United States and France. Thank you for your attention.
Good evening, everyone. I'm Takeo Goto from Osaka, Japan. Today, I will present our work of the endoscopic endonasal approach to all kinds of craniopharyngioma. Today, my presentation is endoscopic endonasal approach to all types of craniopharyngiomas. At first, I would like to introduce myself. Department of Neurosurgery, Osaka City University is one of the largest skull-based centers in Japan. So our old mentor, Professor Hakuba, and our mentor, Professor Ohata, started the transcranial skull-based approach. And I follow their technique. So in our early series, I resected the craniopharyngioma by the classical skull-based approach, such as interhemispheric, orbitozygomatic, or transpetrosal approach. Our surgical result of the resection of the craniopharyngioma by the transcranial approach was not bad. So we reported some paper. But basically, craniopharyngioma originate within the circle of Willows. So even choose all kind of the transcranial approach, we have to reject the tumor between the small space between the perforator from the circle of Willows. So surgical corridor was not large, and also surgical reduction not easy. But recent advancement of the endoscopic endonasal approach dramatically changed the situation. If we access the craniopharyngioma by the transnasal approach, we can directly access within the circle of Willows. In addition, if we drill out the bilateral posterior crinoid and dorsum sella, we could entirely expose the all structure around the circle of Willows. So we can safely dissect the tumor capsule from the critical structures. So since 2014, I applied the endoscopic endonasal approach to all types of the craniopharyngioma, including the retrochiasmatic type, and also to the intra-third ventricular type. After wide drilling and bony structure, and then mobilize the pituitary gland, we access the regions. Since 2014, I rejected 59 cases of the craniopharyngioma. Some is a recurrent tumor, or some tumor has a very large calcification, but I applied the endoscopic endonasal approach. I will show our case. This 60-year-old female referred to us with a chief complaint of dementia. Tumor occupied in the third ventricle. So I used to reject by the interhemispheric approach 10 years ago, but recently I applied the endoscopic endonasal approach to this region. I will show our surgical video. At first, I widely drill out the bony structure around the sella floor. And then I start to drill out the bilateral posterior crinoid and the dorsum sella. Meticulously, I drill out and remove the posterior crinoid process on both sides like this. And then I cut the dura mater along the tuberculum sella and sella floor. This is the pituitary gland, and this is the dura mater behind the dorsum sella. I meticulously mobilize the pituitary gland to the left side, and I cut the dura mater. Then I expose the tumor. Using this approach, we can directly observe the border between the pituitary stalk and the gland, and I carefully follow the margin. This is the optic chiasm. I carefully dissect. Now we are completely within the circle of Willows, so we could perform the meticulous dissection from the critical structure. Finally, we resected out all tumor like this. In this case, we could anatomically preserve the pituitary gland and stalk like this. And this is a PCOM. Postoperatively, all tumor was successfully resected out, and the stalk and the pituitary gland was anatomically preserved. But unfortunately, we could not preserve the anterior pituitary function, but we could preserve the posterior pituitary function. This is another case of the retrochiasmatic craniopharyngioma, showing the visual disturbance. I apply the same technique. After the wide drilling out the bony structure, I cut the dura mater along the sella floor and the tuberculum sella. And then I gently elevate the dura mater around the cella floor and expose the posterior crinoid process on both sides. And then I meticulously dissect the pituitary gland from the medial wall of cavernous sinus. And then I cut the dura mater behind the dorsum cella. Now we can get very clear and wide view around the pituitary stalk. This is a pituitary stalk I could dissect. And this is a perforator from the PCOM. Using this approach, we can safely follow the border of the tumor and could preserve the critical structure. This is a pituitary stalk and optic chiasm. And now I gently dissect the tumor from the floor of third ventricle. After the resection of the tumor, we have to watertightly seal the dural defect. This is our strategy, how to close the dural defect. At first, I put some suture to the dura mater. Of course, watertight closure was very difficult, but we put several sutures to the dura mater to put the tension to dura mater. To make the knot to the deep side, we usually use a sliding knot technique. Like this, we suture and then slide in the knot to the deep side like this. It's very easy and convenient procedure. After the several suture, we insert the fat tissue or duragen to the subdural layer. And then now, dural defect completely watertightly sealed. And then I cover the large mucosal flap and fix the flap using the gel foam, like this. This procedure was very effective to prevent the CSF leakage. Postoperatively, all tumor was successfully preserved and the dural defect was successfully sealed. Patient not shows the CSF leakage. In addition, we could preserve the pituitary function in this case. This is another case of the very large calcified intra-third ventricular craniopharyngioma. Previous doctor put the VP shunt and followed the patient for several years, but unfortunately, calcified part and cystic part increased in size, and this tumor caused some symptoms such as mild pituitary dysfunction and also mild cognitive dysfunction. So they referred the patient to us. This is a very large calcified craniopharyngioma. But to crush this calcified part, I choose the endoscopic endonasal approach with combined the bilateral posterior crinoidectomy. I will show our case. Now I cut the dura mater around the cella floor, and this is an optic nerve and chiasm. Using this procedure, we can observe the border between tumor and perforator. And then we are within the circle of Willis, so we can crush the calcified tumor by the QSA and dissect the calcified tumor from the perforator from the PCOM or ICA or basilar artery. This is a very small perforator from the PCA, but using the endoscope, we can meticulously dissect these perforators. This is the border between tumor and hypothalamus, but we could dissect. This is a tumor along the fornix. Calcified tumor strongly adhere to the or migrate to the fornix. So we have to left behind some calcification along the fornix and mammillary body to prevent the his memory function. But most part of the tumor successfully resected that. In this case, we insert the fat tissues to subdural layer and put some stitch like this. Dural defect was watertightly sealed and covers the mucosal flap. Postoperatively, most part of the tumor successfully resected out, and his cognitive function preserved and improved, but we could not preserve the pituitary function. This is another case of the recurrent craniopharyngioma with large calcification. This patient is a 3-year-old female, but we decided to choose the endoscopic endonasal approach. I will show our surgical video. At first, I widely drill out the bony structure along the cella floor, dorsum cella, and also bilateral posterior crinoid. Then I cut the drum mat. This is a pituitary gland and stalk. I carefully mobilize the pituitary stalk and gland to the left side and start to follow the border between tumor and critical structure. Fortunately, this is a recurrent case, but we could follow the border of the tumor and could remove the tumor piece by piece. This is a basilar artery, this is a PCA, and this is an oculomotor nerve. I resect the tumor piece by piece. And this is the floor of and the lateral wall of the third ventricle, but we confirmed that all tumor was resected out, like this. In this case, we could perform the total resection of the tumor, like this. And this is another case of the craniopharyngioma showing the oculomotor nerve palsy. This patient is a 5-year-old female, so we plan the radical resection of the tumor. But if we just choose the endoscopic endonasal approach, I think it was very difficult to resect the lateral wall of the tumor. So in this case, I plan and perform the combined surgery, transcranial and endonasal approach. I will show our surgical video. At first, I open the right Sylvian fissure. This is a transcranial side, like this. And then, at the same time, I access the tumor through the transnasal route. This is a pituitary gland. I mobilize the pituitary gland to the left side, and this is a tumor. I carefully dissect the perforator from the cyst wall and start to remove, unblock. Some part of the cyst wall was very thin, but so I decided to perform the unblock resection, not left behind the some capsule. From the transcranial side, I dissect the tumor wall from the Sylvian vein and put the cyst wall to the medial side, and then I resect the cyst wall through the transnasal route, like this. Cooperation on both sides was very useful for unblocked resection of the cyst wall. Finally, pituitary gland and stalk preserved, and total resection of the tumor was achieved. And then I seal the drug defect like this. Postoperatively, all tumor was successfully resected out through the transnasal side and also transcranial side. And this is our case. This is our result of our cases. Extent of tumor removal was successful, and visual function and cognitive function was also successfully preserved. But even choose the endoscopic endonasal approach, preservation of the pituitary functions, not easy. But also we can prevent the recurrence successfully like this. To apply the endoscopic endonasal approach to all kinds of the craniopharyngeal, of course, we have to master the additional technique, such as the posterior clinoidectomy, and to prevent the CSF leakage, we have some technique to suture the dura mater or some technique to prevent the CSF leakage. But if you have some interest to our technique, please check this literature. As a conclusion, extend endoscopic endonasal approach can be main surgical procedure to all type of craniopharyngeal. Thank you for attention.
Morning and good afternoon to all of you. Thank you very much for this kind invitation. I'm glad to be in this wonderful event, like held by the WFNS Foundation and the AACNS and the ISMINS. I would like to thank you also, Professor De Puggiari and Professor Komatsu, for having me here. This is Domenico Solari from the Università degli Studi di Napoli Federico II. I work with Professor Capobianca, who's the chief of my service, along with Professor Luigi Cavallo. I'm very glad that I will start with this topic, that is pituitary surgery, and it is a nice episode of neurosurgery because it has been through a lot of years. It started the transsphenoidal endonasal route more than 5,000 years ago with the Egyptians that first accessed the brain via the nose. Then had like several epoch and several fashion modes of performing pituitary surgery. You can recognize here Jules Hardy, and here you can recognize Cushing, you can recognize all the guy that brought in some new technique, but in the end, like this is the final position, the endoscope and the monitors and the new technology that has been brought in changed completely the life of pituitary surgery. We are very glad, like in Napoli, to host one of the biggest pituitary services in Italy. Like for sure, we are the highest volume of cases in southern Italy, and we are also glad that our history of pituitary surgery, it is dated back just 100 before we started our adventure in Napoli. You saw the picture here of Davide Giordano, general surgeon in Venice, that first gave the opportunity of accessing the sphenoid sinus and cellular region via the nose. Of course, it was not a minimally invasive approach at that time. Just 100 years ago, we had the opportunity like to receive all the inheritance of all these giants of the corridors. You can see Norman Dott, you can see Gérard Guillot, you can recognize Sardi, you can recognize Carrao and Joe, that finally, in 1996, 1997, defined the opportunity and described the first 50 cases and led all the world, like changing the paradigm of having transsphenoidal corridor via the use of the endoscope. What is for younger generation, what you have to follow? You have to do, you have to learn, you have to practice, but of course you have to study all these aspects. You have to study the anatomy, you have to know perfectly the meaning and the work, the rehearse of instruments and materials that you have in your OR, and then you have to be peer and peer again in regards to the surgical technique. We start from this one. This is the picture of the anatomical institutes of Leipzig in Germany, and it says in Latin that the anatomy, it is the key and the compass of the medicine. So it is fundamental. We had like lot of mentor along our route, like you can recognize Professor Schabice, you can recognize Professor Prats, but above all, there is Professor Castelnuovo, that is a great ENT surgeon, great skull-based surgeon, but taught us how to deal with the anatomy. That is not a different anatomy, it is still the same anatomy, there is only one anatomy, but the perspective and the opportunity of defining relationship has been provided by his really dedicated and peer work of his team, along with Davide Locatelli in Varese. So this is the endoscope. All of you know perfectly that is sometimes it is a Ultra HD 4K, or this one in particular brought by Karl Storz. It is a HD with 18 centimeters, 4 millimeters, and then there is the sheet of irrigation. There is the opportunity of having like a 3D scope, not that really nice so far. It can give you like a distortion of the reality. Sometimes you can use with video games, sometimes you can use with movies, not yet like properly for the transsphenoidal endoscopic corridor. And this is from Olympus, like the definition Ultra HD and so-called 4K. And brief history of our groups of the Italian brigade, like that followed the path defined by Dr. Carrao and Dr. Joe back in Pittsburgh. You see our group in Napoli started along with the group of Bologna and the group of Varese. And this is the first publication that our group came in, because we studied the problem and we did pay tribute to the ENTs. Why? Because we thought that that time, like having the path via the sinonasal compartment was a functional endoscopic pituitary surgery, because it was via the corridor created itself by the nature that you can achieve the best results in terms of pituitary functioning for the patient. And 10 years later, 2008, like this is probably the definition of what we call the standard approach for pituitary adenomas, or what we call a standard approach that goes through these three phases, like the nasal step, the sphenoid step, and then the cellular step. And it is targeted for what we call like not an extended, but a standard approach to remove lesion of the cellular area. What we have to recommend is like to teach the anatomy of the lateral wall of the nasal cavities. You see the ethmoid complex sometimes gives you a lot of surprises, lot of problems like to pass through. And then you have to move further to recognize which are the main landmarks. On the left side of the screen, you can recognize here the right nostrils with the coena, with the sphenoethmoid recess, with the sphenoidosteum, and the opposite way around. It is on the left side, but it is specular, but it is not certain that in the same patient there are the same structures and can be recognized. And then like some tricks, there is the sphenopalatine artery. It is very, very important, like to recognize it. It comes across like the roof of the coena. You see here in the first days of our experience, we used it to cut it with the very aggressive instruments, because we were afraid like to do not have the proper understanding of the nasal structures. Then we went back to the lab, we went back to study with the ENT, and we find out that that was like the most important thing, like to respect to have the reconstruction, to have like the mucosa vital, and to not overcreate sinonasal problem, wheezing, difficulty in respiratory upper tract of the patient, crusting, and so on. Then we learn also how to expand our fields, like to have a safe movements of the instruments, not only like to sneak with the endoscope inside and steal with the anatomy. So it is here like a very nice depiction of Dr. Kelly in Santa Monica that taught us how to create a box, not like a funnel-shaped corridor. You have to open widely the sphenoidotomy, and you have to be sure that the margins of your sphenoidotomy just go parallel, just go toward the carotid paracellular tract at the level of the sella. And then you have also to recognize the carotid. You see here, like this is a drawing coming from the demarcation that shows these nice instruments. That is a microdropper probe that helps identify. And then, of course, there is the pituitary gland. The pituitary gland has a lot of function, lot of vessels, lot of things to be respected and to be addressed. And for us, it has been fundamental the co-working with the other disciplines, above all, like the friends coming from the pathology with the new definition. It is not anymore a pituitary adenoma. It can be considered like a real neuroendocrine tumor. And it has like a lot of transcription factors that you say have to be claimed, like to give prognosis, to give exact definition, and to give peer diagnosis. And also WHO changed the way of claiming the pituitary adenoma since the suggestion coming from the group of Dr. Laws and friends. And here, like it is a brief reminder of what is pituitary surgery for. Of course, like we adopt pituitary surgery in cases of growing non-functioning pituitary adenomas that creates mass effect, above all toward the chiasm and optic nerve. Then it is first-line therapy for the cases of Cushing disease, of course, in pituitary adenoma that secretes ACTH. In case of acromegaly, and we are changing the paradigm thanks also to the group of Dr. Patrick Semple of South Africa for pituitary apoplexy. We go in only when there is no response to corticosteroid, when there is several injury. And this is our endocrinologist. You see, like the Professor Colau that also taught us like to respect the normal gland, like to spare the functioning after having performed a surgery. And the endoscope was brilliant in this adventure, because here, like we are removing like a paracellular microadenoma, and you see how with the endoscope you can recognize the soft mass that is the tumor. Then you respect the pituitary gland that is inside and protected via the dura. You recognize the reddish tissue of the pituitary gland. You just be sure inspectioning that there is the paracellular tract of carotid artery, and then you close, and you have like to be sure that you removed completely the functioning mass and left the pituitary function. And also in this case, you can recognize the pituitary gland at the upper part of the tumor. So here it is, of course, like a mass effect that brought us into surgery. Here we are removing like nicely with this ring curette the pituitary mass, like starting from the most inferior aspect. And then you see here in the upper part, as in the MRI, it appears the gland. So we can use like blunt removal of soft tissue off the gland. Then at a certain point, the cistern will fall down. We recognize the cistern. There is no CSF leak, so only reconstruction of the sella, and that's it. Also, again, like what has been so important to use the endoscope, like this paper shows that as long as you expand the diameter of the tumor, then we will be have a lot of opportunity with the endoscope, because the endoscope will get you a closer view. It can get you a view around the hidden corner, and this is fundamental above all in those cases where the cistern comes into the view and you cannot like work around, or you do not want to create intentionally a CSF leak. So brief reminder of all the advantages that we find out along this route, but I would like to underline also that there are a lot of advantages for the patient. Above all, like the better quality of life, and of course, like less postoperative discomfort. And so we had the opportunity to look at the horizon and expand our horizon. We follow the path again of giants, as Professor Karau and Kassam, that expanded and defined the opportunity of achieving the corridor, first on the midline and then in the paramedian aspect. And also in Napoli, you see, this is a picture from our hospital. We removed the frame, we expanded the work as in regular skull base. We drill out a lot of bone inside the sphenoid corridor, and we have been able to expand toward the entire skull base, and we transform it from standard to extended endoscopic endonasal surgery. And you saw this picture, basically it is targeted toward all the areas that can be accessed via this corridor, with several tricks and several approaches that has to be performed at any need upon the lesion. But still, there are some evaluation that need to be performed before having this kind of surgery. Of course, like you have to define the anatomical corridor, you have to be sure of the relation with nerves and vessels, and then you have to peer study the function and define the possibility of risk of injury in the stalk hypothalamic region. So, of course, in case of adenoma, our corridor that used the most is the so-called transvercum transplanum approach. This is our first publication, and this is also a publication that divides the giant or big adenomas into two categories. There is certain differences, those adenoma that falls inside the sphenoid sinus and those that grows up, especially if they go toward the brain tissue and they are with asymmetrical extension. So we started like with the extra-arachnoidal dissection, as in this case, not a huge tumor, but a recurrent tumor. And so to be sure that there was no anymore tumor in the arachnoid or around the stalk, we performed like the debulking of the part that was inside the cella, and then we dissected the capsule from the arachnoid, from the chiasm and the stalk. And you see at the end, like there is the stalk with the vessels, the anterior complex vessels, and the pituitary gland and the chiasm. And you see the postoperative course. Of course, in this case, there was an extended approach, so it required a perfect watertight reconstruction. So this also gave the opportunity to study this other category, not like real, only like with the vertical axis extension of the tumor, but this that Professor Cavallo somehow defined unconventional, that says that seems like to be that are adenomas that tend to be aggressive, not in terms of pathological features, but with the shape. You see, they are asymmetric. They usually breach out the arachnoid, extend toward the brain tissue, and surround and encroach vessels. So these are the fundamental key points that you should evaluate. And this is a recent paper that we published on the Italian journal. I'll show you a case. You see that huge tumor with that part that was pointing toward the third ventricle. We performed a double corridor. First, we debulked the tumor inside the cella, subdiaphragmatic space. Then we coagulated the diaphragm, and we started following the lesion in between the arachnoid, dissecting from the vessel. You can recognize here the right optic nerve. We keep on dissecting with blunt and suction instruments toward the third ventricle. So we created a breach toward the posterior aspect, and this is the cavity of the third ventricle. We started also like biting off with the ultrasonic dissector. Then we removed this part of blood that was there, and then at the end we have been able to reconstruct with fat pad and a Bassagastegi flap. But also there are some tricky cases. You see here, like this guy was a prolactin secreting tumor. So we started with the in accordance, it was complaining no visual defect, and it started with a very gentle cabergoline therapy, like to have some shrinkage. It was many years ago, like you see, very high value of prolactin. But look at this, like 2 weeks later, he came comatose to our emergency room. So we started immediately, we placed an EBD, and then we had like to perform surgery. Here, like you see, not that quality because it was nighttime. There was a rush of the instrumentation, but again, like it was performed supracellular, subarachnoid, and you see here the component that was totally invaded by the blood clot inside the tumor. Again, it was soft, so we have been able to remove completely the tumor, and that was the third ventricle cavity. So in this case, like what we have to suggest, like to the possibility of having the pituitary surgery perfectly done. First of all, you have to select the case, be prepared, like acquire knowledge and skills, and prepare like to have 1 route, 2 route, 3 alternative route, plan again, plan and study the case with your team, with all the team, not only the surgeons, the radiology, the endocrinologists, the radiotherapists, and also the clinician that help you inside the ward, and the ENT, of course, to define the anatomical corridor. And then acquire as much as possible confidence with the instruments, with the corridor inside the lab. Rehearse, inspect, study, define, try. Don't be afraid of performing the corridor, but be sure to identify the anatomy, be sure to identify the normal tissue of the pathological tissue. And of course, like in case of that, refer to a specialized center, because only centers that goes up like to 100 cases can treat decently a secreting Cushing, can cure acromegaly, and can expand toward an extended approach. Otherwise, it will be just a biopsy of the tumor, just debulking of the mass effect. And you see, we refine again, we refer to this nice paper written by Dr. Laws, Dr. Yeziku, and Dr. Kelly that define what is a center of excellence. And it is a center that has a multidisciplinary team approach. It has all the figures that are mandatory for this kind of surgery, but it also has a residency program. It hosts a dedicated fellowship. It has the possibility to contribute to research, to exchange, to be involved in discussion such this beautiful event. And we hope like to expand this team in Europe and all around the world. It is not yet over, because what have been done so far maybe can be revolutionized. And you see, there are new techniques, new instrumentation, and innovation that can also predict preoperatively or according like to several radiological features what is the destiny. This has been for craniopharyngioma. We have been working on adenomas to define the features and the possibility of prognosis. Thank you very much. I wish you again a successful event, and I thank you all for having asked me to give these lectures and the opportunity to be with you. Thank you again.
Good morning. I'd like to thank the organizers of NSICon, Professor Sridhar and team, and the Scientific Committee Chairman, President-elect Professor V.P. Singh, for giving an opportunity to speak on neurosurgical treatment of fungal infection in the COVID era. Fungal infections are very uncommon, but during the recent times, it has become very common. And will present our experience as compared to what we had done earlier in non-COVID era. It is a rapidly progressive infection there, and fatal opportunistic infection. Normally, it affects immunocompromised state, but then it's not uncommon immunocompetent, especially in the COVID era. They're associated with high residual morbidity and mortality due to it in angio-invasive property of fungi. The aim is to have early diagnosis and early aggressive management, both surgically and medically, to have good outcome. Rhinocerebral mucormycosis has 3 stages. The stage 1 is a stage of infection of the nasal mucosa and sinuses. Stage 2 is orbital involvement, where they present with orbital apex syndrome or superior orbital fissure syndrome. And stage 3 is cerebral involvement, in which there is intracranial spread via one of the following routes, either ophthalmic artery or through the superior orbital fissure or cubiform plate, or if maxillary sinus is involved, through the foramen lacerum into the middle cranial fossa. Though we believe that it is contiguous spread, but then mucormycosis also has hematogenous spread, as depicted in the diagram. The pathogenesis of spread of mucormycosis is due to presence of free iron in the blood. Normally, the iron is bound by protein, so the fungus does not spread. Whenever in diabetic patients, there is acidosis where the iron is free in acidic environment, both in the blood and the tissue, then there is a growth of the fungus, and then it easily invades the blood-brain barrier and causes endothelial invasion, causes thrombosis and infarcts also, as well as disseminates intracranially with an hematogenous spread. Because this is example where, because of angioinvasion, patients can have infarct, or because of angioinvasion and hematogenous spread, they can have multiple lesions like this in the brain, which was this case suspected actually tubercular or cysticercal, but turned out to be an aspergillus infection. There's a recent study from Mexico in 2018 where they said that the diabetes is the predominant premorbid condition and the mortality rate was 51%. We had published in 2010 of in the pre-COVID era of our experience of fungal sinusitis, and they were predominantly locally fied. They're presented in 5 different types, like allergic fungal rhinosinusitis, or there could be invasive involving the surrounding brain, but did not have at that time hematogenous spread. We published later in 2007 the predictors of mortality, and what we found is whenever they presented with a focal neurological deficit, they had a higher mortality. And the patients who were immunocompromised had a higher mortality, and mucormycosis had a higher mortality than aspergillus. So the mortality depends on the type of infection. But it's not uncommon to have aspergillomas in immunocompetent patients also. In the COVID era, we have treated 32 cases. Another 7 cases which we have treated after July has not been added, and in that 6 were purely the rhinal, from 11 were purely cranial, and 8 were craniofacial. 10 patients had prior post functional endoscopic sinus surgery, and we did not operate out of this 32 what will be presenting 4 patients. Only dural enhancement we did not operate, but if the associated disease, abscess or granuloma in the cranium, we operated. We had 7 who had frontal involvement, 6 temporal, 1 purely ventricular, and 5 patients who had multiple site involvement. We divided the patients into 5 groups depending on the presentation or involvement. Group 1, where it's a purely hematogenous spread causing parenchymal abscess. Group 2, hematogenous spread causing only ventriculitis. Group 3, sphenoethmoid with anticranial fossa involvement. Group 4, we had sphenomaxillary with middle cranial fossa involvement. And group 5 has residual or recurrent following FES surgery. Now, this is a case example of the first group. This is a 53-year-old lady came with multiple intracranial SOLs, and we did as the lesion had a thick wall, we thought just doing a biopsy may not get ill. So we did a robotic guided craniotomy and excision of the lesion. This is how we use a digital globe to create a tract along the planned trajectory, so that excision can be done through the tract with a microscope or an endoscope. This is another case of a lesion in the basal ganglia. Again, turned out to be fungal, which is robotic guided aspiration, and it turned out to be fungal abscess, aspergillus abscess. This is a case example of group 2 where they presented only with ventriculitis. So here, when we did an aspiration of the ventricular fluid, turned out to be fungal infection and fungal ventriculitis, and you can treat it with antifungals. There's the group 3 group of patients who had sphenoid and ethmoid involvement. This is a patient who came following FS surgery, but then there is a gradual increase in size of the frontal granuloma, which we had to do. We did anterocranial fossa exploration, mini frontal craniotomy, excise the lesion, and then drill all the involved bone, and then did anterocranial fossa carpeting. This is a group 4 who had spinomaxillary involvement. Patients who had a maxillary sinus, predominantly maxillary sinus involved, they either involve the middle cranial fossa or the cavernous sinus. This is an example of a cavernous sinus abscess here. And this is an example of a temporal lobe abscess, abscess with maxillary sinus involvement. This is a case of a cavernous sinus abscess, where the pus extradural transcranial extradural subtemporal approach was done. Pus was evacuated. All the involved bone was drilled till we reach the normal bone. The primary aim is to drill till one gets the normal bone. So this is what drilling till we reach the normal bone. Pus was evacuated, all the granulation tissue removed. And wherever the middle cranial fossa was eroded into the maxillary sinus, the pus in the maxillary sinus also was debrided, removed, and middle cranial fossa repair was done with carpeting with the pedicle pericranium. This is the Perkins picture of carpeting with the fat and pericranium and temporal fascia. Now, this is a case of a residual lesion or a recurrent following FES, where it had they had done transnasal FES, but there was a recurrence primarily in the maxillary sinus. So we did a sublabial transmaxillary approach and debrided and curated all the bone, and he was treated with post-op antifungal. Of the cases we operated, 28 cases we operated. We had 20 who had only mucor, 4 who had aspergillus, and 4 who had combination of mucor and aspergillosis, or they had bacterial infection. All of them were treated with amphotericin. 17 had posaconazole, 3 had anidilofungin, and 4 patients who had only aspergillus were treated only with voriconazole. We had complication. One patient came with a severe massive bleed and angiogram showed a pseudo aneurysm, which was again coil. And this patient had developed a massive infarct, and then we lost because of the infarct. He did not recover following decompressive craniotomy also. It's not only the disease, but also the treatment can cause infection, like antifungal Posaconazole is a drug which in 14% of them they can cause thrombocytopenia, and at least 10% of our patients develop thrombocytopenia, and one patient actually lost because of thrombocytopenia and sepsis. Amphotericin is something that can cause renal failure. One has to be careful. And anidilofungins, there is a higher chance, 10% chance of deep venous thrombosis. So one has to look for and treat for DVT if one starts anidilofungins. 4 out of 32 we lost, especially people who had pre-op infarct, the infarct increase, which I saw the scan, and people who had combination of infection, both fungal and bacterial, they did not respond well to treatment, and where we had to give multiple antifungals because they did not respond to antifungal drug. Though in literature, it's reported that mucormycosis with HIV and AIDS has a 100% mortality, but in we had 2 cases who had positive, and both of them did well, contrary to what is reported in literature. In conclusion, CNS mycosis needs careful management for a good outcome. Aggressive surgery with antifungal is a treatment of choice. Voriconazole is the first line for aspergillus, and amphotericin B for zygomycosis. Role of newer antifungal agents are evolving. The cost of therapy is a crucial issue, and it's an issue worldwide. Pre-op infarcts and multiple organism infection are the major predictors of poor outcome, and only dural enhancement did not warrant any surgery. Thank you for your attention.
Good afternoon, everybody. Thanks to the organizing committee, especially to Professor Komatsu and Professor De Pujari. And I'm very glad to present this topic, the skull-base repair. I am Domenico Solari from the Università degli Studi di Napoli Federico II. Here, I have nothing to disclose, and I'm very happy, as I told you, like to speak about this interesting topic. This is a paper, so-called the paper of Edwin Smith, in which for the first time it was written down the word CSF. And this is an Italian pride, of course. This is the Michelangelo painting of God that is creating all the world. And you see the envelope, it can be the dura. So even Michelangelo, that was an excellent anatomist, recognized the importance of having like the brain and all the neural tissue enveloped in a safe box. So a few words about my institution. I am assistant professor of neurosurgery in Napoli in the group led by Professor Capabianca. I had the honor and pleasure to work with Professor Capabianca and Professor Cavallo along their experience in endoscopic and nasal surgery. And this is our city with the volcano that is called Vesuvio, and it is our deities. And this is Federico II, to whom is dedicated our university. It was the first public institution in Europe. It was founded in 1224, and this is probably the most great deity we had in Napoli. This is Diego Armando Maradona. The experience of the group of Napoli started in 1997 with the endoscopic and nasal approach targeted toward the cellar area. And of course, we started immediately without the nasal speculum. It was not required at all in any procedure since the first one. And this has led us to a wonderful world. We were novel of this world. And of course, we had to reschedule our program, our teaching, our learning. And so we had also like to revert our knowledge of anatomy. It was not a different anatomy, but it was somehow a different point of view over the same anatomy. And you can see here clearly what we've been experiencing along the year with conventional transcranial approaches with the hole coming from a conventional transcranial route and the breach that can be created via the endonasal corridor. And of course, like Professor Cappabianca and all the group in Napoli, like has this memento as education, like it is our constant and our main activity. We have to learn and we have to teach and we have to share ideas and all that we learn. And for us, it has been very, very easy. This is our group of residents like a few years ago that is follow the lead, the Professor Cappabianca. And for us, it has been like standing of the shoulder of the giant, like the Orion, like, you know, the myth, the Greek myth of Orion. And we have been traveling a lot. Every one of us has been moving and sharing experience. I'm very glad to be part of the neuroendoscopy committee of the WFNS. And this is our mentor, like on the left side here, you can see Professor anatomist in Vienna, and here it is Professor Castelnuovo, world-renowned ENT that taught how to deal with the nose. And this is my experience. I've learned in US, I've learned with Italian friends and learned all over the Europe to train skull-based concept, to know also endoscopic endonasal approach. But basically, every one of us that approach to this concept should train in the lab, should rehearse and rehearse and rehearse again, like develop a perfect three-dimensional understanding of the anatomy and know perfectly the pathophysiology of the lesion dealt with. For us, it has been like the bit generation, like opening the sphenoid sinus wall. It has been like a gateway to the world of the skull base. Of course, we can even dream about like the shapes of this posterior wall of the sphenoid sinus, but basically we have to pay tribute to the endoscope, because the endoscope not only gave us a close-up and wider view, but also gave the opportunity to go through. So you see here, like we first dealt with transsphenoidal microscopic corridor toward the pituitary gland, and then we have been able like to go farther beyond the sella and expand our knowledge of anatomy, of vessels, and of nerve that were surrounding that area. And you see here, like in 2005, Dr. Carrao and Dr. Kassam like systematized the approach that can be targeted via ventral corridor toward the midline and paramedian skull base. And this is a resume of the main pathologies that we are actually dealing with in regular activities in the centers where there is this kind of service, like with dedicated surgeon, dedicated ENT, and dedicated neurosurgeon. And this is the experience starting in 1997, back to last week here in Napoli. In the January 2022, we ran over 2,000 procedures, with the most component of that were pituitary adenomas of every kind of pituitary adenomas. Then there are cranopharyngiomas, meningiomas, and so on. But of course, it is not only like a bed of roses, like there have been a lot of struggling, a lot of difficulties that we encountered along. And above all, it has been like the CSF leakage, because we are aware that this is a risky business. No one told us that was an easy, straightforward trajectory. And sometimes you do stupid things, you are not prepared, you are not confident, or somehow you are too confident, and then you go beyond your limit and you take the risk of injuring the patient. But there are also some risks that you should consider. Like, first of all, like patients that are overweight express, of course, an increased intracranial pressure. Many of these person that experience pathology, skull-based pathology, need postoperative adjunctive radiotherapy. Sometimes you open the third ventricle, sometimes you opening the Lilliequist membrane. So what should you do? Like, of course, you have to investigate when you have a CSF, when you have to approach the repair of the skull base, because there are these two terrible and threatening complications, the meningitis and the hypertensive pneumocephalus. So what to do? Like, first time you're afraid, like you never would like to go back inside again, and you try everything that is in medical and like adjuvant therapy, like you try to elevate the height of the bed, like you give salt softener, you try with acetazolamide, with the bed rest, like with the diversion, with lumbar puncture, lumbar drain, and so on. But like we started to consider that if the repair like it is mandatory when like there is a huge amount of CF coming and there is an extreme risk of meningitis, of neurocephalus, and so on. But be aware like that the success rate at second time, or like even after traumatic skull base injuries, are very, very low. So please refer to experienced centers. And again, like the experience make it clearly. I had this opportunity again, like not only via the endoscopic and nasal repair. I've been training with Sebastian Frelich in Lariboisier in Paris, and we had the opportunity of writing down this chapter like with a very, very nice and dedicated reconstruction for every kind of approach, every single pieces of the skull base. Of course, my main focus, it is on the endoscopic and nasal technique, and you see a lot of learning came from the ENT surgeon, because there is a lot of adjuvant that you can add to the endoscopic visualization, but somehow it is a myth. Why it is a myth? Because there's nothing different as compared like to reconstruction that we've been adopting for years and years, like in regular transcranial approach. So you have to deal with the intradural compartment, seal the osteodural defect, and then like cover and cover again. Of course, like there is the gravity that is against you, like the shape, it is not like an oval and a well-round shape as in a transcranial craniotomies. Like there are a lot of neurovascular structures surrounding very close the borders, and there is like the amount of the arachnoidal opening that is against you. So far, no one has developed or find out like the ideal material, but we all rely in this community to this paradigm, like that classify the entity of CSF. And when you create like a violation of the arachnoid, you have always to refer to the large CSF leakage, so to the so-called grade 3 according to the Kelly and Esposito classification. So initially we started with this paradigm. We use it to fill the dead space with soft material, glues, fat, and so on. Then we use it as solid buttress, like to seal the osteodural breach. Then we use it seal again with the glue, and then to pack and pack again. We reported in 2007 this, that was a very nice paper on JNS, and it was basically the same that the group in New York led by Dr. Schwartz was performing at that time, with a semi-solid buttress in between the dura and the bony borders, and then with the intradural space completely filled. Then somehow, again, like the Dr. Carrao and Dr. Kassam group revolutionized our idea, because a group of Argentinian ENT defined this nice pedicle over here that allowed us like to use this big chunk of mucosa and to cover the defect. So that was one of the initial cases that we were dealing with. You see, that was after a tuberculum cell meningioma. We used it like to use this soft dural substitute, and then a semi-solid buttress in between with the redundant piece placed over and over again. Then we use it to fill, and then at that time we used only like a cover of the defect, the Haddad Bassacastaghi flap. So you see here, that's a picture where Professor Kassam used it to rely completely on the vascularization of this flap and supporting only with balloon. And you see how nice it is vascularized and how it is stick to support the large opening. Then we moved to this other technique back in the days. It was called like the sandwich technique. And of course, like we had like different materials in different space. It was very long procedure, and usually it came at the end of a tiring approaches. We do not have an ENT that prepared this kind of solution, that there is the two main surgeons, usually Professor Cavallo and I, Professor Capobianca and Professor Cavallo, or other resident. And so you see, you have to fill the dead space inside, and then you have this sandwich that has been already stitched with the fat and different layers that are placed in the different sides of the osteodural breach. But starting 2017, we found this other solution. It is called the 3F, and it accounts on the fat that is placed inside, then directly on the Haddad Bassacastaghi flap that is laid toward, and then the patient stands out as much as possible, as fast as he can, out of the bed to reduce the intracranial pressure. So far, we went up to 117 cases, and you see, like we consider these that were our enemies so far, and also like the thing that the procedure could be on a recurrent disease, and in case already have been done like the radiotherapy. This is our schedule. You see, we had only like a major CSF postoperative leakage, and it was in a patient that harvested also a dermoid cyst that created a chemical meningitis and the retardation of the healing of the flap. And in 3 times, we've been using this technique that we do on the ward, like we inject fibrin glue. And this is a nice case. You see a tuberculum cell meningioma, complete removal, the opening at transtuberculum transcell approach. We stuck in this piece of fat, we just wedge in, and we ask the anesthesiologist to go for a Valsalva maneuver and like to raise down and up the head, like to avoid the excess of fat inside the defect, and then we fix it with glue, and then we fill the space with the saline solution, and then we cover directly with the Haddad Bassa-Castaghi flap. And you see, like here, nice piece of fat. You can recognize here just wedged in between the boundaries of the osteodural breach, and then there is a certain percentage of pneumocephalus, no problem, no headache, the patient stands, and this is the resorption of the fat pad. You see at 3 months postoperative and 1 year post-op. And this is also another case like of the posterior fossa, young lady with a chondrosarc, like we open it, you see the basilar tip, like both third cranial nerves on the sides, and we use it like a huge piece of fat, like to seal the posterior fossa. I go fast here, like very, very large amount of fat. You see no CSF coming. In this case, there's no requirement of moving the table up and down like with the anesthesiologist. We fix it and we cover with the flap, and then we fix eventually with small sponges and small surgicel. Here it comes like the postoperative MRI, and you see like 3 months there is a sort of tumor of fat, but already 1 year it starts to shrink. And here some cases a huge adenoma, like early postoperative MRI, and you see like the shrinkage at 3 months, and then like again like a supradiaphragmatic with the opening of the third ventricle already 1 year. You see how nice it is, the resorption of the fat. Here it is a tuberculum cell meningioma, huge chunk of fat coming across the border, and then 1 year it is already done. So nowadays, this is our policy. We use the fat as a filler, as a cork that comes across the breach, like in the amount, you can avoid the amount in the compression with the help of the anesthesiologist, having Valsalva and having like the slow pulsation of the intracranial pressure. Then you have to seal little with the fibrin glue, and then we have to cover directly with flap. This is what we have done so far. We hope that in 5 years, there will be like nice and other techniques that overwhelm our trouble that we are experiencing so far. Some things is already going on. We have been dedicated our part to new technologies, but we do stress like the importance of being a team and to use your brain at any time. We wait for you in Napoli in July for the IFNI course. Hope to see you soon. Thanks very much for this opportunity. I wish you a successful event.
Good morning, good afternoon, everybody, accordingly. I was given the task to present the complications in ventricular endoscopic surgery. Going through an around 3 decades archive of neuroendoscopy made this presentation possible, and I hope of any benefit. In general, complications of brain endoscopy are injury, infection, hemorrhage, mortality, overall 2.7% in our series. In other reported series, up to 18%. They may be categorized by onset, immediate, early or late, course, cured, stopped, ameliorated, worsened, duration, transient, permanent, severity, mild or severe, procedure, single, multiple, stage, type, inevitable, silent, remediable, ongoing, and most of all, recurrence, especially when it comes to endoscopy. The course is procedure and not disease dependent. Now, the worst case scenarios in ETV are intraoperative, neurovascular injury, whether to the fornix or bleeding, can be solved by ample irrigation, by balloon tamponade, by small chamber irrigation technique, or even dry off the field if you have to. Bradycardia, tachycardia, even cardiac arrest, thermal damage, overuse of the ball electrode, overheated irrigation solution, surgical technique, rough maneuvers, levering, exceeded balloon inflation, drifting from the midline. Now, if you are faced with a small, these are all the types of bleeding that you might have. One of them was the bleeding from this choroid plexus, which was in your way. If you do excessive levering, you might end up by this kind of bleeding. It heals up, and you're able to do your task or whatever you want to do as regards the ETV. Again, another kind of bleeding from a thickened floor. With balloon tamponade and ample irrigation, you solve it, and you continue your ETV. If you are faced with such a small foramen, you can always push your sheath and then guide it through the small foramen in order not to injure the fornix or the choroid plexus. You do your ETV and visual confirmation. And then you pull out, you see the fornix and all the structures of the foramen of Monroe intact. Early postoperative sequelae would be subdural collection or CSF leak, infection, transient fever. In the old days before the autoclavable telescopes, we had to sterilize with some sort of solutions, and if not properly washed out and properly rinsed, you might be faced with transient postoperative fever. Or if you use more than 37 degrees Celsius solutions, you might even also cause transient fever. Memory loss, whether temporary or permanent, endocrinological disorders, cranial nerve, especially the third nerve, and when the balloon is maximally inflated and not under vision, you might injure the third nerve. Seizures and delayed sequelae, of course, are the failure of the procedure. Multilocular complex hydrocephalus are usually in preterm infant, incubator child, and precious baby. Now you go through replacement, refashioning, redirection of the proximal tube when the child is first shunted, and you try to reduce the shunts, use cystostomies, fenestrations, and if you're lucky, you'll be able to do an ETV. Aim is sufficient drainage of the ventricular compartments through a single shunt system. Yet, you might be faced with all these procedures ending up with still a multilocal complex hydrocephalus. And you start doing endoscopic shunt fashioning and placement with fenestration, septi, plus minus another ETV, plus minus redirection and replacement of the proximal shunt tube. And you get all the possible complications. And you shift from ETV to shunt. Some do the shunt planned and fashioned. This might suffice for endoscopic procedures. Outcome should be with control images and clinically. Image guided versus endoscopy. I prefer endoscopy or endoscopic guided. Sufficient drainage and avoid infection. This would be your aim. Now let's have a look on this case. This is a multilocular or multiloculated complex, complicated hydrocephalus from repeated ETV, repeated shunt infection, repeated post-ETV even fulminating infection, and EVD, and every possible procedure that you would do. And then you resort to another endoscopic placement of a shunt. With visual confirmation of the different compartments and that they are connected, with redirection of a fashion shunt to drain all the chambers, with fenestrations, and widening of the opening of the osteo that you have done. And visual documentation that all chambers are connected to have this beautiful radiological result. Of course, the cut with the shunt is not there, but this patient had a shunt left in. And unfortunately, what you get here is a failure of all endeavors and a complicated delayed milestone outcome, unfortunately. ETV redo, a complicated case of ETV with dysfunction of the ETV. You might be faced by these two pictures and you have to do a resort to a shunt. This is a very interesting case, and this might explain, or is a typical example of the reversed flow, regress of the cerebrospinal fluid into the third ventricle, that might explain even the acuity of the condition post-ETV failure. You see how it's pumping in the CSF into the third ventricle. Yet it's successful thereafter. These are to show you a different kind with adhesions, with the previous ETV showing, and yet a redo is successful with visual confirmation. Another assumingly a complication with a version floor after ETV, and a redo is done with visual confirmation, and you see a lot of adhesions inside or beyond the floor of the third ventricle. Secondary ETV after repeated shunt procedures amounting to 20, and a failed trial of ETV that ended up with infection, an EVD until the CSF cleared up, and you are faced with this case. Now your only option is here. You should go through here. In order when you do your widening of the osteo with the balloon catheter, and you do visual confirmation, and you get a successful result. And you solve a complication of both shunt and ETV. An interesting case is this young child, 2 months old, hydrocephalic, had a right malfunctioning shunt and then proved to be undershunted due to high abdominal pressure, left additional BP shunt done. At the age of 7 months, ruptured umbilical hernia, shunts exteriorized and the right removed, the left kept as an EVD, with repeated labs, both CSF and blood. She came to us at that stage. This is where we started doing with such a CT, and we proceeded with flowmetry and repeated CT scans and neuroimaging. At 9 months, secondary ETV was done, even with preoperative CT small ventricle. Closed, redo ETV. Everything was done in this case actually. Visual confirmation of a proper ETV, yet it was not sufficient. So this is another complication. Maybe because of the age, maybe because of the infection, yet she was at 9 months of age when we did all these procedures, followed by an EVD, ventricular, some drainage, antibiotics, repeated labs, right BP shunt, and the distal end was laparoscopically placed suprahepatic, and the present status is quite satisfactory. Shunt is functioning, no fever, milestones catching up. Use all your tools for the purpose of serving, for the purpose of serving. Photos with permission of the relatives. Our prime purpose in this life is to help others. And if you cannot help them, at least don't hurt them. Dalai Lama. 3 years of age, and this is how the child looks like. Postoperative complications in colloid cysts, remediable postoperative chemical meningitis, transient ongoing memory disturbance, intraoperative bleeding, cerebrospinal fluid leak, recurrence, one case after 18 months, with the contents different, missed part of the capsule in 3 cases after 3 years, no mortality, shunt dependency within an ETV, an EVD, ventricular subgaleal, ventricular peritoneal shunt. Interestingly enough, when you come to show your work in colloid cysts, this is what you show. And you forget about this silent complication. This is the corridor that you've created. And this might, in some cases, end up by a porencephalic cyst or remain as such. Another post-endoscopic assisted microsurgical excision of a thermoid cyst ended up with this proximal intracisternal obstructive hydrocephalus with a megacisterna magna, enlarged fourth ventricle, third and lateral. An ETV solved the problem. Craniopharyngioma done through an endoscopic endonasal expanded transsphenoidal intraventricular surgery. The possible CSF leak that might happen and what you have to do in these cases, all the possible repair techniques, preferably in such a case with profuse CSF leak, you would resort from the start to Haddad's flap. You might have intracranial infection, breakdown and reconstruction, persistent CSF leak, and other complications in the nose. You might even have tension pneumocephalus. And this is how to solve it with a posterior nasopharynx occlusion to prevent airflow to skull base with a Foley's catheter or neurocele pack. Of course, you have to empty the air or put the patient on oxygen 100% and prophylactic antibiotics. Now, message: educate one to save a few, educate a few to save many. Patient safety comes first. Plan your surgery and hope for the best. Thank you very much.
Ladies and gentlemen, it's a pleasure for me to be part of this Endoscopic Neurosurgery WEB Summit 2022. I want to present to you the application of the shunt scope. I have to disclose that I hold patients with Karl Storz Company. I used to act as consultant to Karl Storz Company, and I received honorarium from various other companies, which I think is unrelated to this presentation. I'm from Europe. In more detail, actually from a small city called Homburg, close to the French border, about 1 hour from Frankfurt, Strasbourg, and Luxembourg. And this is our university department of neurosurgery. We do like 3,500 procedures per year. We have 4 theaters, and we do about 400 endoscopic and 400 MRI spine procedures per year. The Department of Neurosurgery is well known for the first microdiscectomy performed here by Caspar in 1977 and the development of the surgical Caspar system. That's me. I'm Professor of Neurosurgery at the University of Saarland and Director of the Department of Neurosurgery at the University Hospital Homburg, Germany. My main focus is on endoscopic techniques. I do about 400 to 500 MIS procedures per year, and I have written more than 200 articles and book chapters on endoscopic techniques. Well, let's go to the theater. I want to divide my presentation in 4 parts. The first part is what is the tool we talk about? Then what is the indication to apply the shunt scope? How to apply the shunt scope, and what are the results and risks? So first, what is the tool? The shunt scope is an endoscope manufactured by Karl Storz company in Tuttlingen, Germany. It's a non-disposable, semi-rigid 0-degree telescope with a length of 16 centimeters and an outer diameter of 1 millimeter. Image resolution is 10,000 pixels. You see here in the upper left area the image with the outer diameter of 1 millimeter. It's a semi-rigid endoscope system. And this endoscope is inserted into the ventricular catheter, as you see in the upper left, in the lower left image, and used to guide the catheter. On the right, you see the shunt scope inside the ventricular catheter. The shunt scope can be combined with a burr hole reservoir. So on the upper left, you see the combination of the ventricular catheter and the Rickham reservoir. Then the tip of the catheter has to be cut and opened. And then there's a need of a perforation with a small cannula. And then in image D, the endoscope can be introduced through the Rickham reservoir into the ventricular catheter. On the right side, you see a schematic drawing how to apply this shunt scope inside of the ventricular catheter and the Rickham reservoir to place the catheter into the ventricle. What is the indication to apply the shunt scope? Well, shunt survival is significantly related to accuracy of ventricular catheter placement. The preoperative size of the ventricles and the age of the patient at shunt insertion determine the quality of ventricular catheter placement. The incidence of proximal catheter misplacement reaches up to 45%. So a potential indication for the shunt scope is any indication of hydrocephalus with this expected difficult catheter placement or expected stent catheter implantation. So these are slit ventricles, distorted anatomy, unusual approach. These are revision surgeries for ventricular catheter revision, proximal shunt failures, and interventricular stenting procedures. How to apply the shunt scope? Now we see 3 subsequent videos with the different topics. So here you see the precise cutting of the ventricular catheter. So in this case, 6.5 centimeters. Then connection of the catheter to the Rickham reservoir. Fixation of the catheter at the Rickham reservoir with a non-resorbable suture. Now the catheter tip is opened. So a cut is made so that you can actually introduce the endoscope all the way through the body of the catheter and forward it to the tip. Now here, everything is connected to the shunt system. The puncture is performed for the ricum reservoir, the cannula. Now the shunt scope is inserted through the ricum reservoir into the ventricular catheter and forwarded until the tip of the shunt scope passes the tip of the ventricular catheter. So now this application is used to apply the ventricular catheter under endoscopic view into the ventricle system. Now we switch to the endoscopic view. You see here, this is the slitted condylar tip, the slitted ventricular catheter tip, and now we are inside the ventricular system. Image resolution is a semi-rigid endoscope, so here you see the mammillary bodies, choroid plexus. So we are for sure in the lateral ventricle with the tip of the catheter. Now the catheter is left in place and the endoscope is retracted. Another example, catheter placement in slit ventricles. So this is a preoperative MRI. You see that there's a very narrow ventricles. Now the endoscope is introduced into the ventricular catheter. And under endoscopic view, the ventricular catheter is forwarded into the ventricular system. You see, in this case, the rather poor image resolution, but nevertheless, we see definitely that we are inside the ventricular system and inside the lateral ventricle. A third example, now we can also use the shunt scope to inspect the ventricular catheter. So if we have a suspicion for ventricular catheter malfunction, you can use the shunt scope to inspect the ventricular catheter. So in this case here, the ventricular catheter shows a lot of adhesions and connective tissue which grows into the openings of the ventricular catheter tip. So obviously there's a high risk here for blockage of the tip of the ventricular catheter due to this connective tissue which grows into the ventricular catheter. Here, actually it looks like small vessels. Further down, when you forward the endoscope, it looks like just connective tissue blocking the perforations of the ventricular catheter. Again, here you see the vessel. I think this is a very stunning view of the intraventricular catheter anatomical situation. So now, after we have learned what is the tool we talk about, what is the indication, how to apply it, now we discuss results and risk. In about a 10 years period, we did more than 200 procedures with the application of the shunt scope. Today I will focus on shunt scope applications in children. So 69 shunt scope assisted procedures were done in children. 53 children, 36 male and 7 in female. So a total of 16 cases had several procedures. The mean age was 5.3 years, 6 days to 17 years. And this is the distribution of the cause of CSF impairment. So the most frequent indication was tumor and cyst-related hydrocephalus, post-hemorrhagic hydrocephalus, and congenital malformation. What was done with the shunt scope? A shunt scope was applied about 1/4 in shunt revision surgery and about 1/4 for burr reservoir insertion, in about 9 cases, so 13% for aqueductal stenting procedures, and 10% for first-time shunting because it was considered to be difficult, and some other indication. We evaluated the image quality of the shunt scope. You see on the left, it's a sufficient image quality, although it's just a semi-rigid 10,000 pixels shunt scope. On the right side, it's a limited image quality, but still recognizable that we are inside the ventricular system. We also used a grading scale earlier published by Hayhurst. Grade 1 is the optimum position of the ventricular catheter tip. Grade 2 is a suboptimal position, but still in the CSF space with sufficient CSF circulation restoration. But the catheter touches the choroid or ventricular wall and is a little bit too short for an optimal placement of the intraventricular catheter. A grade 3 is a complete extraventricular misplaced ventricular catheter. With this application scale, we had sufficient image quality in about 87% of cases and 13% limited image quality, but in all these cases it was possible to recognize that we are inside the ventricular system. For radiological ventricular catheter accuracy, with a 84% grade 1 position, 16% grade 2, and there was no catheter outside the ventricular system. The optimal ventricular catheter placement, grade 1, was achieved in 83.6% of the procedures, and a good acceptable position with some contact to the choroid plexus, the ventricular wall, was seen in 16.4%. Sufficient shunt scope assisted image quality was seen in 86.9%, and a limited image quality, but still good enough to identify that we are within the ventricular system in 13.6%. The intended transaqueductal stent placement had to be abandoned in one case. In this case, the oil pediatric endoscope was used for placement of the stent under endoscopic view. The proximal shunt failure rate in our series was estimated to be 3.07%. There were 2 shunt revisions due to ventricular catheter dysfunction in 65 procedures. There were no intraoperative shunt scope related complications, and the mean follow-up scored 33.7 months with a range of 1 to 105 months. In conclusion, the shunt scope represents a reliable and helpful intraoperative technique for catheter placement. The correct position of the ventricular catheter results in long-standing sufficient cerebrospinal fluid circulation restoration. Particularly in difficult cases and challenging circumstances, erroneous ventricular catheter positioning could be avoided. The shunt scope is recommended as a supportive adjunct in treatment of hydrocephalus in pediatric patients, and its application should be considered more frequently for experienced neuroendoscopists. We have made a number of publications about our experience with the shunt scope. So, for example, you can look up the Journal of Clinical Neuroscience, 2018, from our group, the view to the ventricular catheter, the new shunt scope for therapy of pediatric hydrocephalus. For example, you can look up Child's liver cyst in 2016, aqueductal stenting with an intracatheter endoscope and technical note. You can look up endoscopic assisted burr reservoir and ventricular catheter placement in joint neurosurgery 2017.
Orange juice.
Or you can look up
Orange juice, yeah.
intracatheter endoscopy for various funding procedures and retrospective analysis of surgical practicability, catheter placement and failure rates, actinic and Ulrica.
Sama je hai, masih same. Ke nak chocolate milk? Fresh milk or
I
chocolate
want
milk?
to acknowledge particularly Dr. Preisner Borak, who did most of the evaluation of the recent cases. I want to acknowledge Dr. Linsler, who is my vice chairman, for his continuous support with the pediatric cases and the endoscopic applications. And I want to acknowledge Dr. Zenger, who is in charge of our endoscopy research group and our endoscopy seminars. Thank you for listening, and I hope we will have fruitful discussion.
We now move to the live session. Unfortunately, there is no time for the discussion. Dr. Liu is going to be our first speaker. He's a well-known skull-based surgeon at New Jersey, at Rutgers, and I would like him to start his talk on infratemporal fossa. Is that correct?
Yes, that's correct.
Yeah.
Okay, can everyone see my screen?
Yeah.
Okay, may I ask the host to please mute the other speakers or panelists to minimize distraction? Well, thank you, Professor Yoko Kato, and thank you, Dr. De Pujari. It's a real honor to be here with you today and to participate in this fantastic webinar on endoscopic neurosurgery summit. I'd like to speak on the topic of infratemporal fossa tumors. And these tumors are very formidable because of their deep surgical targets. And they also often involve very complex anatomy and involve different compartments and important neurovascular critical structures. If you take a look at this Roten beautiful dissection, you can see the coronal plane of the vascular and neurological structures of the infratemporal fossa. This is the sphenoid sinus that you see here with the clinoidal segments of the carotid artery, the pituitary gland, and this is the standard approach to most of the lesions that we treat endonasally with the endoscope, namely pituitary tumors. And as you move down in the sagittal plane, you can access the clivus, the craniovertebral junction, and then moving laterally by using the pterygoid plates, we can access this area more laterally into the infratemporal fossa. You can see this large vessel, which is the imax, that eventually becomes the distal branch of the sphenopalatine artery. And these vascular structures are important to know because this is the primary blood supply of a lot of these infratemporal fossa tumors that you see here. And it's important to know some of the nerves. This is the Vidian nerve entering the Vidian canal, which is a useful landmark in identifying the petrous carotid artery as it joins the foramen lacerum. And this is V2, the nerve that becomes the infraorbital nerve in the roof of the maxillary sinus. And again, that's an important landmark and useful landmark in helping us guide our tumor dissection, and of course the distal branches of V3 in the infratemporal fossa. When we look at the dry skull, these are the foramen that are helpful. This is the Vidian canal, foramen rotundum for V2, the infratemporal fossa. And when we look through this corridor, this is the anterior transmaxillary corridor, also known as the Caldwell-Luck approach. And this is an important corridor to use, and we must not be dogmatic in saying that endoscopic skull-base surgery is only done endonasally, but as you can see from our other lectures, we can consider other corridors like the orbit and also the maxillary sinus, which I think is a very useful adjunct for infratemporal fossa surgery. You can see the maxillary sinus really gives us that corridor to look at the infratemporal fossa, the pterygoid plates, and again the infratemporal fossa. So it's very important also when you're visualizing the coronal plane that you really study the course of the ICA, because this can be a source of potential risk and injury. So it's important to have that X-ray vision that Dr. Roten taught us to have, and really know the course of the ICA. Again, the Vidian nerve is an important landmark that takes you to the junction of the vertical paraclival and horizontal petrous carotid artery, and then allows you to safely access the lateral corridors of Meckel's cave and the cavernous sinus if needed. Traditionally, the infratemporal fossa was well described using the open approaches, and it's important to remember where we came from and where we're going. And so you need to know the traditional infratemporal fossa approaches described by Ugo Fish, A through C. Taka Fukushima modified the concept using the ITF approaches coming transcranially from above. And for the lesions that I'm going to be describing today are mostly anterior infratemporal fossa tumors, namely this area behind the maxillary sinus. And the approach from above is traditionally through an FTOZ approach, where we mobilize the lateral wall of the cavernous sinus and we drill out the infratemporal fossa floor to access this region from an anterolateral approach. Previously, these would be combined with facial translocation approaches described by Yannicka, and you can combine them using these traditional craniofacial approaches with disassembly of the facial bones that you would see here, like the Lefort and the transmandibular variations. And, you know, more recently, we've been really using the advantages of the endoscope, and the contributions of our colleagues in Pittsburgh have nicely described the sagittal corridors, but also the coronal plane corridors to the infratemporal fossa. When we think about going to the infratemporal fossa, if you're doing a purely endonasal approach, there often can be limitations in going lateral. And so to increase the lateral extension, you have to remove the medial maxillectomy, including the inferior and middle turbinates, to really access fully the maxillary sinus. This allows you to get to the pterygopalatine fossa, as well as the infratemporal fossa here. And to get more lateral, you would have to violate the nasolacrimal duct. And this is called the endoscopic Denker's approach, where you remove this lateral portion of the piriform aperture, but there can be limitations, namely due to potential cosmetic sunken defect in the face due to the bony defect in this area, and then also nasolacrimal duct transection, which can result in obstruction and resulting in tearing of the ipsilateral eye. And so this is the area that you would get through that Denker's approach. And the alternative here would be a Caldwell-Luck approach going through the anterior maxillary corridor. And the advantage here is that this really gives you a more anterior view rather than this oblique view that the Denkers gives you. And you definitely have more working room. And also having that second channel, it really gives the surgeon a lot of surgical freedom, so there's less sword fighting of your instruments. Dr. Andrew Little from the BNI nicely described this imaginary line called the send line, where you draw an imaginary line from the anterior nasal septum through the nasolacrimal duct on an axial scan through the lesion of interest. And if the tumor extends lateral to the send line, generally it is more technically difficult to view and access the lateral portion of the tumor, in which case adding a anterior sublabial Caldwell-Luck incision gives you access to that tumor. We published some years ago a cadaveric study looking at the multiple angles of attack, going from uninostril to binostril to adding a Caldwell-Luck maxillotomy, and then coming lateral through a small gillis incision to get to the infratemporal fossa. And we applied the same concept when we looked at our JNA series published here in Journal of Neurosurgery, looking at the use of this individualized, tailored multi-corridor approach, using all of those corridors that I just described. So in this cadaveric study, you could see this is the unilateral approach, uninostril approach. So coming in through a single nostril, you must open up widely the maxillary sinus. You can identify the sphenopalatine artery, the IMAX, and this is the vascular feeders to a lot of these lesions. And then you can find V2 along the roof of the maxillary sinus. Here's a clinical example of a lesion. This is a JNA that can be approached using a single uninostril approach. You can see this was readily removed. The lesion is mostly midline and extends very little extension laterally. And you can see the contralateral right nasal structures have been largely preserved. Here you can see on the CT scan. And so intraoperatively you can see here's the left inferior turbinate, left middle turbinate. We've done here the medial maxillectomy to get control into the maxillary sinus. This is where you can devascularize the tumor, getting that IMAX feeder, and then the tumor here is in the asterisk, and you can see complete removal of the tumor. Here's another example using the uninostril approach. This was a Vidian canal schwannoma of the infratemporal fossa. These are a little bit technically easier, not so vascular as our JNA counterparts, but again, preservation of that nasal structures on the right nostril. You can add a binostril technique for more laterally pointing tumors, and this is created by a transeptal corridor, a mucosal preserving transeptal corridor. So we raise a small mucosal flap, not for reconstruction per se, but really to create a little window, and we can resect the cartilaginous septum to really allow you to get a second instrument through the other nostril to work into the lateral maxillary sinus corridor. And at the end of the surgery, you can bring that septal flap back down and suture it in place. So it's a mucosal septal sparing technique. And I think for neurosurgeons, having binostril access is a lot more comfortable and more working space and less frustration. Here's an example using that binostril corridor with a transeptal window through this JNA. You can see complete removal here. This is the example showing that transeptal corridor too. We've made a mucosal flap ipsilaterally, resected the cartilaginous septum, and then continued the septal flap contralaterally. And these septal mucosal flaps are offset, meaning they're not in the same plane. So when you suture them back together, you have good coverage of the septum without a septal perforation. So we've opened up the posterior wall of the maxillary sinus, identified the fat pad in the infratemporal fossa, and that's where we can find the IMAX feeder and coagulate it. Now, even though these tumors are largely embolized, you still have to coagulate that maxillary feeder because these tumors are often still very vascular despite great embolization. So once you devascularize it, the tumor becomes very avascular. It's much easier to dissect and debulk. Here we're delivering the tumor from the inferior orbital fissure. You can see these tumors tend to have little fingers that erode through the bone of the skull base, creating little pockets of tumor that you must follow. If you amputate it, you'll leave nuggets of tumor left in the skull base. Now on these large tumors, I like to compartmentalize them and divide them into zones. So here we're removing the midline nasopharyngeal portion, and this is midline, so we can remove the tumor. Now this large part going into the posterior nasopharynx was a bit too large to deliver through the nose, so instead we push the tumor down into the posterior nasopharynx, into the oral cavity, and then we can grab the tumor through the oral cavity and deliver it there. You can see this would be difficult through that little nostril to deliver, so having that oral cavity is very nice, and you can see a nice complete removal. Here's the oral pharynx and the reconstruction of the septum here done by my ENT colleague Dr. Eloy. You can see we put the cartilage back in place, and we can suture it using the Keith needle, and then using a mattress suture to suture the mucosa back in place. So this is a nice mucosal sparing septoplasty technique. Now for more lateral tumors, it's very useful to add the maxillary sinus through a sublabial incision and park your endoscope in here, or even use your instruments in this corridor to give you that more lateral view of the lateral maxillary wall. Here you can see the send line. You can see this tumor extends more lateral to the send line, so adding an anterior maxillary corridor is quite useful. You could see, looking here through the right nostril, here's the right inferior turbinate, here's the tumor, and then here's the nasal septum. Here's the floor of the nose, the hard palate. And on the contralateral side, you could see the tumor is displacing the septal mucosa contralaterally. And so when we look through the endonasal corridor, look how the tumor is way lateral here. This is the lateral portion of the tumor, but look how the view to the tumor is, it's a bit awkward because your instruments are really restricted to the line of sight of the nasal corridor. But when you add a sublabial maxillotomy, we're looking through the nasal corridor now with the endoscope, but now we're using the instruments in the maxillary sinus. Look at the direction of the angle of attack using the suction there. You see how like there's more room, there's more viewing space with the endoscope, and then we have a second corridor to put the working instrument through the maxillary sinus to get lateral control of that tumor. You can see again, this is a beautiful view of the lateral maxillary wall. And then we can go ahead and use this multi-corridor access to our advantage to take out the tumor and expose the skull base. So you can use this multi-corridor concept in a variety of ways. You can put the endoscope directly in the maxillary sinus and use your instruments in either corridors, or you can park the endoscope in the endonasal nostril corridor and then continue to use the instrument. So there's a lot of variability on how you can use this principle, and there's the tumor being removed from the nostril. And this is the final view, a nice panoramic view. Here's the midline skull base of the sella, but the infratemporal fossa resection bed back here. And you can see here's the post-op scan, a nice complete removal of the tumor. Now, for JNAs that have some intracranial extension, large majorities can be done endonasally with a maxillotomy from below. But in some cases where the tumor starts to involve the cavernous carotid artery and superior orbital fissure, my preference is to add an open approach from above with an FTOZ and peeling technique. And the reason why I do this is that if you do this purely from below, there is that risk of carotid artery injury. But when you add the approach from above, the main idea is that you have early control of the cavernous ICA. So let me demonstrate this for you. So we do a standard extradural FTOZ. We divide the meningo-orbital band, and we start to peel and unlock the cavernous sinus the way Hakuba had taught us by peeling that lateral wall of the cavernous sinus away from V1, V2, and V3. We then decompress those foramen. This is the foramen rotundum. Decompress. You can see the tumor has now been exposed. And the idea here is that we're peeling the tumor away from the cavernous ICA and the cavernous sinus, and we're pushing the tumor into the infratemporal fossa. And by doing this, we've now isolated and gained control and protection of the ICA, so that when we now come from below, we have more confidence that we're not going to see the ICA last, that we've already established control of the artery, and now we can have more confidence in removing the tumor from below so that we don't risk that dreaded carotid injury. So now we're going back and removing the tumor in compartments. Here I'm removing the midline component of the tumor, and now I'm accessing the lateral component of the tumor using this, adding this Caldwell-Luck dissection. There's V2. There's a small branch of V2 overlying the tumor, but the main branch of V2 is still preserved, that you can see right here. And now the tumor is being dissected from the infratemporal fossa. This portion of the tumor eroded through the hard palate, extending inferiorly. So we lift up the tumor, cauterize those last feeders, and we can deliver the tumor from that second window of the Caldwell-Luck maxillotomy. There's the temporal lobe dura, there's V2, and then there's a nice beautiful view of the infratemporal fossa resection bed. This is the pre-op. Here's the post-op, and the patient did quite remarkably well. Just a little bit of V2 numbness, and this is very well tolerated, and we see this often with these infratemporal fossa tumors. So you definitely want to minimize any trigeminal neuropathy post-op. Here's another example of a multilobulated JNA. Again, this tumor you can see was extending through the superior orbital fissure against the lateral wall of the cavernous sinus. Here I did this through a staged approach, and keep in mind when these tumors start to invade intracranially, you must do the angiogram, and in this case the angiogram showed feeders not just from the external but also feeders from the cavernous ICA. And these tumors tend to be more difficult because when the feeders are coming from the cavernous ICA, those feeders generally cannot be safely embolized for the fear of embolic strokes from the internal circulation. So you end up having a very vascular tumor with potential considerable blood loss. So in those cases, you have to be ready to stage your surgery, which is what we did here to minimize the blood loss. This was another one of these very hypervascular JNAs that would just bleed profusely because there was multiple cavernous ICA feeders that could not be embolized, and so we had to do this in multiple stages. The first stage was done through an endonasal transmaxillary approach, and we were able to debulk the tumor mostly in the infratemporal fossa, but because of blood loss we had to stop and come back and fight another day. And so the second stage we did was a modified OZ to control this intracranial portion of the tumor and then to protect the cavernous ICA. And then lastly we came back for a third stage for an endonasal resection, and we packed off the nose. When we're packing off the nose, I find using Vaseline gauze very useful. It actually helps control hemostasis quite well when we're working with these very vascular tumors. And then you leave a long length of the gauze, and so you can remove it as you're removing surgical gauze packing. And then lastly, we did a fourth stage with some minor residual, but also to take the remaining packing out and to look for any residual disease. So when you stage them, it's safer. You don't lose the patient on the table from blood loss. You have to keep in mind for pediatric patients the surgical blood volume, and to work with your anesthesia team to make sure that they don't fall behind. But you know, with persistence and planning ahead with your team, you can achieve this kind of result for these treacherous tumors and get the patient into safety. Here's an example. This is a different kind of tumor. This patient had leukemia as a child and underwent radiation therapy. You can see she's developed multiple radiation-induced tumors, with this large one involving the infratemporal fossa. I always study the CT angiogram looking for the course of the ICA, and I can use the CTA as the source of the image guidance merged with the MRI images. You can see how this tumor is eroded through the middle fossa floor and really has close encounter relationship with the clinoidal segment as well as the petrous segment of the ICA. So we use this concept of multi-corridor surgery, adding this endonasal corridor where we park the endoscope in the right nostril and then use the contralateral nostril and Caldwell-Luck window to move our instruments. And this really maximizes the surgical freedom for the surgeon and minimizes the sword fighting and instrument collision. So here we've done the Caldwell-Luck maxillotomy through a sublabial incision. We're drilling off the posterior maxillary wall to expose the tumor, open up the sphenoidotomy in the usual fashion, and very important to peel the mucosa from the sphenoid sinus so you can see the osseous anatomy and any clues of where the carotid artery can be. Important to use a microdoppler. This helps you confirm the force of the carotid artery so you don't injure them, the infratemporal fossa. And we use this caudal elevator to peel that tumor periosteal plane. There's often a plane in this area, and we now can go after the intracranial extension of the tumor. Fortunately, this tumor was a little bit softer and was amenable to suction and debulking. And here's the middle fossa dura. Instead of resecting the dura here, I decided to get a Simpson 2 resection and just to coagulate the dural attachment using this device. And then there was a small defect in the middle fossa dura. We plug it with alloderm, similar to the way we treat encephaloceles, and we can rotate a contralateral nasoseptal flap. And you can see this is a panoramic view going from coast to coast, from one maxillary sinus to the contralateral maxillary sinus to get this nice panoramic view. Here's the complete removal, post-op day 1, and this is all extradural surgery. She went home on post-op day 2. And lastly, I'll show you this case. This was a 44-year-old female presented with right proptosis, some right visual loss and facial numbness. You can see there's a large mass here in the infratemporal fossa, eroding the middle fossa floor. You can see again the erosion of the middle fossa floor and central skull base. The petrous ICA canal here is eroded and is involved in the posterior portion of the tumor. And then there's some intracranial extension, but also erosion of the right optic canal and erosion and displacement of the orbital floor. Here's the optic canal. and you can see the orbital floor erosion causing this proptosis. And on the MRI scan, you see a brightly enhancing lesion here, extending intracranially. So this was initially biopsied endonasally, which was confirmed as a schwannoma rather than a malignant process. So again, when we talk about the concepts and when we think about surgical planning, we initially considered the binostril endonasal approach, but you can see if you look at the send line, a large majority of the tumor goes all the way anterior to the anterior maxillary wall and all the way out to the lateral maxillary sinus. So an endonasal approach would be quite limited. And if we add the Danker's approach, again, this is the zone of exposure that we would get. You would end up transecting the nasolacrimal duct, but also have the risk of cosmetic deformity of the lateral nasal ala. This is also a very awkward working angle, getting instruments out laterally through just 2 nostrils. And so if we add the Caldwell-Luck exposure, this is the kind of working corridors that you get. You have 2 corridors and you have a direct head-on approach to the target. It's more natural and less awkward for the surgeon with these obtuse endonasal angles. So we apply again this concept of multi-corridor, multi-portal surgery. We park the endoscope namely in the middle and work in the 2 corridors to avoid the sword fighting. This video now shows the sublabial exposure. It's just an incision in the sublabial mucosa, which heals very, very well. Patients just get very mild numbness in the right upper lip. But we expose the anterior maxillary wall here, doing a Caldwell-Luck maxillotomy. And you can see the tumor is already there. It's very anterior, just right underneath the bone. The bone was quite thin. The endonasal phase of the exposure here, the typical medial maxillectomy, removing the inferior and middle turbinates to expose the tumor in the maxillary sinus. We can also do a nasal septoscopy to get the binostril access as well. So here we are devascularizing, debulking the tumor using a microdebrider. And we can work again in the sublabial maxillary corridor and cauterize the tumor using a suction bovie. Alternatively, you can use a endoscopic bipolar as well. And remember that the tumor had eroded the posterior wall of the maxillary sinus, so that the posterior wall of the maxillary sinus was elevated up to the region of the orbit. So you see this thin piece of bone here? This is actually the posterior maxillary sinus wall, and it's juxtaposed to the orbital floor. So the tumor arose behind the wall of the maxillary sinus, probably maybe a Vidian nerve schwannoma. But you can see we can use that remnant of that wall as a plane of dissection to peel it from the orbit to avoid any orbital injury. And so we can peel the tumor away from that maxillary wall. There's the posterior maxillary wall, a remnant of that floating island of bone. And as we work backwards, we can again debulk the tumor further using ultrasonic aspirators. And then we can now use the endonasal view looking laterally. You can see we don't have as good of a lateral view here, but a much better medial view using the nasal corridor. And then we can switch back to the anterior maxillary view. We can see we have more lateral control here over the tumor. So again, you can use these corridors in a multi-variable fashion, working back and forth, whichever is the best view for you. So it's nice to have options. It's nice to have options of better surgical freedom, improved viewing angles, and more versatility. So I think it's important not to be dogmatic to say that endoscopic skull surgery is only done through the nose. We have to be able to use other working corridors to our advantage. So there's the middle fossa dura, there's the infratemporal fossa. And the last portion of the tumor is here up superiorly into the nasopharynx. And then here we're delivering it through the nostril corridor. And this is the last portion of the tumor that's removed. Again, using that compartmentalization of removing tumors in a piecemeal fashion. And there's the view of the skull base. There's the middle fossa dura, the choana, and the infratemporal fossa. This is all extradural, no CSF leak. I put a piece of alloderm, and then we reconstruct with a septal flap here. And we put some Vaseline, bacitracin ointment posteriorly to help keep the nose from being dry, and a bit of nasal packing here. Now, the tumor had caused a iatrogenic Danker's defect, so we put a little plate here to reconstruct the piriform aperture to prevent any cosmetic sunken nose effect. And the closure of the sublabial incision is very readily done through a absorbable stitch, and this incision heals quite quickly, and the patients do quite well from this. So you can see here's the post-op scan showing complete removal of the tumor, only some mild V2 numbness, and the patient did very well with improved vision and reduction of her proptotic eye. So in conclusion, the endoscopic and nasal approach is useful for the resection of infratemporal fossa skull base lesions, and for the ones that extend more lateral, I believe the addition of the Caldwell-Luck maxillotomy is a very useful adjunct when combining it with EEA. It really has the advantages of the multi-portal, multi-corridor endoscopic skull base surgery principle, and it really maximizes the surgical freedom for the surgeon so that you have less sword fighting with instrument collision, and you can also combine it with transcranial approaches if needed. And so it's really important that, I think in this era, even though we're pushing for endoscopic surgery, you have to master both traditional open approaches to be a contemporary skull-based surgeon, because sometimes you have to apply both approaches using multi-corridor surgery, and you really need to have a great team, and I'm blessed with my team here in skull-based surgery. And thank you for your attention. I'll be happy to answer any questions.
Thanks, Dr. Liu. I think it was wonderful exposition of what can be done not only with endoscopy but with the extended corridors. One of the applications which we have used in is the residual actually trigeminal schwannomas. Many a times the infratemporal fossa component is not effectively taken out by a transcranial approach, and even there this can be quite useful to go through the lateral corridor to get the residual tumor. Or a couple of times we have had to do it for recurrences which occurred predominantly in the infratemporal fossa. You have any experience with trigeminal schwannomas?
Yeah, we do. I think trigeminal schwannomas are interesting because when we talk about trigeminal schwannomas, we often think of them as the dumbbell ones that are in the posterior fossa and Meckel's cave, and those ones I generally prefer a transcranial approach through a Kawasi's approach or FTOZ approach. But when we think about trigeminal schwannomas, think about the different divisions and branches of the trigeminal nerve. If you look at the classic Gray's anatomy diagrams, these branches extend all the way into the nasal cavity along the roof of the maxillary sinus, and they can occur anywhere, even like the distal branches. So they can often occur in various areas of the sinonasal cavity and infratemporal fossa. So for those lesions that are primarily extradural, I prefer the endonasal approach. And so we've done a number of these that are namely in the Vidian canal or in the infratemporal fossa nasal cavity, like the last case I showed you. And for the Meckel's cave one, I look at the film judiciously, or I choose.
You have been muted, Dr. Liu, for some reason.
Sorry, did you
No,
hear any?
we didn't get you last 1 minute.
So what I was saying is the different branches of the trigeminal nerve can occur, anywhere along the brainstem, all the way out.
Meckel's cave was where we lost you.
Meckel's cave, yeah. So I think for Meckel's cave tumors, I think those can be. I tend to be judicious as to choose whether an open approach or endonasal. We certainly have done both, and I think the challenge is always predicting which side the cranial nerves will be on. If the tumor presents itself so that you see tumor first from the endonasal side, those tumors tend to be favorable to remove endonasally, as opposed to on the lateral side, which I think transcranial approaches tend to be easier for those.
Thanks, Dr. Oyama. You have any comment or a question? You have to unmute yourself first.
Hi, James. Thank you very much for your beautiful operation. We can really understand the utility of the multiportal surgery to the infratemporal fossa tumors. I have one question. You showed us the technique for reconstructing the nasal septum. Is it always necessary for reconstructing the nasal septum?
I don't think it's always necessary, but sometimes you have tumors that are destructive to the nasal septum, and of course, in those cases, you cannot reconstruct. But I think in the cases where you can still try to preserve the anatomy, it's always a good principle to try to preserve as much normal anatomy as you can, as this can help the patient from a functional sinus standpoint.
Thank you.
Sebastian had joined us. Any comments or experience in infratemporal fossa surgery, Sebastian?
Thank you very much. It's very nice to see you all. James, fantastic presentation as usual. Kenichi, it's great to see you. I have a question. Have you tried the prelacrimal approach for those tumors? You just drill a corridor in front of the lacrimal canal, and you push the medial wall of the maxillary sinus medially, preserving the medial wall without extensive drilling of the piriform opening.
So this is it's kind of like the Denker's type concept, except you're not removing this portion. Is that what you're?
Yes, and you're not pushing the approach laterally on the piriform opening, but you're pushing it a little bit medially, trying to push medially the medial wall. I have tried it once, but with the ENT for maxillary sinus pathology, and I know that Dan Prevedello has published something about it, and I was wondering if you have some experience with it.
Yeah, I don't think I've had experience purely with that approach, but I do have some cases. I recall a recent case of a sinonasal chondrosarcoma that had lateral extension where we didn't come through under the lip, but we pushed it, through the nostril corridor in that fashion. But we did go through the nasal lacrimal duct, but just below it, and trying to get lateral extension. And with the angled scope, we were able to visualize the anterior maxillary margin of that.
I have the feeling it could be a good option, for preserving the medial wall and avoiding. It's probably something we have to study more.
So you're saying that you can preserve the medial wall of the maxillary sinus through this approach?
Yes, I have the feeling the ENT have been using this approach for maxillary pathology for quite a while. It's not something new for them. And they are mobilizing the medial wall, you know, pushing it medially to extend the corridor and preserving the lacrimal canal. You can expose it to the roof and mobilize it without injuring it. And I think it's a reasonable corridor. It's not much less than what you have with a Caldwell look. I have this feeling. Something to work together on it.
Thank you for opening my mind to that concept. I will explore it further.
Thanks. So do we go for the next one? We have 2 additional talks in this session. So thanks, Dr. Liu. And I think next probably I'm supposed to be talking. So are you doing the video? Sachin told me you are presenting the video. That's why I have not shared the screen. Got Dr. Venkatramana's talk. You can go ahead, no issues.
Can I go ahead?
Yeah, please do. Dr. Liu, if you can find my talk, otherwise I'll get it on my.
Ben, you need to on the sharing. Hello, ask Ben to on the sharing. Ask Ben to on the sharing, the website sharing now.
Oh, the website sharing. Okay.
Yes.
Okay, sure.
Okay.
Hello. Okay. I'll sharing the website. Yeah, can you hear it?
Hello. Hello. I don't. No. Yeah, I don't think it's running from the website now, Did Ben or you download it?
Yeah, I'm here. So you don't see the website? So it's not on the website, Liu?
Yeah, it's not on the website, but if Prof has his copy, Prof can run from your computer. Otherwise, I can try to run from my computer too, Prof. Yes. No, not done. Did Ben have the copy of it?
I think I get a PowerPoint from a section, but it's not a video.
No. There is another talk. One moment.
Welcome, friend. It is my great pleasure
to have you for this WFNS Foundation, ACNS, and ISMIN's Web Summit for 2022, which has been kindly organized by Dr. Yoko Kato and our colleagues all over Asia. We have many international participants who are stalwarts in this, and friends, it is my great pleasure to have you for this WFNS Foundation, ACNS, and ISMIN's Web Summit for 2022, which has been kindly organized by Dr. Yoko Kato and our colleagues all over Asia. We have many international participants who are stalwarts in this, and my job today is to talk about endoscopic management of Rathke's cleft cysts, a relatively rare disorder, but sometimes presents a dilemma in management. Endoscopic management of Rathke's cleft cyst has become now a standard of care, as most of you know. These cysts are most common incidentally discovered cellular pathologies apart from pituitary adenomas, and in routine autopsies they encountered in about 13 to 33% normal pituitaries in different studies. In a retrospective review of 2,500 subjects undergoing at least one pituitary MRI scan in a span of 10 years from 2000 to 2009, almost 80% of
the video is not moving. Cellular masses were seen, and out of which the most frequent were Rathke's cleft cysts. Cyst arising in Rathke's pouch or cleft is a benign non-neoplastic cyst which originates from the congenital remnants of the Rathke's pouch, and many of these lesions are purely cellular. Some are with supracellular extension, and there are very few which are exclusively supracellular. Most of the lesions are asymptomatic, but you find several times that they come either as a diagnostic dilemma, or some patients really come with clinical manifestations. Obviously, the clinical manifestations are in terms of visual and hormonal disorders, and one of the main reasons why diagnosis of Rathke's cleft cyst has become very common these days is because of improvement in imaging techniques, and accurate preoperative diagnosis can be achieved in 80 to 85%. Though cystic pituitary adenoma, apoplexy in a microadenoma, and a rare possibility of craniopharyngioma still exists. Indications for surgery and how to operate on these patients is evolving. There is a nice paper from NIMHANS India which talks about, is it really necessary to diagnose Rathke's cleft cyst preoperative? The main reason why we need to diagnose it is probably that we know for sure that we can tackle this lesion by transsphenoidal approach, and therefore better definition we have, better idea we have as to what we are dealing with, makes it easier for you to preserve the pituitary and probably prevent CSF leak, which are important factors in postoperative management. Headache is one of the most common presentations, especially in young children and teenagers. The subjective quality, site, and severity of headache sometimes can localize you to a pituitary lesion, but sometimes it is very vague. And perimetry and acuity testing must be done, of course, before surgery. And pituitary hormonal assessment should be done because some patients may already be hypothyroid. There are very few cases reported where there may be hypersecretion along with the Rathke's cleft cyst. Neuroimaging consists, apart from MRI, a CT-PNS, which gives you a better idea of bony anatomy, how to reach there, and if there are going to be any difficulties in your reaching the sella or in that area. So as we were talking, I think the main indications for surgery are really the chiasmopathy, documented progression in the size of the cyst, documented progression in hypopituitarism may be considered as an indication but is not uniformly accepted, and headaches which do not respond to any other treatment, and occasionally you may have to do it because of uncertain diagnosis. The objective of surgery remains evacuation of complete contents of the cyst and excise the wall without inflicting any damage on pituitary gland and optic apparatus. Out of the 80 patients we have seen, we have operated on 38 of them over the last 16 years. All 38 patients underwent transnasal surgery, except for first 2 cases where it was endoscopic assisted microsurgery. Rest of the patients were operated by purely endoscopic endonasal approach. In 21 patients, it was predominantly sellar region, which requires standard transpyramidal surgery with transpituitary approach, while 16 were suprasellar, and these were treated without pituitary manipulation by extended transpyramidal approach. So this is one of the classic cases, a young lady with this kind of a cyst. You can see that the surrounding normal pituitary can be seen, and the lesion is confined to diaphragm ocellus, so sellar cyst. And this lady actually presented with a mild hypopituitarism, was recently married, and started getting intractable headaches with some visual blurring. Abnormality. Her headaches were so severe, and she wanted to have children, and she was told that she may have difficulty because everybody thought it was a sellar pituitary adenoma, and therefore we went ahead with the surgery. You can see that the sella is opened. You can see that an incision is being made between the anterior and the posterior pituitary. You can see that the cyst contents are slowly oozing out as soon as I have made an opening into between the anterior and posterior pituitary. And you can see that the cyst is coming out nicely. With silver dissector, we can try to take this out. And you can see that the whole cyst is coming out through this area. The whole anterior pituitary is forwards and the posterior pituitary is backwards, and the whole cyst has been taken out by this way. You can see the residual cavity, and that there is no there was no problem with hemostasis, and this patient remained hormonally intact, and she actually delivered a child about 2 years after this surgery. This is the postoperative scan, which shows complete excision of the cyst and restoration of the chiasm and normal anatomy. This is another patient where you can see that the cyst is going into the suprasellar region as well, and similar kind of a surgery. We go from carotid to carotid. Here I do not make a standard opening like pituitary, but make an opening enough to get between the cleft between the anterior and posterior pituitary, and you can see that there is a kind of a concretions. This is a like a dried cyst, and you can see after the cyst is removal, you can see the right ICA, left ICA, and the pituitary stalk. And this patient remained mildly hypothyroid, but otherwise recovered quite well in her headaches as well as in her chiasmopathy. Sometimes you may need to resort to extended endoscopic procedures, like in this child who presented with this cyst, which was predominantly going into the frontal area, and therefore we decided right in the beginning to have an extended approach. This child, because of the black spots, was thought to have probably a craniopharyngioma, and when we went for surgery, we went prepared to deal with a craniopharyngioma. However, you will find one of the anterior cranial fossa. The sella is being drilled. About half a centimeter of anterior cranial fossa is being drilled. The thinned out bone has been exposed, and then we are doing an extended procedure to go in front of the anterior intercavernous sinus. Oh. The anterior cranial fossa is being exposed for about a centimeter. Then you coagulate the anterior intercavernous sinus, and the cyst is right in front of you. The pituitary is just behind you, and the cyst is gradually getting separated after partial decompression. You can see that some cyst fluid is coming out, cyst is getting decompressed, and it is being dissected out with blunt dissection. You may need to use sharp dissection for some time, like we did it now. You can see some calcification in the wall, which can occasionally be present even in a Rathke's cleft cyst. And therefore, sometimes it is difficult to determine it from craniopharyngioma, and you can see that the stalk is intact behind and the adherence to pituitary is being dissected. And the last portion of the cyst is now coming out. Should the cyst wall be removed or completely or not is controversial. Most people feel that if it is a thin wall, it usually can be, you can take a biopsy, or you can make it open to the exterior, but you do not have to remove it completely, while a thick wall like this one, which can be shelled out nicely, can be done so. So whenever there is a CSF leak, we repair the sella in 3 layers. We try to put the bone there. We try to put some fat and then use the Haddad flap to close the defect. So these are the steps of surgery. And this is the postoperative scan, which shows the complete excision. The postoperative signal is intact. The patient had transient diabetes insipidus, which gradually cleared up over about a year or so. We have written about our experience of first 30 cases in World Neurosurgery a few years ago. One of the main factors which has been talked about is what happens after treatment of this cyst. If you leave the part of the cyst wall behind, or if you remove it completely, is it necessary to remove it completely? And this is a single series, large series, which shows from California, which shows retrospective analysis of 109 cases operated over a span of about 20 years with a mean follow-up of, this is probably the longest follow-up series, which talks about follow-up of almost 6 years or so. And they have shown that in this period, about recurrence or progression of the residual cyst happened in 29 cases, which is like 26%, with an average latency of about 2 years. And of these, only 10 patients, like 9% of the total series, were symptomatic, and only symptomatic patients underwent reoperation. Dr. Liu has done a meta-analysis of more than 1100 cases between 1990 to 2012, which have been treated variously as subtotal resection, gross total resection, and complete drainage only with wall biopsy. There are 2 important findings which is trying to point out is that since the endoscopic era has come, the recurrence rate has dropped from 14% to 8%, and new endocrine dysfunction has also reduced considerably from 25 to 10%. In addition to that, he feels that there appears to be no conclusive evidence that more aggressive resection of the cyst wall results in lower recurrence, were almost the same in all the categories. One of our experience of recurrence, this is a 28-year-old man who came with hypopituitarism and visual disturbance to me. And we did this scan and we thought we should be able to get this with an extended procedure. And you can see that we got a nice exposure here. We are opening the in front of the pituitary. We have been able to separate it from the normal pituitary to start with, and some dense colloid material is coming out from the cyst. I have opened the suprasellar component, and you can see that the thickened stalk is in front of me. What we failed to recognize on those pictures, that you can see anterior cerebral arteries, etc. You can see the infundibulum, which is dilated in front of you. We went from one side and removed this cyst as much as was possible, but we knew that we had left some cyst behind. And when we closed this case, postoperative scan looks fairly good, and the patient was relieved of his headaches as well as of his visual problems. However, within 6 weeks, he came back with further visual deterioration, and then we decided to drill the posterior clinoid and go from what is called the retro-infundibular approach, or clival approach, or dorsum sellae approach, where you take out the dorsum sellae, go into the interpedunculaar fossa, as we are doing here behind the infundibulum, and then try to remove this cyst completely, which we could manage to do it by this approach. And you can see that we are getting the anterior wall of the cyst also, and the whole third ventricle is empty at the end of removal of this cyst completely. So we have found that in thick cyst wall, it is probably important to remove the cyst wall, even if you have to take another approach. Could this have been done by single approach? Probably if we had realized the position of the infundibulum preoperatively, we could have done a direct transclaval approach to begin with. The whole cyst has been taken out now from the third ventricle, as you can see nicely. And this is the postoperative picture. This patient required thyroid and cortisol supplements, but he has recovered well and he is back to his job. Now, there is another point of view which says that the long-term recurrence in Rathke's cleft cyst is not only determined by the residual wall, but it is also by the histology. Whenever you find that there is increased metaplasia, you have probably more chances of recurrence. So squamous metaplasia was thought to be significant, while there is another contrary view where they have showed that squamous metaplasia may not be so important. Now, I think on the whole, we can probably say that thick walled cysts need to be removed completely. And if you have metaplasia, you need to probably follow this patient more closely. There is another technique which has been described by our colleagues recently, which is of marsupialization. And whenever you do not have CSF leak, I think this is a very good way, rather than trying to extirpate the whole cyst wall. You can probably marsupialize the cyst and line it with a mucosal graft, so that if there is any kind of a recurrence, it can drain into the sphenoid sinus. So this is one of our recent patients, and you can see that the whole cyst is presenting in front of you. Once the cyst has been drained, you can see some sort of granulomatous tissue. We thought for a moment, could it be craniopharyngioma, but it was diagnosed definitely. And then we knew that we could not remove the whole cyst wall because it was stuck to the pituitary. And therefore, rather than closing this, we have actually made a marsupialization, lined the cavity with mucosa to drain into the sphenoid sinus. We will be removing this gel foam later on. And then we have not put the bone back and allowed it to drain further. And this is a scan at 3 months, which showed complete drainage of the cyst, and no enhancing cyst wall is seen, at least on this scan at the moment. A similar kind of a procedure has been described recently by our Japanese colleagues, and the marsupialization method for RCC, they have also shown that it is quite effective in the 14 patients which they treated this way. And in 9 patients where they did by conventional approach, 2 of these patients required repeat surgery. So I would like to end with saying that symptomatic Rathke's cleft cysts have a wide spectrum of clinical and radiological features. Surgical indications are still a little controversial. Endonasal endoscopic approach probably gives you the best scope to remove the cyst completely. And surgical intervention is definitely important in giving dramatic relief from headache and visual symptoms, but improvement in pituitary function is unpredictable. Thank you for this, and I'll be very happy to take any questions.
Dr. Depujari, thank you for a very nice comprehensive presentation on Rathke's lesions. I wanted to ask you, you know, I've sort of changed my paradigm after the meta-analysis in terms of simple drainage versus aggressive resection. However, there are those cases that we've encountered, and you've alluded to them, with the ones that have a higher tendency to recur, especially those ones with more thickened cyst walls with some metaplasia, and sometimes I've seen these xanthogranulomatous type features noted on histology. What is your strategy for those that tend to recur but multiply recur even after simple drainage multiple times, and they start to form a very thickened inflammatory cyst wall?
Fortunately, I have had only one recurrence, which case I showed. And I think you are absolutely right. When you see such granulomatous kind of cyst and thickened cyst wall, though it is adherent, it is many a times possible to, peel it off eventually. And it is probably worthwhile doing it. There have been suggestions that you can probably apply some, alcohol or some kind of toxic substance. But the main worry, especially in young patients, is that you probably would make them hormonally worse. And therefore, should we really be scraping it out all out, and should we be applying any of these toxic substances? I'm still not sure.
I have one more comment. I've also seen spontaneous regression of some of these cysts. I've had maybe 2 occasions where the patient was scheduled for surgery and a preoperative image was done for image guidance, and the lesion had actually spontaneously regressed or gotten smaller, and it tells me that these can be dynamic, and I'm wondering if you had experiences with those as well.
So I'm not sure really. I think these are the kind of patients, some of them actually present very acutely, and many a times the MR report, the imaging people report that patient has probably bled in a microadenoma. And these kind of patients, I think probably may go shrinkage of the lesion. But you are absolutely right. I mean, I think your threshold of taking this patient for surgery has to be really very high. As you can see, less than 50% of our patients actually came to surgery. Have I seen any regression in the cyst? I think I have had one patient where I have seen that there was a marginal decrease, and patient felt better, and she was hormonally intact and visually intact. So we decided not to do anything. But I have not seen a dramatic decrease in the cyst under observation. For the thick walled cyst, as I showed in the last case, the previous question, I think if you are not opening into the CSF space, maybe it is easier to, sort of morcebulize them rather than completely scrape them out. That is the one option I am seriously thinking of nowadays.
I believe there was a recent paper from a group that I came across where their technique of marsupialization included placing it was either a free mucosal graft or a small nasoseptal flap, similar to what you do for cholesterol granulomas, where you keep the marsupialized surface mucosalized to keep that open.
I think that sounds a good technique, as I think, and it would certainly promote a more natural kind of healing. So that is an attractive proposal. You have any comments, Dr. Frolish or Dr. Oyama, before we move to the next one?
No, it was a very nice overview. It's a difficult lesion to treat. It's always difficult to know what's best for the patient, and the interesting subject because it's not very clear in the literature what we should do. But it's nice to hear about it. because it's something we face quite often, in fact.
Thank you for a great presentation. For me, the lactose cyst is still a challenging region to cure completely. So I'm still wondering whether we have to do to treat the cyst. Actually, I'm doing always do just aspiration of the contents and use sphenoidal mucosa to create the drainage route. It is you showed the paper from the group in Japan. I think, in my opinion, it's one of the good options for treating the lactose cyst. Thank you so much.
Yes, Venkat.
I think just drainage of the cyst is a good option for those young people who would like to conceive and continue their reproductive life. And little elderly people who completed their family obligations is maybe worthwhile to remove the capsule if it is possible, but not at the cost of compromising the pituitary. So,
thank you. Azmi, we move to the next one presentation. I think Cleopatra is not here, so.
Sebastian Flores should be the next presenter.
Samir and Venkat. I think Sebastian is the next.
Yeah.
Perfect. So I'm going to share my screen. It's okay. I was not completely sure of how much time I have.
How much time do you want?
No, how much do you want to give me?
25 minutes is ideal.
Okay, perfect. Because I read 40 minutes and I could not listen to myself for 40 minutes. So, so 25 will be fine. Thank you very much.
Thanks.
Okay. So here it is. Yes. So the subject of my talk is chordoma, and as you know, we have a significant experience in Lariboisière with this approach. Bernard Georges, my predecessor, was the one who really built all this practice, skull base, and unfortunately, as you know, he passed away not so long ago. I am just trying to follow his steps. And one of the things I figure out when I started to treat those patients is that the side effect of the surgery, of what we do as surgeons, is somehow significant. And I think one of the goals we should try to achieve is to reduce definitely the surgical footprint of what we do. And this is the purpose of developing endoscopic endonasal technique. As you know, gross total resection remained an extremely important goal in chordoma. So it's probably until now the goals that we should have in our mind as a priority before trying to reduce the surgical footprint. Proton beam therapy is the best treatment. We use it most often for our patient, but it also has some side effects in terms of healing of the surgery. When you put proton beam therapy on the top of an extensive endonasal resection, the side effect of endoscopy, endonasal approach is worse, definitely. So endoscopic endonasal approach has been a revolution. We all know that. We are talking a lot about it, and it provides definitely a lot of options, new options for those midline tumors. And it was great for chordoma patient because it's a midline tumor. So definitely we have used this approach a lot, and we were probably one of the first team really going into it with extensive approach, trying to take most of the chordoma out through the nose, and it was good. And compared to what we were doing before, there was a huge increase in the use of endoscopic endonasal approach. But there is limitation with it. It's a narrow space. The endonasal cavity are very narrow. It's a midline corridor. The nasal cavity brings you midline towards the clivus and sella, but not really laterally. Every time you need to go laterally, you need to do something more in the nasal cavity to have more exposure. It's an approach based on resection more than mobilization. If you need to go laterally, you need to resect tissue. You cannot transpose structure like you would transpose the temporalis muscle to do a pterional craniotomy. In the nose, you need to resect. CSF leakage is still an issue. And definitely, you need a very strong suction because suction is the most important tool into the nose. Rapidly, if you don't have a suction, you're extremely limited with what you do. So there is limitation with endoscopic endonasal approach. Risk of vessel, nerve injury every time you go laterally. CSF leak if you have an extensive opening of the dura. And every time it's extensive laterally, the chance of achieving a complete resection of chordoma, including the soft tissue, the soft part of the tumor, but also the bone infiltration are going down. We know quite well now the morbidity of this approach. Obviously, for a simple pituitary, it's very limited, but every time it's extensive, it's another story. Depending on the location, the morbidity varies from crusting to nasal discharge. You can have more swallowing issue at the level of the craniocervical junction with velopharyngeal insufficiency. When you go up, you have a risk of hyposmia or anosmia. And if you go transcribriform, it's even part of the approach. So what causes the endonasal morbidity? Well, mostly mucosal injury, mucosal removal, bone exposure, and coagulation. And this is because the healing process takes time. Whenever you take some mucosa out, it takes time. It's like taking the skin out. It takes time to heal. And 3 to 4 months is usually what is accepted for coming back to normal after an extensive surgery. Again, contributing factor such as proton beam therapy are extremely important to consider because it considerably slows the healing process. So this was a case we did at our early beginning, an extensive chordoma of the craniocervical junction going quite far laterally. We did what we were supposed to do at that time, resecting a lot of normal tissue to get enough exposure. When you see that, you don't realize that the mucosa covering all this, the pharyngeal muscle covering all this, the eustachian tube has been removed. It has not been transposed. It has completely been removed. And we are also removing some bone to get to the intradural part of the tumor, such as the condyle in this case, reaching the vertebral artery on the, behind the condyle. So extensive surgery. The goal in terms of oncological resection was achieved, but for the patient postoperatively, it was tough. It was very tough. And the patient needed also an additional surgery the next day because of instability. So how to reduce the morbidity of such a strategy is definitely an important question. First, should we use an aggressive strategy for all chordoma patients? Maybe not. Maybe some patients are very slow, have very slow growing tumor, and we could adjust the aggressiveness of the treatment according to the biological behavior of the tumor. We have to try to be less aggressive going into the nose. It's extremely important. We were very aggressive with transcranial approach, and then we step back to more minimally invasive strategy. This is what we have to do also into the nose. We have to improve dural closure, and we have maybe to better select the approach to achieve the goal of first, oncological results, secondly, to reduce the surgical footprint for the patient. So how to better adjust the aggressiveness of the treatment according to the tumor behavior. We published recently this study looking at the growth rate of chordoma before surgery. You always have few months between the first MRI and the pre-op MRI to evaluate the growth rate of the tumor, calculating the volume. And this will give you important information, very simple information on the behavior of the tumor, and it's really linked to the outcome for the patient. So this is some information you can have before starting the surgery. We participate recently to this international study with the Toronto group, Gelare-Zadeh, looking at the methylome into the blood to look also for some factors, criteria to adjust, to balance the aggressiveness of the treatment before surgery. And this is definitely the future. I'm quite sure of that. Once the surgery is done, you also have prognosis factors that have been studied recently. This study from the Pittsburgh group, I think, is extremely important. There is a second study going on with international centers looking at prognosis factors which could help to adjust the treatment after surgery. Should all the patient have proton beam therapy? Maybe not. Some tumor, again, are slow growing. Some are very rapidly growing, and the strategy should be adjusted to this. We are also doing some study on some molecular factors after surgery, looking at some other factors. I am quite sure in the next 10 years, we will have a lot of information coming from the tumor, coming from biomarkers into the blood to adjust our treatments. Then going back to endoscopic endonasal approach, which is one of the main approach used for chordoma, what was the goal of the endoscope at the beginning when we started to use it? The goal is to look inside, to take advantage of natural cavity, to visualize and remove deep lesions without a need to resect everything. If you resect everything, then it's not exactly the true meaning of endoscopy. Endoscopy was supposed to be a minimally invasive technique. And this is why we have used this chopsticks technique that we named it like this, because it's quite representing what we are doing. In fact, we use the chopsticks technique, one nostril, holding two instruments in the same hand, the endoscope and the rotative section, in order to preserve endonasal anatomy. Because if you are not using a holder, you hold everything in your hand. In fact, you don't need space to work. The reason why we need space to work into the nose is also because someone or something is holding the scope, and the surgeon has to deal with it, to deal with this endoscope in the middle of the surgical field. And to avoid word conflict, we have to create space around the endoscope. But with this chopsticks technique, there is no need for that, because in fact, the endoscope, the sections, the instruments are supported by the endonasal structure. If I remove everything, I cannot use anymore this technique, because the endonasal structure are my holder, my buttress for the instruments. So this is a cartoon representing what we are doing. I am holding the endoscope and I am using this section that is a very specific section. It's not a straight section. It's a rotative. With my finger, I can rotate the section and I can move the bended tip of the section all around, because it's a malleable section also, as you can see here. And I can sometimes bend the section more than 90 degrees to look really behind critical structure with angle scopes without a need, for example, for a transpterygoid approach. So this is what I have been using for a very long time. A criticism could be that with the three hands technique, you have more precision. It's probably true, but because I have a very narrow space, because I hold everything in my hand, the tip of my endoscope is extremely close from the tip of my instruments. It's usually 1 centimeter, 1.5, sometimes less. So what I lose with precision of my two hands technique, I gain it because I see better, I see closer. And I have a perfect view without a lack of 3D view, because I need to be far away from what I do when I use the three-hand technique with the endoscope. So I think in terms of precision, I am not losing much compared to the forehand technique. I have the feelings that sometimes I gain because I see much better. This is also a technique for which you definitely need angle instruments. You cannot do it with a 0 degree scope. It doesn't make any sense. You need at least 30 degrees. and I quite often use 45 degrees, 75 degrees scope. You need to really go straight and then look on the side. Straight means to go in the sphenoid sinus, and from the sphenoid sinus, you look on the side. For this, we have fantastic 70-degree scope. We have also a lot of angle instruments coming from our ENT colleagues. They have created almost all possible angle instruments possible, going to the frontal sinus, maxillary sinus, because this is what they are doing. They are going into deep corners. So we have a lot of options in terms of instruments if we look in the list of instruments from our ENT colleagues. Angle drills also are important, and it's coming. Angle drills, mi-label or with articulation, as you can see in these pictures. Another concept that we have been using in the last 3 years is considering the rostral mucosa as the endonasal skin. The approach, in fact, starts at the level of the rostrum. Before that, we are not inside the body. We are inside a natural cavity that we respect. And the entry point of the approach is the rostral mucosa, in which we are doing an incision that is supposed to be closed at the end of the surgery. I believe that's the best way to fight against the CSF leakage, for example, is to close the first layer we open when we do an approach inside the body, which is the skin or the mucosa. It's the same. It's the first coverage. So the concept is really to go into the nose, preserving all endonasal structure, to make an incision on the rostral mucosa, luxation of the septum, and then we extensively drill the anterior wall of the sphenoid sinus, including the rostrum. To widely expose the sphenoid sinus, we remove the mucosa of the sphenoid sinus, we remove the tumor, and at the end, we put some fat in this cavity. The sphenoid sinus has been cranialized, just like we cranialized the frontal sinus. So this is how it looks on this cartoon at the end of the surgery, with the closure, the stitching of this mucosa, which is like closing the skin at the end of a transcranial approach. This is a case here of a chordoma that was not very big, located below the sphenoid sinus. So I could have done an extensive approach, resecting what I need to gain exposure, but I can also do a tiny incision on the rostral mucosa, go below the sphenoid sinus without opening the sphenoid sinus, putting some fat in the cavity, and at the end, closing the mucosa. So this is, I think it's one of the first cases for which I did it. And I did it because this patient had a septal perforation and I could not use a nasoseptal flap. So this is, I think, how it started. Here is the mucosa incision. You know that you see that it's quite small. It's about 1.52 centimeter. And from here, using this diamond drill, I progressively drill the rostrum. I progressively create the working corridor, the working space to have enough space to resect this chordoma. I am working here below the sphenoid sinus, trying to preserve the mucosa of the sphenoid sinus, of the floor that is pushed a little bit upward. And progressively a cavity is created into the bone. Because I'm using the chopsticks technique, you see that I don't need much space. My endoscope is all in my same hand than my section. So it's quite easy to work in a very small cavity. In fact, it's easier than working in a wide cavity. I am using also neuronavigation, which is more important because some landmarks are more difficult to identify, such as the median nerve. And progressively, having my landmarks, I go towards the tumor. Here is the tumor that is resected quite easily. It's a soft chordoma as usual. And once the tumor is removed, the next step is to close. And for this, I am just putting some fat into the surgical cavity. I'm going a little bit faster. Some fat into the surgical cavity. And then comes here, there was a little dural defect in which I put a little snowman of fat, then a big piece of fat into the surgical cavity. And then closing this incision of mucosa. At the beginning, I was doing this hangman node to block it. I changed my technique now. It's much easier. I am doing 2 nodes in the same direction, and then I tracked the stitch, and the nodes are going down on themselves. I'm using a monofilament stitch, monocryl 50, and I do a running stitch. And then at the end, instead of doing the node deep, I come back with my stitch to the nostril, and this is where I cross the septum, and then I do my stitch. It's a resorbable suction, so there is no need to do the final node deep in the surgical cavity. So this is how it looks postoperatively. You can see here the cavity with some fat inside, and the endonasal structure are absolutely intact. This is another case here of a chordoma, a little bit more extensive, that we did exactly the same way with this incision on the rostral mucosa. This is a more extensive case going down in the craniocervical junction, going into the petrous apex on both sides, mainly on the right side, for which we used also exactly the same technique. You see that the tumor is bulging a little bit in the rhinopharynx. We do the incision here a little bit more anterior on the septum, luxation of the septum, and here is our entry point. We drill bone. This bone is not useful, and we can drill it just like we do a drilling of the sphenoid ridge when we go transcranial. We don't transpose bone. We can use the volume of bone to work. This is what we do here into the nose, but we keep the mucosa because this is useful for healing, and we will close it at the end with a suture. So with angle scope here, I was able to look with a 70-degree scope in the petrous apex. You see the posterior aspect of the petrous ICA. The resection looks complete. I am doing a little bit of coagulation on the margin. You absolutely need to resect all the mucosa of the sphenoid sinus, otherwise you will have a mucocele. And this is one of the difficulties to resect all the mucosa, especially when it goes quite laterally. And at the end, this is how I close with this running stitch. Here, I was not using yet a monofilament. A monofilament is better because when you tract it, it's not injuring the mucosa. If you use a polyfilament, it's cutting the mucosa. And progressively here, I am doing this running suture that will end, I think it was already the case in this case, with a node here at the level of the vestibule. So postoperatively, this is how it looks. This is, I think, the immediate post-op MRI. And this is the MRI after 2 years, 2 or 3 years of this patient. You can see that the endonasal cavity are absolutely normal with a quality of life that I consider quite perfect for this patient. So this is another case. I will go fast on those with a more extensive tumor intradurally. So here, closure of this mucosa is even more important. On this patient, we did exactly the same strategy with an incision of the rostral mucosa. Same way, it always starts the same. You have to do the incision in the part of the mucosa that is quite thick, so not too posterior. You want to stay at the level of the septum, the mucosa is thick. And then progressively again, you increase the volume of the working space to resect the tumor. We resected here the part that was going intradurally. And at the end, the same, we do the closure with stitching. There is probably someone who should be muted here. So at the end, instead of doing an extensive resection of the dura, I am coagulating also the infiltrated dura. This is the strategy we are using in our institution, not necessarily to resect the dura that looks quite normal macroscopically. And at the end, the same, stitch with 5-0 monocryl, running stitches with a node at the end done just at the level of the vestibule. That's where the node is done at the end, at the level of the vestibule. So this is a postoperative scan for this patient where you see that the tumor is replaced by fat and the endonasal anatomy is exactly the same. So as you can see here, we have changed a little bit the way to treat those patients with more minimally invasive approach, but also with some change in the choice of the approach. Between 2010 2017, 77% of our patients were operated with endoscopic endonasal approach. In the last period, 3 years, this number decreased to 73%, using more classic transcranial approach, especially at the level of the craniocervical junction. For a chordoma like this, even with this shift in the choice of the approach, endoscopic endonasal approach is still the best. In a case like this, because of the extensive intradural extension, I was not feeling comfortable to use this minimally invasive technique, especially because I was expecting some relationship between the brainstem and the vessels, which definitely would require more space to work. So this was at the beginning. I think now I would use this same technique with the incision of the mucosa, but when I did it, we still use the chopsticks technique, but with a classic closure using a nasoseptal flap, which for the last 3 years, I think I didn't use because I was using this stitching of the rostral mucosa. In this case, you can see that the vessels, nerve, perforators are infiltrated by the tumor. It took us a very hard time here to dissect the tumor away from those vessels. I'm still using the chopsticks technique. It's not a four-hands technique, chopsticks, and you see that I still have quite good precision cutting adherences from the tumor to the vessels. We were able to achieve a complete resection in this tumor, not gross total resection because there was infiltration of the vessel and brainstem, but we did a nice resection. We closed now with the 3F technique from Napoli, which give us a lot of satisfaction and I think a significant reduction of our CSF leak rate. It's based on having the patient in an upright position, sitting position immediately after the surgery for at least 2 weeks. Choice of the approach, I think, is extremely important for a tumor like this one. You can see here that it's an extensive chordoma going intradurally, extradurally. This patient was not very symptomatic, just a slight diplopia looking down. And the goal here was to resect the tumor completely, but also to preserve the patient function. So here, instead of using a pure endoscopic endonasal technique, I decided to use first endoscopic endonasal for the part of the tumor that was extradural into the cavernous sinus, and transcranial for the part of the tumor that was intradural. First step, endoscopic endonasal. It's the same strategies that I showed you before, chopsticks technique, incision of the mucosa, drilling the infiltrated bone, resecting progressively the tumor that was stuffed with some remnant of bone into it. We monitor the cranial nerve in this patient. In most of our patients, all the cranial nerves are monitored, especially here to identify the sixth nerve. And we were able to identify the sixth with the cranial nerve monitoring. And the goal here was really to stop at the level of the dura, not to create a CSF leakage. The goal is really to use this combined endoscopic endonasal transcranial strategies also to reduce the risk of CSF leakage. So here through the nose, I don't want to see CSF. So you need to stop early enough not to have a CSF leakage. About 1 month after the surgery, this is a postoperative MRI. There is this remnant of tumor intradurally. The resection outside was quite complete. We decided to use a combined petrosal. We are using for those tumors and for petroclival meningioma now this mini combined approach with an incision behind the ear quite minimal with very limited manipulation of the soft tissue, using the concept of transposition of the sphenoid of the sigmoid sinus and transverse sinus to work below the temporal lobe. Well explained concept in the Professor Al-Mefti publications. Here is the incision. You see that it's a quite small incision. We are mobilizing here the temporalis muscle, small craniotomy around the petrous ridge, cosmetic mastoidectomy here to preserve this bone for reconstruction. We are doing here the mastoidectomy, shaving of the sigmoid sinus, extremely important because this approach is based on the transposition of the sigmoid and transverse sinus. We are now drilling behind the labyrinth, taking really much advantage of the petrous ridge, a little bit of anterior petrosectomy, coming from a little bit more posterior than the classic combined petrosal. And then we have the approach done. We can start to open the dura. Opening of the dura is quite classic, but again, the goal is to free the sigmoid sinus, to unlock sigmoid sinus, to be able to transpose the sigmoid sinus posteriorly and to open this space between the temporal lobe and the cerebellum. I was happy to have my two hands, micro instruments here to dissect the cranial nerve, the vessels, the perforators away from the tumor with a good control of the cranial nerve. Endoscopically, maybe I could have done it, but I'm not sure I could have achieved such a functional preservation of the cranial nerve. And probably the risk of CSF leakage would have been significant because an approach like this, and a tumor like this, require an extensive opening of the dura through the nose. The more you open the dura, the more the risk, the higher is the risk of CSF leakage after the surgery. So at the end, we just put a piece of pericranium over the clivus, through which we went previously to resect the endonasal part of the tumor. Reconstruction is classic, with putting back the bone, including the piece of mastoid for the comfort of the patient after the surgery. So, few words about the craniocervical junction. This is a perfect approach for endoscopic endonasal, no duped. There is nothing to resect into the nose for that. This is a case for which I don't feel comfortable anymore to go through the nose because of the extensive work I will have to do with limited chance to achieve a complete resection. You have to understand that in those extensive tumors, the bone is infiltrated. And you need to drill this bone if you want to achieve a complete resection. To the nose, if you go endonasal, you're not going to drill here the anterior arch of C1, which looks normal on the MRI. You're not going to drill the tip of the odontoid process. And the more you will do that through the nose, the more you will have to fix after the surgery. So it's a second surgery. So in a case like this, I use an hybrid strategies, going with a far lateral transcondylar approach on both sides, and then I put the endoscope inside to take the rest of the tumor out, which is anterior to the dural sac. This requires additional anatomical study to understand how, for example, the vertebral artery will look from an endoscopic perspective through a contralateral, far lateral transcondylar. And we have research fellow doing this work in the lab. I will finish with this video. This is a far lateral transcondylar with transposition of the vertebral artery from C2 to C0. This gives you a fantastic corridor to the tumor. Remember that we have made an acoustic incision that goes very far down to the tip of the mastoid process, even sometimes continuing with the classic incision of the anterolateral approach, in order not to have the bulk of muscle in your way. And once we have done that, once we have resected this part of the tumor, we can really have a look with the microscope anterior to the dural sac. And we can work quite far with the microscope in front of the dural sac, in this anterior part of the tumor. And once we have reached the limit of what we can do with the microscope, we can put the endoscope inside, looking in front and looking to the opposite side. This is a little bit of resection from the opposite side also, but I didn't transpose the vertebral artery here. It was not necessary. You can see the axis of the section here from one side to the other in front of the dural sac. For the rest of the tumor that was really in front of the sac, for the bones that needed to be drilled on the lower clivus, but also odontoid process and lateral mass of C1, we used also the endoscope. This is here the drilling of the tip of the odontoid process, anterior arch of C1, using the endoscope. At the end, in this patient, the resection was complete. And the beauty of this approach is that I can do the reconstruction during the same stage. I put some cement anteriorly to have something in between what remained of C2 on the clivus, and we do the fixation at the end. The risk is infection because it's a long surgery, but if you're careful enough, you can reduce this risk to the minimal. This is a postoperative scan. I am going to the end. I am sorry, I am a little bit too long. I will skip the anterolateral approach that we are sometimes using also for those tumors to reduce again the surgical footprint. So I think what is extremely important in the future is that we will have pre-op and post-op prognosis factors to tailor the treatment strategy, to tailor the surgery. The purpose of endoscopy is to be minimally invasive, not to make extensive approach. We need new instrumentation, but we already have quite good instrumentation with angle instruments from the ENT sets. For chordoma, complete resection remains the primary goal, and you should not try to be minimally invasive without achieving a complete resection of chordoma, which is the first goal. So having the choice of the approach is extremely important to achieve oncological goal, complete resection, but also to try to minimize the surgical footprint for those patients. Thank you very much for your attention. A thought for our colleagues in Ukraine that are probably facing a very difficult situation for a war they have not chosen. Thank you very much for your attention.
Thanks, Professor Froelich. That was a wonderful talk, which has gone beyond the endoscopy, and you have emphasized what endoscope can do and where you need to use different corridors. Dr. Liu showed us the use of other corridors also with endoscope, and maybe in future, I do not know if you wish to use that as well. But most people who have started at microsurgeons, I think that may or may not happen. But the combination of approaches seem to be minimizing the footprint, which was the main thrust of your talk, and achieving a total excision. I think Dr. Oyama and Dr. Liu are definitely going to comment on this presentation.
Sebastian, thank you for, again, a wonderful presentation. I think you're probably one of the few neurosurgeons that, emphasize the importance of nasal morbidity, and thank you for being a proponent of that, because I think that is one area that we tend to forget. We think we don't see what goes on. We see what there is no incision on the outside, but we know definitely there's a lot of work that and destruction that can be performed on the inside. And thank you for addressing those principles. I must say for myself, it's hard to go from binostril to uninostril, even for pituitary lesions. And I know you've been a champion of the chopsticks technique. And maybe what kind of advice would you give for the audience in terms of continuing to evolve your techniques and strategies doing something more minimalist in that way?
I think it's for the chopsticks technique. It's definitely a question of instrumentation. You need this tool, this rotative and malleable section. You cannot do it with a straight suction. It doesn't make sense because you need to go on the corners. And if you have a rotative section, imagine the tip of the section is like this. Just with a simple manipulation, you rotate the tip and you can go in all over. So this is a tool that you can easily find. Malleable section with a little, we call it the American piece, which is rotative. And then it's a question of practice. James, you're an amazing surgeon. Don't tell me you cannot make it. You can do everything you want. And it's just a question of habit, of experience, and that's it. Me, I don't really had the choice, in fact, because that's how I started from the beginning, and I learned to work like this from the early beginning. So that's how I know how to walk on only one leg, and you can walk in one leg if it's the only choice you have. So I think it's important to preserve the endonasal anatomy. We have learned with ENT surgeon to do endoscopic endonasal surgery, but we have different goals. The ENT surgeon are treating malignancy most often. And for this, you don't want to preserve endonasal structures. And we have used this technique to achieve different goals. And this is, I believe, why we use this four hands technique, which is nice for some indication, but not for all. For some indication, we as neurosurgeon know to reach deep structure without disturbing what's between the surface and the deep structures. And we need to have our own approach, own philosophy, own strategies for pathologies that we know better and for which we know that reducing the footprint of the approach is important. And I work with ENT, you know that, but for some pathologies, such as those ones, I have the feeling that a minimally invasive philosophy in the nose is better and is better adapted to what I treat compared to malignancies that ENT treats. But instrumentation is key. If you have this section, quite rapidly you can make it.
Okay.
Sebastian, it's a very, very fantastic talk. Do you use synthetic dural material for the dural closures?
Not anymore. I have used everything that is possible. All kind of tissue, patch, glue, everything. And nothing worked, in fact. Not when I was reaching a certain amount of patient, that's when you start to realize that the rate of complication increase. When you have two patients and one leak, it's 50% CSF leak. So rapidly you figure out that it's not optimum. What I believe now is optimum is really to close with fat. Fat is an extremely good tissue sealant. Skull-based surgeon for open surgery have been using it for a very long time. And I use positioning, upright position, because I think it's even more important to control as naturally as possible intracranial pressure post-op. So when we finish the case, the patient is left like this for at least 2 weeks, never like this. Not even for an MRI. It's extremely important to keep the patient like this for at least 1 week and if possible 2 weeks. With this technique, I have significantly reduced, I believe, the rate of CSF leakage. I need to wait a little bit more cases to conclude, but I have the feeling it's extremely important. On stitching, this is why I stitch this incision of mucosa. I think it's the third extremely important key step for fighting CSF leakage.
Thank you.
Sebastian, thank you for your wonderful presentation. I really understand the utility of the minimally invasive endoscopic endonasal approach. And I'm a real chopstick user. And nowadays, I'm sometimes try to use a chopstick technique using the endoscope, but it's still really difficult for me because my hand is not so big. So sometimes it's difficult to hold the suction with the endoscope, but I'm still learning how to do.
We can transplant. We can make a small transplantation of a piece of finger at the tip.
Yeah. Okay, sure. Thank you so much. And I also realized that your endonasal technique is getting more sophisticated than before, right?
Yes, yes. I mean, I had the chance to work with Kenichi for a year, a long time ago. It's 7 or 8 years. We were starting with these techniques. It was fantastic time. But yes, I have changed a little bit. And what I changed is this concept of making an incision of the mucosa and stitching it at the end. It's much easier to stitch this rostral mucosa than doing a stitch of pericranium on the dura that I know you are doing also. But I know that I have done those stitching of patch, of dura, of pericranium on the clivus. And you agree that it's extremely challenging. It's much easier to do a running stitch, 1, 2, 3, and that's it, of a thick mucosa, 5-6 centimeter deep, than doing a patch of pericranium 10 centimeter deep. No question.
Okay, thank you.
Thanks once again, Sebastian, and we move on to the next talk. Which one do we have next, Dr. Liu? Is it Dr. Venkat or Dr. Samer?
Prof. Samer is here. Prof. Samer.
So Samer goes first. Welcome, Samer.
Thank you, and good morning from Orlando, and I hope everyone is doing well. Good evening to my colleagues in Asia, and great to see you all. Can you see my slide?
So Dr. Samer Albeba is Chief of Pediatric Neurosurgery at the Arnold Palmer Hospital for Children in Orlando, Florida. And today he is going to talk to us about how does he use his endoscopic assisted technique for pediatric brain tumors.
There's some, okay. Well, thank you, Professor Diopujari, for the kind introduction. Thanks to the colleagues and the Asian Congress and colleagues in Japan and India and other parts of the world for the kind invitation. We'll talk about the use of the endoscope in my pediatric neurosurgical practice in both brain tumors and skull-based pathologies. Here are my disclosures. As we all know that deep pathologies in the brain, in the ventricles or deeply seated white matter or gray matter locations can be a challenge for the practicing surgeon when dealing with difficult pathologies. In my practice, in children, some of those pathologies can be challenging as well, but at the same time, on the pediatric side, we have a more aggressive approach about trying to attempt or achieve curable resections with the minimal morbidity as much as possible. When we decide to use the approach, for instance, when we deal with ventricular tumors, we have to think about the anatomical corridor. We use which cortical gray matter we're going to enter, what is the white matter tract that we're going to traverse or displace, and what are the surrounding structures, specifically within the ependymon of the ventricle, that we're going to potentially damage when we get to the pathology. We always talk about eloquent parts of the brain, like the motor strip, precentral gyrus, postcentral gyrus, the pars, the insula, the operculum, the speech areas. We also talk always about highly eloquent white matter tracts like corticospinal motor fibers, thalamocorticosomatic sensory fibers, as well as optic radiations. But at the same time, we should look at the whole brain as eloquent. I've been fortunate to be mentored by Professor Ghazi Yasragil for over the years. And I remember when I used to assist him in surgery, he always used to say, the whole brain is eloquent. You should pay attention, specifically if you think about endoscopy, more actually than microsurgery, that the entry point you use to enter into the brain or the white matter you're going to traverse, you have to think of it all in an eloquent manner. For pathologies that are deeply seated in the third ventricle, we know there are many microsurgical and endoscope-assisted microsurgical approaches, and sometimes purely endoscopic approaches to get to those pathologies. And as late Professor De Oliveira said, surgery is a superior option only when it's done at a superior level. So anatomical knowledge of neurosurgical anatomy is key when we get to those pathologies and be able to get to the pathologies safely and effectively. Fortunately, the endoscopes we have on the market nowadays are becoming more and more advanced with the optics, with the orientation, with the angles. And nowadays there are new endoscopes similar to flexible endoscopes we're using for certain indications. Should we use an endoscope or microscope, we should not be looking at this in a dogmatic way or a biased way. The best surgery is the surgery that is done the right way with the best use of equipment. You use a, excuse me, you use a microscope or endoscope, or you use an endoscope-assisted microscope is all the same as long as you do it safely and effectively. Going back to Professor Pernetsky's definition of in 1998, when he defined endoscopic techniques, purely endoscopic, similar the way when we do, for instance, ETVs, or endoscope controlled, similar when we do endonasal transsphenoidal surgery, when the endoscope is primarily used for visualization. And also the third component is the endoscope assisted, is when we're using the endoscope in different parts of the surgery. And he described endoscope assisted microneurosurgical techniques as minimally invasive techniques with maximally effective treatment. Professor Andre Rittenhouse, our good friend, also published this wonderful book about endoscope assisted microsurgical techniques that I highly advise you to try to find a copy of and to read it. So we'll go through a few cases. This is a child, a 4-year-old child, who presented to me with gait imbalance, dysphagia, multiple lower cranial nerve pathologies. Here we can see a prepontine cystic mass with severe compression of the brainstem. You can see the basilar artery and its perforators pushed ventrally. And the question is, what is the best approach? We use the DTI tractography to confirm that the corticospinal tracts are all displaced dorsally. But here, actually, the DTI helped me decide in which direction we should come from for the retrosigmoid approach. And in this case, we decided to approach from the left side because there were less fibers displaced to that side. So we mapped out the transverse and sigmoid sinus, planned a retrosigmoid approach, and here you can see microsurgically we're able to identify the mass and the brainstem. After entering into the cyst, draining it, we got a green fluid suggestive of likely neuroenteric cyst. Then used all this all those arachnoid windows between the cranial nerves to get into the pathology. The most concerning part was here. You can see the perforators of the basilar are all surrounding the cyst. So it started with sharp microdissection. You can see here the basilar artery via retrosigmoid approach, dissecting all the perforators and creating microsurgical windows between all the perforators to dissect for total excision of the cyst wall. And after completion of the resection, then we bring the endoscope to take a closer look and make sure that all the perforators are free and looking all the way into the contralateral internal auditory meatus. All the cranial nerves, all the basilar, the perforators, the ICA, the pica, all of them have been identified. This is one of the basilar perforators. And now we're looking all the way to the contralateral EAC. This is postoperative day 1, immediate decompression of the brainstem. And after 6 months, you can see the brainstem return back to close to normal anatomical midline, and he recovered most of the pathologies. He underwent a shunt placement for hydrocephalus, as well as he had a tracheostomy and G tube only for 6 weeks, and they were removed, and he recovered most of the deficits. Tumors within the ventricular system can be managed endoscopically, purely endoscopic, as we know, with ETVs and endoscope-assisted or endoscopic biopsies. The pathologies in the pineal region can be managed successfully with a combination of ETV and biopsies. Those are rigid endoscopes, but we also know now we have the flexible endoscopes that many pediatric neurosurgeons use for applications like endoscopic Turbulent colostomy and choroid plexus cauterization. And now in the United States and Canada, there is an ongoing prospective randomized trial looking at the use of the flexible endoscope for ETV, CPC, randomized with shunting for treatment of hydrocephalus during infancy. This is another baby. You can see this is a baby who was born, 7-month-old baby with a large pineal region mass. I decided to approach this from 2 different angles for the ETV and the biopsy. This is from an anterior trajectory, massa intermedia. This is the posterior third ventricle. And excuse me, being able to approach the mass, get a biopsy. In this case, it came back as pineoblastoma, so it was resected via supracerebellar infratentorial approach. Another 15-year-old boy with a similar pathology, the biopsy confirmed germ cell tumor, and this was treated successfully with adjuvant therapy. So two similar locations for the pathology, 2 different strategies, one with adjuvant therapy, the other one was resection, and we know that the endoscopic biopsies can really have a high yield. And when colleagues looked at the diagnostic yield for large numbers, for instance, this is almost 2,000 biopsies, showed that the diagnostic yield can be close to 88%. Another tumor in the periaqueductal region that was managed endoscopically also, and navigation can be very helpful for this pathologies, but nothing better than the microsurgical anatomy. When we deal with tumors endoscopically, we have to always think about the complications, which can be one of them, inability to make the diagnosis, seizure, CSF leak, and hemorrhage. It's not always about endoscopy. This is a 5-year-old child who presented with seizures and coma, and there's a large mass in the left foramen of Monroe. I elected to perform this via an interhemispheric transcallosal and transforaminal approach for this. Also transchoroidal. The mass performed the expansion of the choroidal fissure to get into this resection. I did not feel comfortable to use the endoscope for this case, and this was done in microsurgically with clean resection, and this came back as ATRT. When we deal with optic pathway tumors in children, we know that adjuvant therapy is very effective in treating those, specifically when the vision is well preserved. After performing biopsies, confirming the diagnosis, and we start adjuvant therapy, many times we're faced with cystic transformation of those masses. You can see here optic pathway glioma responding beautifully to chemotherapy, but we have hydrocephalus that is asymmetric because of the cystic transformation of the mass. And those are the cases we can handle endoscopically by going in, communicating the cystic component of the cyst with the third ventricle, as well as decompressing the cyst, followed by performing septostomy for effective communication and being able to communicate all those ventricles together. Again, it's not always about endoscopy. This is an 18-year-old patient who came in with a recurrent suprasellar podocytic astrocytoma, had 2 resections in the past, 18 shunt operations, gamma knife, and radiation, and was labeled as inoperable. And when I looked at his MRI, you can see there's asymmetric ventriculomegaly, but when you look at his shunt X-rays, you can see that this is a nightmare. He has complex hydrocephalus, and multiple cysts are placed in different components of this tumor and into the ventricles. The right thing to do in this scenario is to take out all the shunts and start clean by doing an interhemispheric, safe transcallosal resection of this mass and converting the complex hydrocephalus into simple hydrocephalus, not by endoscopy in this case, but via microsurgery. And he had no tumor recurrence for 3 years. Other endoscopic tumors and the suprasellar regions in children also can be managed endoscopically and via biopsy. And very important when at the time of placing a shunt is to communicate the ventricles via septostomy and communicate effective drainage of both sides equally. This is a similar case also with optic glioma with cystic transformation after chemotherapy, and this after the this was managed via sorry, this video is now working via an endoscope-assisted interhemispheric transcallosal approach, communicating the cyst with the ventricle and achieving a successful communication. Another case with looks like diffuse limbic cystic tumor. You can see here this should be managed by biopsy followed by adjuvant therapy, but very important at the time of the biopsy to communicate the ventricles to achieve successful drainage via the shunt, so the adjuvant therapy can be helpful while the hydrocephalus is being treated equally. How about deeply seated tumors? This is a 7-year-old child with temporal lobe seizures on the left side. Functional MRI confirms speech on the left side, and he's neurologically intact. The appearance of this mass in the perihippocampal gyrus on the left side appears to be likely ganglioma. This could be approached via anterior temporal approach or transcortical, or other approach would be to avoid any injury or manipulation of the dominant temporal lobe is to go supracerebellar transtentorial, which we did in this case. And why did I use this approach? If you look at the FLAIR and T2 images, you see significant hyperintensity within the perihippocampal gyrus surrounding the mass. So the goal of this surgery is to remove the mass without missing the temporal lobe. This was done via the supracerebellar transtentorial approach, was described beautifully by mentors like Professor Ture in Istanbul, late Professor De Oliveira in Sao Paulo. This has been published in beautiful atlases looking at this approach for mesial temporal pathologies. This should be done in a semi-sitting position with beautiful exposure of the mesial temporal lobe. All our cases are done with transesophageal echo to monitor for obviously air embolism. I use a suboccipital paramedian approach, similar to the one from Professor Ture's paper from Istanbul, starting the surgery with the microscope to perform the infratentorial dural opening. It's very important to sharply open the cisterna magna to drain CSF and relax the hemisphere, and then bring in the endoscope to perform the transtentorial opening. And here there's beautiful exposure of the tentorium. I like typically to do the transtentorial opening with the endoscope, not with the microscope. Always know the anatomy of the fourth cranial nerve. Then the next step is to bring the microscope back and to perform the resection using the ultrasonic aspirator of the back of the perihippocampal gyrus and the mass. And the resection was, this appeared to be likely a ganglioma, and resection was continued, and then putting the endoscope back to confirm that we're able to take the tumor out. When I put the endoscope, I found that I I left a good residual lateral to the P2 segment of the PCA. This is the portion of the tumor the microscope was never able to allow me to resect, lateral to the P2 segment of the PCA. And again, via the transdental approach, going between microscope and endoscope, we're able to achieve a gross total resection and maintaining patency of the PCA. And when we look at the MRI on the day after surgery, we see the gross total resection of the mass. And here's the transdental approach. And most importantly, when we look at the flare and T2 signals, we will find that the edema, or the here you can see the edema within the parahippocampal gyrus is completely gone, also on the flare. We achieved a gross total resection of the mass without messing with the dominant hemisphere. How about pineal region pathologies like pineal cysts or other tumors in the pineal region? As we all know, there are different approaches. But when we get more and more experience with endoscope-assisted supracerebellar techniques, you'll find that slowly we can transition from endoscope-assisted to endoscope-controlled approaches to the pineal region. Like in this case, was done completely endoscopic of a girl with a large pineal cyst that was giving severe headaches and then developed hemorrhagic transformation. We can see here, this is the next step, doing a combination of blunt and sharp microdissection of supracerebellar adhesions. Now we can see the anatomy: basal veins of Rosenthal, right, left, right thalamus, vein of Galen. Now dissecting the mass from the right basal vein of Rosenthal, and then we go to the left. Very important to, when we start doing bimanual endoscope-controlled bimanual resection of the mass, very important to pay attention to the superior attachment of the mass to the internal cerebral veins, and this should be the last part. And now after complete resection of the mass while maintaining safety for the internal cerebral veins, the basal veins of Rosenthal and the vein of Galen, and the thalami on each side, it's very important to make sure that there are no attachments before the resection. Now we're doing nice exposure, and now the third ventricle has been identified to be clean of any resection. Optimal positioning is critical in those cases. It was the pleasure to partner with colleagues in Europe about publishing recently the extreme lateral supracerebellar infratemporal approach using endoscope-assisted techniques. In conclusion, microsurgery versus endoscopy should never be understood as a battle. Endoscope-assisted microsurgical techniques can be very helpful. The choice of the approach is critical. We should always think about the gray matter we're entering, as well as the white matter tracts we're traversing. And at the end of the day, anatomical knowledge, using best equipment, technology, and the surgeon's personal experience are critical for safe execution of the surgical plan. Thank you.
Thanks, Samir. Comments, Dr. Oyama?
Thank you very much for your great instructive presentation. As you know, in Japan, the flexible endoscope is very popular and very useful for the ventricular tumors. And probably in other countries, it should be used, I think. And also, you showed us the utility of the purely endoscopic approach to the ventricular region. Actually, we are now using mainly the endoscope for the ventricular pathology, because in my opinion, it is much better to use the endoscope for the ventricular regions, because we have a great panoramic view of the inside the ventricle. So probably you were switching to purely endoscopic approaches to ventricular regions, right?
Thank you, Professor Oyama, for the comment. First, I want to say that the use of flexible endoscopy is becoming more and more popular in North America. As you know, many countries around the world, include specifically in Europe and South America, are unable to use the flexoendoscope for because of license issues. So hopefully more and more we will see flexoendoscopy being used worldwide. I personally learned it in Uganda at Cure Children's Hospital when I went to learn it specifically for ETV and choroid plexus colorization. And this ST trial, that is a prospective randomized trial running in North America now, is going to make even the use of flexoendoscopy more popular. I use it for selected indications for biopsies, specifically in Pioneer regions. For your comment regarding the pure endoscopic approach for ventricular pathologies, I do use it for the right indication. For instance, if I'm doing a choroid plexus tumor in the ventricle with heavy vascular supply from the choroidal vessels, I don't need to expose the patient to risk and use a pure endoscopic ventricular approach, but I'll do microscope. I will use an endoscope-assisted microsurgical approach for that specific case because of the heavy vascular supply for choroid plexus tumors. So it all depends on the pathology. Colloid cyst, all endoscopic. Solid tumors, all endoscopic. For highly vascular lesions, like choroid plexus tumors, I do endoscope assisted. For Pioneer region tumors, it all depends on the case, the size, the involvement of compression of the aqueduct or the thalamus, thalami on each side, if I see attachments to the internal cerebral veins. So it all depends on the case, but I agree with you. The transition from endoscope assisted to purely endoscopic should be done, but for selected indications. Thank you.
Thank you.
That partly would also depend on if the tumor is solid, fibrous, etc. Because do you use the CUSA, the Nycomed in your practice, or any other device?
In selected cases, I do. To be frank with you, when they first start coming out, I use them more and more. Now I'm using them less, except for the selected indications. They can give you beautiful resections, but if you have a vascular attachment for the tumor, you will start having bleeding, and the screen will go red, and it'll take a long time with dry endoscopy trying to take care of the bleeding. But for selected indications, I use it. But I'm more and more using actually old school ventricular endoscopy of having good hemostatic control of the feeding vessels, using the micro scissors through the working channel, the endoscope, to control all the feeders before doing the resection.
Especially for choroid plexus papilloma, Samer, as you pointed out, I have actually used endoscope at the beginning of the surgery. Mainly, you can usually see where the pedicle is. And it's usually, if it is in the atrium, which is the most common site, you can get underneath the lesion, you can coagulate it under endoscopic control, and makes it much easier for you later to remove it, even if you're doing it microscopically. So that can be one use. I think now Sufia now is also showing some cases where he's actually putting a clip. I have just coagulated them in a few cases, and that made my life easier while removing the whole lesion.
Yes, sir. It all depends, obviously, like you said earlier, on the size of the mass and if it's fibrous or not. For small choroid plexus tumors, I fully agree. For larger choroid plexus tumors, sometimes I deal with in infants that are huge. I found that a safe endoscope-assisted microsurgical excision is safe, effective, and quicker, actually, with less blood loss.
Dr. Oyama, in Japan, do you use any kind of CUSA to debulk the tumor for
Yes.
solid intraventricular tumors?
Sure.
Is there an endoscopic device available?
Yes, actually, we're using the device instrument for the endoscopic endonasal approach. We can switch such kind of instrument to the small opening craniotomy using the endoscope. Then we can put the instrument from the small key opening.
So you're talking of tubular retractor surgery. It is not through the endoscope.
Purely endoscopic, open surgery.
Well, endoscope controlled, if we want to use the language. The endoscope handpiece does not go through the channel of the endoscope, right?
No. I'm talking about the keyhole approach to the to the ventricle, like occipital transtentorial approach or infratentorial approach. We can use the instrument for the endoscopic endonasal approach because it has a single shaft, monoshaft instrument and a tiny tip of the QSA. We can switch such kind of instrument to the keyhole approach toward the ventricle. It is
Dr.
getting.
Fidelity, do you use the flexible endoscope for tumor excisions?
Yeah, actually, we are using the flexible endoscope just for the biopsy.
Just for biopsy.
Yes, if we want to perform the complete removal of the tumor, we have to use the rigid scope.
Correct.
By a small craniotomy, and then we can get to the third ventricle or lateral ventricle as well.
Any comments, Dr. Fidelity?
Yes, I use flexible scope for this kind of tumors, unless the tumor is in the lateral ventricle. In that case, I use a rigid scope. In my memory, I think I was able to completely remove only selected cases of tumors in the ventricle. So if the tumor is soft enough, not too big, like not bigger than 2 centimeters in diameter, not too much vascularized. So I totally agree with Professor Samir about the indications. You have to select the cases, I think.
Thank you, Albert.
Yeah. Thank you. Shall we move on to the last presentation of the day?
Jetzt kommt die letzte Präsentation. Mit der fettigen Wurst und dem Kassler da drin. Und Pickel.
Then, Ben, can you share Professor Venita slides?
Yeah.
Thank you.
Yep. Okay. Yep. Can you all hear it?
Thank you very much.
Yeah, I can run the slide for you.
Can you hear me? Yes. Can you hear? Yeah. So at the outset, I would like to thank Professor Koto and Professor Dev Pujari for this opportunity. Thanks for accommodating this talk for the technical snacks what we had yesterday. So in 1831, the Bright has described arachnoid cysts as the serous cysts. So they are primarily classified as the developmental cysts as well as the secondary cysts. The arachnoid cysts constitute about 1% of mass lesions. With the recent imaging, the incidence have increased all over the world. However, there have been a familial incidence which has been reported. Next slide, please. These arachnoid cysts, primary cysts, are most common, considered to be developmental in origin due to the developmental abnormal splitting of the arachnoid membranes in the uterine development. Therefore, there will be anomalous collection of the CSF. And there is another theory that the abnormal development of primitive meninges creates a localized enlargement of the subarachnoid spaces, and therefore there can be enlargement subsequently. The developmental theory has been supported by the presence of corpus callosal agenesis and the parenchymal malformations, as well as the venous malformations that are associated with the arachnoid cysts. The secondary arachnoid cysts are less common. However, there can be a consequence of trauma, surgery, infection, as well as intracerebral hemorrhage. However, the natural history of these arachnoid cysts are not very clear. Most of them remain stable. Incidentally, they are detected. The important thing, some of them become symptomatic by enlargement and causing symptoms. The exact mechanism of the progression and enlargement is not clearly understood. However, the CSF secretion from the cyst membrane is one of the propositions. the osmotic gradient, and there will be absorption of the fluid continuously from the surrounding spaces is another theory. And a valve type of mechanism where CSF enters from the subarachnoid space, gets trapped into the arachnoid cyst, gradually bulging whenever there is a cough or a Valsalva-like maneuver in the day-to-day life. So these are the three mechanisms that are known to enlarge this is symptomatic over a period of time. Some of these arachnoid cysts, they remain very quiet, but even with a simple trivial trauma, the large cysts can cause a lot of problems, such as subdural hygromas, subdural hematomas, raised intracranial pressures, and hydrocephalus. That's how they can be acutely become symptomatic, requiring immediate intervention. Next slide. When you consider the location of the arachnoid cysts, they can occur intracranially all over, including in the spinal. Most common of the arachnoid cysts are present in the supratentorial area. Of that, sylvian location is the most commonest, followed by the interhemispheric, and very few are in the convexity and the anterocranial fossa. The next commonest arachnoid cyst that we see in the supratentorial compartment is the cellar and suprasellar area, followed by the quadrigeminal arachnoidal cysts. And there can be miscellaneous ones such as paraventricular, hemispheric, interhemispheric, basal, and polar arachnoid cysts. 5 to 10% of arachnoid cysts occur in the posterior fossa, and the next commonest location for the arachnoid cysts is in the spinal canal, which is about 20 to 25%. Can you move, please? Next slide. Yeah. Most of the arachnoid cysts are incidental, and they're detected by the imaging for some other purposes. However, good number of them can become symptomatic in lifetime. Choi et al. Have classified them into 3 types. One is a type 1, where the symptoms of hydrocephalus and raised intracranial pressure, therefore they require intervention. Type 2 can come with vague symptoms, such as headache, dizziness, large head, developmental delay, seizures. These, a clinical judgment need to be used, where we need to intervene at what time. And type 3 can have very minimal symptoms or no clinical symptoms at all, and they may just require observation, may not require any intervention. There are certain unusual presentations as far as the arachnoid cysts are concerned. They can come with the bobble head as an inappropriate laughter or behavioral abnormality, as well as precocious puberty. MRI is the gold standard that can image the cysts very well. Cysternal imaging is also seen to see the CSF dynamics. CT is very useful to identify the complications immediately. Of course, ultrasound can be used through a transcranial window in very young children, as well as for the prenatal diagnosis. And prenatal diagnosis of large arachnoidal cyst is possible today. The cyst usually appears as the smooth surface, thin-lined cyst, can be associated with a calvarial defect or a bulge. If there is hydrocephalus, there can be a large head. The parenchymal compression surrounding the cyst is well seen. Chiasmatic compression can lead to visual symptoms, and of course, variety of mass effect can cause raised intracranial pressure. But what is very relevant for the endoscopic surgeon is the location of the arachnoid cyst, size of the arachnoid cyst, its relation to the ventricle as well as the cisterns, and relation to the neurovascular structures. And that's the one which is going to decide the type of approach and the trajectory for the endoscopic approach. The indication for surgery is all symptomatic arachnoid cysts need to be dealt with, either clinically progressive symptoms or radiologically progressive enlargement that warrants surgery. Next slide, please. Conventionally, we have several techniques, surgical options that are available for the management of arachnoid cysts. That includes craniotomy, which is an open fenestration, a stereotactic cyst aspiration, cystoperitoneal shunt, the reservoir placement. Of course, of late, the endoscopic fenestration is becoming very popular. There is a surgeon's choice as well, depending upon the experience and the availability of technology and techniques. Next slide. The choice of procedure, if you look at craniotomy, gives a wider exposure, A complete membrane excision is possible. Inspection of pathology is very good, complete. Penetration of other cysts is possible. The recurrence rate is very less. Whereas the cystoperitoneal shunt has a very high recurrence. All complications of shunt as well as the shunt dependency is associated with this procedure. Pathology may be invisible. Similarly, stereotactic aspiration has very poor results due to insufficient penetration as well as insufficient communication, high recurrence, and higher complications. Therefore, apart from the craniotomy, the next best procedure that is possible is the endoscopic fenestration. Next slide. Endoscopy is gaining popularity because of the improvement in technology, optics, and skill sets. It is minimally invasive. Pathology is visible. Biopsy is possible. The most effective outcomes have been reported of late with endoscopy. It's very simple and less complications. Of course, what is required is the technique as well as the technology. The surgeon's experience is at most important. When we look at the middle fossa arachnoids, Galassi has classified them into 3 types. Type 1 are very small. They remain asymptomatic, and they will be only in the anterior middle part of the fossa. And often endoscopy is not useful here. Therefore, craniotomy is the first option. Type 2, these extend along the sylvian fissure, displacing the temporal lobe. And type 3 can be very large, occupying the entire middle fossa, displacing the brain. So type 2 and type 3 are the ideal indications for the endoscopy. And the ideal procedure here is the cystocysternostomy. And however, craniotomy, cystoperitoneal shunt is also been effective, but the endoscopy is preferred. In the recent meta-analysis by Chen et al., they have found that cystocysternostomy has a superior results compared to the other ones. Next slide. So this is the video, and if you look at that, it's through a small temporal burr hole. Here, the trajectory is very important. Initially, there can be little bleeding, and with the irrigation, you will always clear the bleeding until you continue, till you see the clear membrane very clearly. The ideal location to penetrate is at the opticocarotid space into the cisterns. The cyst of the sylvian fissure is now communicating into the opticocarotid space. You will see the thick membrane there. Sometimes the membrane is so thick that you need to have a sharp instrument to open that, and you can see the frontal lobe and the optic chiasm inside. Next slide. So especially when you want to communicate to the sylvian fissure, you need to be very careful using the sharp instruments and to avoid the injury to the sylvian veins. The next commonest is the cellular and supracellular cysts. They represents about 9 to 21% of the arachnoid cysts in the intracranial. They are in close proximity with the third ventricle. Sometimes they extend and indent into the lateral ventricles as well. Often and most often present with hydrocephalus, and they can have associated neuroendocrine abnormalities. Now, Miyajima et al. Have tried to differentiate these supracellular cysts, the real cysts that are arised out of defect in the Liljeqvist membrane, which is the diencephalic membrane. The second variety is the cystic dilatation of the interpeduncular cistern. However, Michel Gerard has published a very beautiful paper where the first variety, or type 1, where there is a blockage of both foramen of Monro. Therefore, there has to be associated ventricular megaly. And the Liljeqvist membrane here is displaced caudally. And because of the hydrocephalus, the early surgery is warranted. So the type 2, where it's only a prepontine expansion, but the Liljeqvist membrane stays rostrally, generally not associated with the hydrocephalus. So they can be observed. Whereas the third one is asymmetrical quadrigeminal cysts. They extend laterally to temporal lobe or to the sylvian fissure, usually associated with the macrocrania. And as you see here, they require the surgery. So this classification gives us a very good indication for the surgical classification. The type 1, which requires early surgery, type 2 can be observed, whereas type 3 also requires surgery. Next slide, please. As far as the treatment of the quadrigeminal cysts are concerned, endoscopy is the treatment of choice. Several authors have reported best results with the endoscopy. of them. GUI has reported more than 70% success. Two types of procedures have been described. One is the cystocystostomy. The other one is ventriculocystocystostomy. Of these, the superior results are always with the ventriculocystocystostomy, where the cyst is communicated from the lateral ventricle to the cyst, that is the ventriculocystostomy, and from ventriculocystostomy to further opening of the Lilliquist membrane will communicate that into the basal systems. So ventriculocystocystostomy will give the best results here. So this is the way you can see the membrane, the cyst here, the lateral ventricle, and into the cyst, and then come down into the preponderant system. It becomes a ventriculocystocystostomy. So the other miscellaneous cyst groups include the interhemispheric arachnoid cysts. They're usually parasagittal, unilateral, most often in the children, and they can be associated with the agenesis of the corpus callosum, and they grow and enlarge closer to the ventricular system, therefore gain access to the cystoventriculostomy. So this is the usual procedure. Again, endoscopy is preferable, and the trajectory here is very important, where you make a colostomy at the same time into the cyst and communicate into the ventricular cavity. The neuronavigation is absolutely effective. And one of the important point here technically is these cysts are usually associated with multiple septae, and they need to be opened up completely so that the cyst will have a better outcome. And the second group of cysts here is the paraventricular cysts. They can be very close to the ventricles, and they can be easily communicated from the cyst into the ventricular system. Therefore, again, cystoventriculostomy is the procedure of choice for these cysts. Next slide. The quadrigeminal cysts, again, they're quite infrequent, usually associated with the hydrocephalus, and also can have eye movement disturbance. Now, these cysts again are classified as the type 1, where the cyst has both supra as well as infratentorial extension. The type 2 cysts only with have a pure infratentorial extension, and a type 3 with a lateral extension. So the treatment, again, the endoscopy is a very good choice of option. It depends upon primarily the extension of the cyst into different directions. If the cyst is extending superiorly towards the trigone, a ventriculocystostomy is ideal. You can have a best access through the ventricle and communicate that into the cyst. And again, navigation and the trajectory and the entry point is very important and very useful technique. When the cyst is extending anteriorly into the third ventricle, a ventriculocystostomy into the third ventricle is very useful here. You can see the bulging into the third ventricle. One can come anteriorly through the lateral ventricle into the third ventricle and communicate the ventriculocystostomy through the third ventricle. Whereas here is a ventriculocystostomy through the lateral ventricle. And when the cyst is extending inferiorly into the supracerebellar system, cystocystostomy is the ideal option. You enter the cyst and communicate with the surrounding systems, and that will be effective. All the three procedures can be done with endoscopy, and very effective. And Sinali group have reported 90% of success rate with endoscopic procedure alone. And similarly, Sengul et al. Have reported that hydrocephalus control can be achieved in 78 to 93%, where combined with the endoscopic third ventriculostomy can be significantly avoided in many situations. Next slide. Coming to the posterior fossa cysts, located in the CP angle, a supravermian location, retrocerebellar or retroclival. Again, are coming up with successful results with the endoscopy. However, the data in the literature is very minimal. Choi, Schroeder, Kim, and particularly for the retroclival cysts. Yesterday, the commonest procedure that is adopted for this process is a cystocystostomy. This can be communicated to the either CP angle system or the supracerebellar system or to the foramen posterior fossa cysts as well. Next slide. The special tools that are adopted for the endoscopic arachnoid cyst surgery more effective are one is the flexible endoscope, navigation is of paramount importance, particularly for the para-axial cysts or paraventricular cysts. Endoscopic ultrasound probes can be useful in identifying the exact location where we need to get access into the cyst. Lasers, which we have seen yesterday in some of the talks. The points to remember for a best surgical outcome is the point of entry is very important, both the cortical placement of the burr hole and the trajectory through which the scope is passed into the cyst. A clear visibility is mandatory. Even if there is bleeding into the cavity, you can irrigate continuously so that the cyst becomes very clear and visible, and you can identify a proper instrumentation is very essential. Identification of neurovascular structures and a complete anatomical orientation is mandatory so that we can avoid the complications. One of the major complications intraoperatively is the bleeding that can be avoided by avoiding damage to the vascular structures. And if there are membranes, it's mandatory to open up all the membranes so that the outcomes are always better. Next slide, please. Looking at the comprehensively, the endoscopic procedures can be classified into 4 types, essentially. One is a cystocystonostomy, which is useful for most of the sylvian fissure cysts, as well as the posterior fossa cysts. Ventriculocystostomy, which is useful for the intraventricular cysts, as well as quadrigeminal cysts. Cystoventriculostomy, where a paraventricular and paraaxial cysts can be treated endoscopically. A ventriculocystocystonostomy is very useful for all the suprasellar location of the arachnoid cysts. However, ETV can be combined along with these procedures wherever necessary, wherever the hydrocephalus is significant. Next slide. Outcomes of endoscopy overall for the arachnoid cysts, the literature says about 67 to 100% have remarkable improvement in their symptoms. The headache is recovered in about 80 to 100% of the people. Epilepsy has improved in 83 to 100%. Gait improvement has been reported in the posterior fossa cysts, and raised intracranial pressure has been alleviated in 92% of the people. Clinically, if you look at, the best results have been from the suprasellar cysts, followed by the quadrigeminal arachnoid cysts. And however, the posterior fossa cysts, the symptom take long time after the endoscopic surgery. Similarly, radiological outcomes, there can be reduction in about 50 to 100% in the size. In 25% of the arachnoidal cysts, there may not be any change postoperatively in the scans. Nevertheless, if there is symptomatic improvement, they can be observed unless the symptoms recur, if there can be for a procedure which can be planned once again. Next slide, please. Coming to the complications, endoscopy has its own share of complications. It depends on the surgeon's experience and the quality of equipment one has. The commonest intraoperative complication is the bleeding. The venous bleeding is the most commonest one, followed by intraventricular hemorrhage. Intracerebral hemorrhage has been reported. A rapid decompression can sometimes create a cyst collapse. It's always necessary to drain very slowly, and a cyst collapse can sometimes create a movement of the brain shift and make the neuronavigation also difficult. So once again, we can refill the cyst to come back so that we can get the cavity enough to navigate with the endoscope. Postoperatively, complications are about 30% of them have been reported. The commonest is the subdural hygroma, the subdural hematoma. The incidence of subdural hygroma and hematoma is proportionate to the degree of hydrocephalus, and the CSF leak is another complication. Similarly, infection. And 19% of the arachnoid cysts following endoscopic surgery can recur and become symptomatic, requiring one another procedure subsequently. Among them, the commonest recurrences are with the sylvian arachnoid cysts, followed by the posterior fossa cysts, and very rarely suprasellar cysts. Next slide, please. We had a 4-year-old boy. He underwent next slide. This is the MRI. Preoperatively, has a large cyst, the suprasellar cyst, shifting the brainstem, pons, and the medulla. At the same time, the cyst is lifting the third ventricle, almost coming to the roof of the lateral ventricles here. And he underwent a ventriculocystocystonostomy for the first time. You can see the defect in the postoperative MRI from the lateral ventricle to the cyst, and cyst is communicated into the cisterns here. Next slide, please. He was on follow-up for 10 years. He had slight obesity, subsequently developed severe endocrine deficiencies requiring replacement of the growth hormones and several other hormones for his growth. He had a normal physical as well as mental milestones, and had a very good scholastic performance. 15 years later, after the original surgery, he started developing headaches, which became progressive, and then developed memory disturbances. By then, he was studying in the college. Though there was no neurological deficits, no abnormal movements, he had precocious puberty, which was a concern for him. He had developed blurring of vision, and he was unable to continue his education as effectively as before. And these are the two symptoms, like visual blurring and the memory disturbances, which is brought to the attention for the intervention. Next slide. A repeat MRI, next slide please, showed a clear recurrence here, and possibly the original hole got occluded here. So we went in again, and you can see that there is a thick membrane here. The hole which were opened earlier became a very thin hole, and it required a balloon dilatation and enlargement of the opening from the ventriculocystocystonostomy, as well as we used sharp scissors to excise the membrane as much as possible to make the opening as wider as possible. Thus, he became once again asymptomatic. So recurrence, if it is symptomatic, can again be approached with the endoscopy, unless there is any other technical problem, and we can choose other options such as craniotomy or a cystoperitoneal shunt. So you can see the cyst wall being removed as much as possible to make it very larger. You could even take a biopsy here, and the cyst edge has been coagulated to maintain the patency of the cyst. Next slide. So it is important that we have a large opening to achieve the good results. He had continued to have neuroendocrine deficiencies requiring replacements. However, his growth and activities have become normal, and his education he could pursue, and he's doing very well subsequent to the second surgery. So the recurrence is possible in arachnoid cysts in any of the locations, and depending upon the access, depending upon the size and the technical expertise, we can consider endoscopic surgery once again. Concluding, endoscopic surgery for arachnoid cysts is very safe, effective, and minimally invasive. It provides very high success rates with low complications. It can be a first choice of surgical technique for those particularly obstructing the CSF pathway, as well as causing the hydrocephalus. The surgical skill and experience is mandatory before we contemplate on endoscopic surgery for the arachnoid cysts. However, if you review the literature extensively, there is no level 1 evidence of endoscopic surgery benefits in the as far as arachnoid cysts are concerned. The current literature, there is sufficient evidence to say that level 2 evidence that endoscopy is preferred over other surgical options, and endoscopy can be a primary choice wherever possible. Thank you very much for your kind attention.
Thanks, Venkat. Samir, I would like to have your comments.
Thank you, Professor Venkat. This was really an excellent talk. There's no question that the use of endoscopy is the mainstay now, or gold standard for most arachnoid cyst surgery. Interestingly, I recently had a complication related to what you just mentioned, which is when we deal with Galassi type 3 arachnoid cysts and you do endoscopic fenestration, decompression. I did my best to do slow drainage as well as successful multiple fenestrations and communication with the cisterns. And at the end of surgery, I replaced the cavity with good irrigation before closing the dura. And post-operatively, the patient had a contralateral epidural hematoma, actually, on the other side of the cranium. I've seen another case a few years back. So I fully agree with you that when we deal with chronic large arachnoid cyst with mass effect, endoscopic management can look safe and effective during the surgery, but those patients should be monitored carefully, and post-operative imaging is critical. Thank you for the excellent talk.
Thank you, Samir. Nice seeing you.
Good to see you, my friend.
Dr. Fileti, any special advantages in using flexible scope, you think?
Well, it depends on the location, I think. Well, congratulations, Professor, for the nice talk. I really much enjoyed it. I think about flexible endoscopy, of course, some cysts in the quadrigeminal cistern, for example, or in posterior fossa can be fenestrated with a flexible scope. I showed some of these cases in my presentation earlier today. It's interesting what we heard from this lecture, that there is no level one evidence for endoscopy, although in the common sense, in the common feeling nowadays, probably, well, for sure, endoscopy is believed to be the first choice for this kind of pathology. So probably we should think about joining forces for some prospective studies to have this level one evidence. Of course, some locations are more controversial. I remember I published a few years ago, maybe 5 or 6 years ago, fenestration of a posterior fossa cyst in cisterna magna using a flexible scope through a frontal bar hole, so a trans-aqueductal, trans-Magendie foramen fenestration. And my paper was published actually, but with a very long editorial. And in this editorial, initially, this kind of procedure was a bit criticized because of the long way to get there. But in the end, this editorial was very nice because the author said actually every time a new surgical procedure is proposed, at first it's ignored, then maybe it can be ridiculed, but then probably more people will start doing it and realize that probably it's an advancement. So I'm very happy to see that this kind of procedures are done more and more in the world. So thank you very much.
Thank you. I totally agree with you. For all the midline cysts, flexible endoscopy is very, very useful.
Yeah, I think so.
There's another point which I think came into one talk yesterday, and I have also realized in the recurrent case which you showed of the suprasellar cyst. Do you think that taking out more of a dome, which has become possible with laser, etc., do you think that plays a role at all?
I felt it's the membrane that's at the bottom. It's the Lilliquist membrane, and was the one which was created problem in my situation. Whereas the ventricular opening was quite large. Actually, it was sufficient enough to gain access there. One of the reasons why we made a reasonable opening in the lateral ventricular cyst is that we don't know about the third ventricular situation there. So that is why how much third ventricle is compressed is very difficult to identify. So we make a reasonable amount of opening to access. But what I think made the difference here is the Lilliquist membrane, which developed fibrosis and the hole became very narrow. So ideally, even for the primary surgery, at least it should be about 0.5 to 1 centimeter opening wherever possible to have an effective drainage of the CSF from the cyst into the cisterns. So in all the failures, if you look at, a very ineffective opening is one of the main reasons for the failure of the surgery. Similar reason for the cystoventriculostomy as well as the stereotactic aspirations as well. So when you make a reasonably good opening, I think that's a good success rate will follow that. And I think so, that's what I feel.
Samir, one question to you, which has not been addressed during this talk, but is quite well mentioned in literature. Whenever there is a hydrocephalus associated with an arachnoid cyst, apart from suprasellar, where I think it is just obstructive, but there are other arachnoid cysts like posterior fossa or even Sylvian fissure, where you have occasional association with hydrocephalus. And the literature is in favor of doing shunts in these kind of patients, even for the cysts, not only for the hydrocephalus.
So it all depends on the age, Professor. For babies or for young children, let's say under the age of 2, I try to avoid a shunt as much as possible. And I found that addressing the posterior fossa cyst endoscopically and carefully monitoring the ventricular size, head circumference, anterior fontanelle, I had a great success with avoidance of shunts. Older children, on the other hand, I usually start by checking for papilledema. If they don't have papilledema and their symptoms of hydrocephalus are okay, I would go with treating the cyst endoscopically, and sometimes at the same setting, under the same anesthesia. I've done it in a few cases to do ETV. And I found this, is it helpful or not? I don't know, but at least made me feel better. And I can tell you doing the strategy of tandem endoscopic fenestration of the cyst and ETV, I found it to be successful in many cases in saving those kids from a shunt. If they do not have urgent need for treatment like papilledema, and typically they don't have one. I have not placed a shunt in the setting of a cyst-associated hydrocephalus in a very long time. The ETV usually is a good alternative if it's done in a tandem way with the endoscopic cyst fenestration. What is your experience, sir?
Thank you, Samir. There are two controversies in this location. One is when the hydrocephalus is significant. Now, I've also mentioned that ETV is very useful whenever necessary. Now, the question is when to do an ETV. You do first ETV and then deal with the cyst, or deal with the cyst first and then decide when the hydrocephalus continues to be symptomatic, go for an ETV. Now, of late, this controversy has two issues. With the radiological imaging and cysternal imaging, now the consensus is that if the arachnoid cyst is obstructing the CSF pathways and significantly contributing to the development of the hydrocephalus, then deal with the arachnoid cyst directly, and ETV can wait. Now, after dealing with the cyst endoscopically, if you think that it is not going to treat hydrocephalus, you can go ahead for the ETV in the same sitting. So this has been of course, this is a controversy. I think it is at the moment an individual decision, depending upon the location of the cyst, extent of the hydrocephalus, clinical symptoms, and the radiological features. So that's what I would feel at the moment.
One of the reasons why shunt has been talked about in preference to ETV is because just like in very young children, the feeling is that in arachnoid cyst patients also the CSF absorption may be faulty.
I agree.
Yes, that is one of the propositions made, and one of the rapid reduction of symptoms is being reported with shunts. So that is another thing. There is acute symptoms and persistent symptoms. Shunt is always preferable, but it has its own share of complications of the shunt as well as the shunt dependency.
Anyone else from the faculty would like to make a comment on this before we close? Dr. Feleti, Dr. Oyama, Dr. Azmi?
Well, I agree with my colleagues saying that for sure we have to try to avoid shunts if possible. Of course, it's a strategy, but I don't think it's the first choice for these patients. Of course, as you said, Professor, in patients with arachnoid cysts, probably reabsorption might be impaired, but it's probably not always like that, because I have clear memories about patients. I have done a fenestration of cysts, and they did perfectly well. So I think probably it's similar to what we do with patients with obstructive hydrocephalus and ETV. Just give ETV a chance, and then if it fails, if it closes again, maybe redo or place a shunt at a later stage. So similarly, in these cases, I think it's better to give endoscopy always the first chance, and then leave VP shunt later.
I think most of us agree with that strategy.
If I may comment, I've seen a strategy done by some colleagues. I found it actually helpful, is that they do the endoscopic cyst fenestration first. And if there is some component of hydrocephalus, it converts from ventricular hydrocephalus into external hydrocephalus. You see subdural, large hygroma. Then they place a subdural peritoneal shunt temporarily until the brain expands. And after a year or two, they take the shunt out. And I've seen this strategy done by some colleagues, and very successful as well.
That's nice.
Dr. Resha joined us again. You have any comments to make, Dr. Resh?
Yes. Yes.
Please go
Thank
ahead.
you all for our nice presentations. But we have to realize that reality is different, because especially in Germany and Middle Europe, the endoscopy is not the first choice. We have decided in the World Congress 2009 in Athens, in the IFNI Congress, that the endoscopy should be the gold standard, but this did never occur. And why? What is the reason for that? The complex technique? No. The pathophysiology? No. The reason is that our education is not enough. We have not educated and trained enough younger neurosurgeons. And we have still a problem to convince our general colleagues about endoscopy and about the concept of minimal invasive neurosurgery. They view us as a very nice bird, but they do not take us serious. And the reason is because we do not make enough education. And we have to regard that we have to look more to our problems than to our successes. This is very important. It's not so important to show that we are great masters. This is evident, I guess. But we have to show the youngers how we do come to this point being a master. This must be more clear for them. We have to show them also the dangers and how they can overcome the dangers. And when we have to show them to go into anatomy, to train, and to train, and to know about, as I mentioned in my presentation yesterday, we have to do our innovations not only in new surgery, new kind of surgery. Also, we need innovations in training environment. And in education, and even in science theory, we have to do some innovations to come to a point that the general neurosurgery world takes min and endoscopy serious. I'm sorry, but I have to comment this.
No, I think this is a good comment, and this is one of the aims of this kind of a summit which we have had for the last 2 days. I am sure a lot of young neurosurgeons would take tips from this about technique, about possible complications, about multi-corridor surgery, and the expanding indications. I think this is something for them. And I'm sure when we get back to real world, we will probably have more hands-on courses to do the same. Samer has been doing them. We've been doing them, and I'm sure there are several available even in Europe. So I think, I mean, endoscopy has not only arrived, it has already become established. The question is, how do we expand indications without increasing complications is probably in the hands of all of us who have spoken here today and yesterday. With that, I think the scientific session will be closing. Is Professor Kato around to say the final remarks? Is Professor Komatsu here to give the final remarks? I hear Dr. Kato, so please.
Nein, bis jetzt noch nicht. Du sagst, du bist zum Hören, oder? Ja. Dann darfst du nicht so was reden.
Dr. Liu, you have Dr. Kato's address, or is she going to come to talk?
I can play her closing speech.
Please go ahead, and I will make my closing remarks for a minute after that.
So recently in Japan, the pure endoscopic treatment is equal, almost very less invasive the treatment for the patient. So duration of the stay in the hospital, and also some painful feeling of the patient is really reduced with this technology. And also the very high illumination and the enlargement, very precise resolution of the image. It gave us so many information. I think in the future, the more and more this type of the surgery will be increasing for the patients. Hope that you can learn many things the last 2 days seminar. Thank you very much.
Thank you for all experts. We had precious opportunity in the past 2 days. I hope what we learned in this seminar was valuable and beneficial for all attendants. This year, Pure Endoscopic Summit was held for the first time. However, I hope this seminar will be held every year, and we can meet online again in the next year. Thank you.
So thank you, Professor Kato and Dr. Komatsu, for a wonderful organization. We must thank Dr. Liu, who brought all of us together today and made it easy for us to, get together and give our talks. I also would like to thank the technical team and Sachin and other people who have been helpful in running this program. And Dr. Azmi, who has been with us all these 2 days to support the venture. So thanks everyone. Thanks all the speakers. And I hope some of you will probably be in Bogota. I still do not know how things will be in 2 weeks' time, but maybe we will probably meet there. I would also like to tell you that through the WFNS, Ages of WFNS, we would be coming out with a book for guidelines, which would be helpful for young neurosurgeons. And hopefully it should be available over the next 1 week or couple of weeks. And it would be easily accessible to most of you. I can assure you of that. So thank you once again, and goodbye for now.
Bye.
Thank
you.
Thank you. Goodbye.
Goodbye.
Thank you, everyone. Goodbye.
Thank you, Ajmer.
Bye-bye.
Nice to see you.
Nice to see you again.
See you, Samir. Thank you,
See you.
Dr. Mary. Bye-bye.
Great to see you all.
Thank you.
Best regards.
Nice to see you. Thank you very much.